It is my honor and privilege to welcome you all to BW Healthcare World's World Heart Day Conclave 2022. My name is Shivam Tyagi, and I will be taking you through the proceedings of this insightful virtual conclave on the occasion of World Heart Day 2022. Today, we will listen to India's top cardiac doctors and industry leaders who carry the torch of expertise in India's healthcare sector landscape. Today, you will witness the best cardiac health insights, advice, and solutions coming from experienced and specialized doctors and cardiac health experts on how to keep our heart healthy and safe. Cardiovascular diseases are seeing a rise in India, and it is predicted to rise even more in the coming years. In such circumstances, information and awareness hold the key to getting the right diagnosis and treatment at the right time. To start off the proceedings of the World Heart Day, where every heartbeat counts, we have the opening address by Dr. Anurag Batra, Chairman and Editor in Chief, BW Businessworld, and founder, Exchange for Media.
Welcome to this BW Healthcare World Heart Day event. BW Healthcare World has been active in the healthcare domain, bringing all the stakeholders together and making sure we all have better health. We have institutions that prioritize patients over profit, planet over profit. The World Heart Day, as it is celebrated every year, is an important day to remind that the most important organ in our body is our heart. How your heart works is a culmination of how your mind, body, soul are working. So while the medical profession is moving from curing to preventing, on World Heart Day, I want to say that lifestyle changes, dietary changes, pranayam, yoga, good sleep, and more importantly, a life where action, words, and thoughts are in sync is very important. Of course, today's event will have the leading experts, literally India's best experts, who are doctors, who are medical entrepreneurs, who have set up institutions which have made a huge impact, talking to you about how to be healthy and how India is dealing with heart disease. I hope we can have a World Heart Day where we brought down the number of deaths through heart attacks, because the number of people we lose to heart attacks is much more than what we would have lost in a tragedy like Corona. Every life matters. So I wish you luck on this World Heart Day. It is being streamed on bwhealthcareworld.com. So do come to BW Healthcare World and listen from the experts. I wish you great health. I wish you great heart. Thank you.
That was Dr. Anurag Batra, Chairman and Editor in Chief, BW Business World. Now, moving on to the introduction to World Heart Day, and that will be delivered by Mr. Harminder Nirula, CEO, BW Healthcare World and BW Wellbeing World.
Welcome to BW Healthcare World. Today's World Heart Day, and the question arises as to why do we need to celebrate a specific day as the World Heart Day. I think there's a need for all of us to come together to not just create awareness of what needs to be done, but for people to understand the challenge that we are facing, acknowledge it so that then we can take an action and do something about it. India was known for people dying because of infections, communicable diseases. But in the last few decades, we have seen India become a diabetic capital of the world. Diabetes, hypertension, stress, we are seeing more number of deaths happening because of cardiac issues. And if we do not take action right now, we will soon not just remain the diabetic capital of the world, but we may soon become the cardiac capital of the world, or the capital for heart related issues. Nearly 25% of the deaths happening in the country are because of heart issues. We need people to understand the challenge that is there. We have spoken to a lot of cardiologists, and you will watch these sessions that super senior cardiologists of the country, they have one thing that they have to say, that Indians are relatively more predisposed to heart conditions. We typically get heart problems 10 years earlier compared to our counterparts in the West, which is why we do need to focus on driving two things in the minds of our citizens in India. One is acknowledge that there is a problem. Second is we must have the healthcare fraternity to come forward and share their views and knowledge, expertise, training, to let people be aware of what is it that needs to be done to prevent the heart ailments. So these are two things that come to my mind, which make it imperative for us to start celebrating this day with full conviction, to ensure that a change is triggered. People start going in for screening much earlier and a much younger age. People must take precaution and action so that they do not land up with these problems. And that, to me, is the purpose of celebrating the World Heart Day. I must acknowledge every doctor, professional who has taken out time to be with us, to share their knowledge, their views, hoping that they could bring in a change to everyone who's watching this program today. These are all super senior people. And, on behalf of BW Healthcare World and the team, I must thank each of these doctors to take out time to be with us, to share their knowledge with us. There's a lot of effort that has gone in. It takes time. It takes them to put in extra hours because they already had their OPD going on. They had surgeries lined up, and yet whatever free time they got, they chose to spend time with us so that we could all together bring the change. So I hope you find all the sessions super useful and impactful, and I will be happier if few of us take action and bring that change in our own lives so that we can build a healthier, happier India. Thank you.
From the introduction to World Heart Day to addressing the elephant in the room, which is the cardiac care. Now, to give an opening keynote on cardiac care, we have Dr. Devi Prasad Shetty, founder and chairman, Narayana Health.
As a young doctor, I wanted to be a heart surgeon. And those days, I had no choice. I had to go outside the country. I went to England for training in cardiac surgery. When I used to work at the Guy's Hospital in London, my consultants, my teachers, had a busy private practice. And most of their private patients came from India. It is so heartening to see today hardly any Indian goes to England or or US or any other country for a heart treatment, because the quality of heart care available in India is comparable to any other part of the world. And this transformation happened in less than 20 to 30 years. Thanks to the great doctors this country has produced in the past and will produce in the future. I've been practicing in India now for the last 30 years. The first half of my career was spent on reducing the cost of heart surgery. And thanks to the effort of wonderful doctors, administrators, the nurses, and everyone involved in healthcare delivery, largely with the support of the government, we have really managed to reduce the cost of heart surgery. Going forward, reducing the cost of heart surgery can only result in affecting the quality of care. We need to look at alternative, and that alternative is affordable health insurance. Thanks to our government, nearly half the country's population is covered for every problem of the heart, and most of these problems which require surgery is done through the Ayushman Bharat free of cost. Our concern is the remaining 50% and significant number of working class people who are not coming under the BPL category. They need an affordable health insurance. And I am just hoping all the fintech startups and changing policies of the country to help micro health insurance. This will become a reality soon. If that happens, I am confident that India will become the first country in the world to dissociate healthcare from affluence and prove to the world that the wealth of the nation has nothing to do with the quality of healthcare its citizens can enjoy. As part of the celebration of World Heart Day, I have a simple message to all the adult Indians about taking care of your heart. First of all, how you feel, how fit you feel, has nothing to do with how fit your heart is. It is very important for every Indian adult past the age of 35-40, or the ones who want to exert themselves with extreme sports at a much earlier age, to undergo some basic tests. That's routine blood test, a ECG, echocardiogram, and a CT angiogram to find out whether you have any coronary artery anomalies or coronary artery blockages. Once these tests are okay, we can assure you that it's very unlikely you will ever have a cardiac event. The best treatment for heart disease is prevention. If prevention is not possible, at least you can arrest the progression of the disease. And if you can arrest the progression of the disease, it is almost as good as the cure. And today, technology exists to treat you if you have a dreadful heart problem. And there are scientifically proven methods to retard the progression of the disease. Please speak to your cardiologist and they will be able to guide you. Thank you so much.
Cardiac care is indeed very crucial in order to keep our heart healthy and safe. Now, moving on from the overall cardiac care to one specific aspect of it, which is the golden hour. Now, to know more about what is golden hour and how to capitalize on it, we have Dr. R. Kasliwal, Chairman Clinical and Preventive Cardiology, Heart Institute, Medanta, the Medicity, Gurugram. Golden hour is the most crucial hour after a patient has a heart attack, which determines the course of action. It can turn out either good or even bad for the patient. Now, to tell us more on this, we have with us Dr. R. Kasliwal, who is the Chairman of Clinical and Preventive Cardiology, Medanta, the Medicity. Thank you for joining us, Dr. Kasliwal.
Thank
Grateful
you.
to have you
Namaste.
here. So, first of all, I'd like to start by knowing what is golden hour in cardiac arrest and why is it so critical to capitalize on it?
Shivam, thank you. That's a good start. But let me take 2 steps backwards. First is to actually be able to diagnose an acute heart attack. Then only starts the golden hour, and I'll come to that. So it's imperative that we tell the patients, that we tell the people that what are the symptoms of a heart attack, which can be typical, atypical, and non-cardiac. So typical symptoms should be known, like chest pain in the middle of the chest, or as if there is a pressure on the somebody's pressing the chest, sweating, or a feeling that I'm not going to make it. And sometimes a gaseous, many people come to our ER saying that, sir, I thought it was gas. A fair majority come like that. Then sometimes the pain will go up to the jaws or to the teeth, and there is a feeling that something is not good. Those who are diabetic patients may not have these classical symptoms. Women may not have these classical symptoms. So you have to differentiate there that just excessive sweating or fatigue or palpitation may be the first inkling that something is going on, right? So with this background, I will answer your question. What is the golden hour? The golden hour is those 60 minutes in which, if the patient is having an acute heart attack, then we can save the heart muscle from permanent damage. Cardiac muscle can be damaged as if the correct treatment in an acute heart attack does not take place at the right time. That is the golden 60 minutes you get. After that, the heart muscle gets damaged over a period of time. So the golden hour is the time when, if the treatment which you will give is correctly applied, correct diagnosis, correct treatment, then the patient will get maximum good in the long term. Because you're looking at 2 things, that you want to save this person's life then, and you also don't want to make him a cardiac invalid. Both things should start with the patient's symptoms, taking him to a facility in 1 hour and instituting the therapy. That is the value of the golden hour. Shivam.
Right. Getting into the specifics of it, what are the complications that occur during the first few hours? You've already mentioned that, the muscles start dying, but are there any other complications which occur during the first hour or maybe even later?
Yes. 2 deadly complications can take place. One is that the patient may get rhythm disturbances, which can be deadly. And the second thing is that almost 25%, 20 to 25% people will not be able to get up from their chairs and say, look, I'm having a heart attack here. Please do something. That is the value of early recognition of symptoms and recognizing the golden hour. That no, this gentleman did give us some time, but we said, नहीं आप थोड़ा सा पानी पी लीजिए, ये कर लीजिए, आप शायद ठीक हो जाएंगे. So the patient may not be alive. 20% people may not be alive to say that I had a problem. That is the value of the golden hour. Also, rhythm disturbances can take place, and also definitely the patient collapse may take place. So it is imperative that we recognize the symptoms, we recognize that this could be an acute heart attack, and we start instituting proper therapy and taking the person to a proper facility where the golden hour can give him or her the best results.
Right. In the previous question, you talked about gas, right? So,
Yes,
is there a way to differentiate gas between a heart attack? Like a lot of people are getting confused,
yes,
and this is something which is very, very common.
very common. This is very common. I totally agree with you. But see, two or three things are important here. First is, along with that guess, does he have a feeling that this is the first time he's experienced that kind of thing? Is he feeling he's also fatigued, he's sweating, and that he's not feeling up to it? Otherwise, people have gas, they take whatever treatment they take usually, and they go on in life. Also, there are heart attacks in which the lower part of the coronary artery is affected. They may actually come with gas. So the best is to go to a facility, get an ECG done, get biomarkers like troponin done, and sort it, because this may mean the difference between life and death. So that's the importance of saying that this was not gas or this was gas. After all, what will it entail? Going to somebody who will say, "Yeah, you're okay, please go home." That's fine, but not to take a chance. And why we say this is that in a country which has the highest numbers of STEMIs, that means acute ST elevation MI, that means the classical heart attacks, maximum or near maximum in the whole world, why would you take a chance? And 25% of these are anyway below 40 years of age. So it's a deadly combination. So don't take a chance. That's why even though you asked me on a question on the golden hour, I said, first, let us start with symptoms. That is very important. That's something that is occurring to you. Don't try to say, no, I'll be okay. I'll have some water or a cold drink and it'll be fine.
Right.
So
We
gas,
need we need to be vigilant if there are
we need to be
symptoms
vigilant. And
which
this is the power of your medium, that you are getting this across to millions of people, that please don't take these things lightly, because many people will never have a second chance to stand up and say, yeah, do something for me.
right. Getting into the diagnosis of it, the patient arrives in the hospital. How does the diagnosis take place in the golden hour?
Shivam, why are we waiting for the hospital? The diagnosis should be made in the ambulance, because it may take you 1 hour to reach a facility. Then that golden hour is gone. So your diagnosis should be made by the paramedics. They should take an ECG as soon as you hit the bed in the ambulance. He flashes it across to his hospital, and they say, yes, this is acute heart attack. That means the ST segment ECG are getting elevated. The paramedics know exactly what medications to give immediately. That is going to be the lifesaver. That is going to tell the course of the disease. Number two, what's going to happen is that the emergency room understands that the patient being carried in ambulance number so and so has acute heart attack. ECG has been flashed in. They keep the injections ready. They keep the cath lab ready. All these things. So, but if we are truly going to a hospital and it takes us 1 hour to actually reach the hospital, then maybe we've lost time already. But of course, given the fact that if you don't have it in your region, then you will have to go to the hospital. The first thing they will do is to check your oxygen saturation, check your pulse rate, hook you onto the monitor and do an ECG. And then they will tell you what is happening. Of course, they will take blood tests and all that. But
then the SOPs will be decided on the basis of what comes up.
Because many times, Shivam, people ask me that what is the first aid for heart attacks? But there is no first aid. No? Supposing you have given somebody aspirin and he was actually having a dissection of aorta, then you've done permanent damage to this person.
Yeah, this happens a lot as well, and Dr. Google comes in play here a lot. People get paranoid at their homes and they look up for the symptoms and they think it's a heart attack and they start taking pills or doing all sorts of remedies.
Yes.
And it ends up in most cases it ends up being gas or some other discomfort. So
if the golden hour lapses, right, what are the SOPs there? Are there any do's and don'ts for the doctors or for the general people as well? If it lapses during the course of the patient coming to the hospital, what are the SOPs there and in the hospital?
No, obviously the standard operating procedure is even if you have reached whatever time you have reached, if you have reached the hospital and it is a acute heart attack or what I call as STEMI, then they will ask you that look, the best treatment is actually to open the clogged vessel. An artery, there are three arteries of the heart, one of them is blocked 100%, that has caused the heart attack. We can take him to the cath lab and we can open the artery and put a stent so that the blood flow is restored. What the heart does is the heart is a muscle. Heart needs blood supply all the time. Even though you are sleeping on the beach and relaxing, the heart needs oxygen, which it extracts to far larger amounts than anywhere else. So that one artery is blocked, we will take the patient to the cath lab, we will open that artery with a balloon and a wire and then put a stent. That is, you may put it, that is the golden treatment for the golden hour for the heart attack patient, right? But if we are not in a facility which can do a angioplasty right then we can actually give pharmacological agents which will open the artery some so that the heart flow, the blood flow through that clogged artery is restored till we can take you to another facility which can carry it forwards. So,
But the pharmacological elements there work only in the golden hour. After that,
no,
okay.
they will no. This is that they will do best during that hour, up to 90 minutes. They will do best at that hour. Then, of course, heart muscle starts getting damaged. But that doesn't mean we leave the person unsecure and in the wilderness. We say, all right, let's see, still take it to the lab, see what is flowing and what is not flowing, and take it from there. But popularly, it is called golden hour to tell the people that not to just waste that time. Supposing you were close to a facility, then you can reach much earlier than an ambulance coming to pick you up. And the emergency rooms and the heart CCUs are typically open 24/7, so that should not be an issue. Yes, Shiva.
Right. Is there, are there any advice for the caregivers also at home who are there with the patient and for this golden hour, like when they're at home, or how should they go about from there? Are there any advices for the family of the patient as well?
Yes. That again is a very good question because everybody is not going. So those who are at home, and mostly it will occur at the wee hours of the morning, the first thing they should do if the patient says, I'm having acute heart attack, acute chest pains, make him lie down flat. Let him have oxygen. Don't waste his energy by asking too many questions or making them sit and say, okay, you walk and the gas will pass. Do not do all that. Make him just lie down and do two things. Either you phone up for an ambulance, or if there are some constraints there, then with the help of your neighbors, put them in a decent car and just rush to the nearest hospital.
That is flat on the back or on the chest?
No, slightly raised, but the collar should be open so that they can breathe normally. Now, one pertinent question arises here, which maybe you were hesitant to ask, is supposing they got a cardiac arrest during that time, what can the caregivers do? Well, at least in our community at the World Spa, we teach everyone how to do a basic life support. And that people should know that if they have vulnerable patients who are above 60s, who have had high blood pressure or who have diabetes, at least they should learn how to give a good cardiac massage, a CPR as it is called. And then you can, by the time the ambulance arrives. And typically, if you have relatives who are in that age group with multiple risk factors, you should also know the telephone numbers of the facilities around you. So some homework, if it is already there, then you will move faster. And it's not only for the heart attacks. Person may be having a stroke, maybe having a acute intestinal problem, maybe whatever the issues are, at least you will reach a facility well in time without having to do too many things at that point of time. Because typically, many of these things will occur late at night or early in the morning when everyone is asleep, nobody's around you. That's the time when it's going to occur. So in many countries, how basic life support is trained as a training which is given even in schools. And I see no reason we have such bright school teachers and such bright students that we should not do it. We should start at that level.
Right, right. So, how should one, like, okay, we know we have seen the journey of a patient coming to the hospital. Then we the CPR also. You said that it works for not just heart attacks, but other things also. So the
Yeah.
awareness, you believe, needs to go out for
Yeah.
this a lot in younger generation, or where how should the awareness factor be explored more?
Shivam, the biggest thing here is that people believe that heart attacks do not take place before 60 or 65. However, your medium has been so phenomenal in bringing out, but they feel that the few examples that have taken place are like freak or could have happened. But if you look at even Hindustan Times just 3 days back, they said 70% of the world global burden of disease, 74% of deaths are because of cardiovascular, cancer, and diabetes. Diabetes also as a result of cardiovascular. So when the data is so clear, and from our own country in South Asians that this disease occurs a decade or decade and a half earlier than other countries. I mean, one of my DNBs, a student, finished a thesis on heart attacks below 40. And he said, sir, it just took me 6 months. That's about it. And this is just selected one center study. So what I'm saying is the awareness has to be that those who are young should be able to predict and prevent. And those who have passed that time, they should be aware that if something happens, what needs to be done. But this thing has to be done at an early stage. One of the articles recently published said that heart attacks are actually a childhood disease. So people said, how? He said, why? Because atherosclerosis, that means thickening of the arteries, deposition of cholesterol levels, oxidized cholesterol, actually starts during childhood. And then it builds up. It's not a disease which has taken place today. No, the manifestation has come, as you said, Kisar, what do we do in golden hour? But the disease has actually been there for at least 10 to 15 years. Now tell me, how much time have you all got to modify disease during that period of time? Amazing, isn't it? But it is for us to understand, that in our region, it may be more than other parts of the world, though I think it's equal. And secondly, to diagnose early. If you have risk factors like smoking, high cholesterol, diabetes, high blood pressure, sedentary lifestyle, family history, extremely important. All these things will predispose you. So once you have a predisposition, well, go to a doctor and say, look, do I do some relevant tests? Yeah? And tell me if I am already harboring the disease. Everyone will not be, but those who are harboring the disease, then they come online and say, all right, I'm going to control my hypertension. I will never smoke, and I will control my diabetes. And because these are very common in our country. And the consequence ultimately is a stroke or a heart attack or kidney damage.
Right. You talked about that, we have such a big time frame that
Yes.
15 to 20 years, we already know we might be having it. So
Yes.
then comes the preventive cardiology subspecialty, which is coming about now in the hospitals. So I just want to understand your view on the hospitals. How should they treat, the fields like preventive cardiology? Should there be a subspecialty in all hospitals
Well, at least,
around the
well,
lines of prevention?
yes, in our hospital there is, because I chair the Department of Clinical and Preventive Cardiology. I also do a lot of other things like echocardiography, diagnostic angiography, and look after the acute care cardiology and teaching sessions. But yes, there is a chair of clinical and preventive cardiology at Medanta and many other hospitals. And they will then channelize people who will then serve the country at large.
But it's still in the nascent stage in the country at large.
You said it, yes. But
Yeah.
Shivam, I also feel that you all have had a huge responsibility and you have carried out very well the meeting. I think you will also have to step up and come to the fast lane now and say that, look, we could have prevented it, right? And the prevention doesn't come, okay, I must hit the treadmill and I'll be all right. No, first is to detect whether you have the plaque inside or not. What are my risk factors? These are in public domain. 9 risk factors, everybody knows. And today's biggest risk factor, if I may digress for a minute, is actually psychosocial stress. It is the biggest risk factor. Person says, sir, I am not a high blood pressure patient. I am not diabetic. Nobody in my family ever had a stroke or a heart attack. Then why did I have it? Well, because you're glued to the iPad all the time. You don't sleep. You sleep, hardly sleep. And another thing that is coming out now is snoring and sleep apnea. We used to say life simple 7. Say no to extra salt, say no to, and the 8th thing now is sleep disorders, which also increases thickening of the arteries, at least is a trigger. So, what I always feel is that we are not doing this just for saying that, no, I will not have a heart attack, but you will feel fitter otherwise also, no? Supposing you were, and what do we say? 20 to 30 minutes of brisk walk every day, 10 minutes of yoga, and 10 minutes of meditation. That's about not even 1 hour. And this is our Eastern way of thinking, right? It's ingrained into us that this is the way to go. So we do all that, but we also detect, okay, look, did I have the seeds of the disease or I didn't? If I didn't, I will still continue it. If I did, I will do it with more rigor.
Right. You talked about stress and screen time. So correct me if I'm wrong, but there are studies now which project that your screen time also affects on, a lot on your heart, on how you're feeling, and it also adds to the stress level. Does the screen time play out as you rightly mentioned? Would you like to explain more?
No, it's not just the screen time. The question is that it's a stressor, right? And what happens with the screen time is then you're glued to a place, no? You're not moving about. I always tell my people, okay, you have an 8-hour job, you have to sit. Well, okay, but at least when you're going to the restroom, at least take a restroom which is 100 steps away, or go up and down, or do something, and then come back. There is something called NEAT, non-exercise activity thermogenesis, which means that you may be standing while doing the same thing. You can keep while having food, you can be, not walking around, but at least you can be standing. So this is non-exercise activity, which you can do. And see, some people have to do screen time because that's what they do. How can you say you don't? But there are ways in which you can underscore that by coming to hit the desk. You've already done your exercise, yoga and meditation. Then in between you take even if it's called a lunch break, you take a break which actually you just shut off everything and then be ready for the evening.
So constant breaks are advisable if you're having a lot of screen time there.
Yeah.
Right. So just the last question and an advice, perhaps. I've been asking a lot of advices from you. Just the last message that you want to give out on World Heart Day to our viewers, on how to prevent these diseases, or whatever will be your message on the World Heart Day to our viewers.
My message is what our Miss Universe told in the ceremony, predict and prevent rather than repair and repent. Repent and repair. That's what it is. If you look after yourself, then you don't have to think of the golden hour. But if you think of the golden hour, then you are on medication, you've got a stent inside. All these are very good. I mean, they're lifesavers. They're miracles, what cardiology has developed. But then you do have to think about those things. But if you've already predicted and prevented and you're on a nice path, then you may not need the doctors at all, except for every year or 2 yearly checkups, which is anyway mandatory, because atmospheric pollution and all these things, climate changes are also driving people crazy. No? These also should be taken into consideration. So I think we are today on the brink, not on the brink, we have reached a stage in cardiology that we can predict the happening of the disease. I don't think many specialities can claim that. So if it's there, then you can get away with many deadly diseases just by non-intrusive tests. Depends on what you have. It's not just heart attacks. You may be having a cardiomyopathies or rheumatic heart disease or arrhythmias, but there is a control and cure for everything now available as in 2022. So early diagnosis holds the key, is what I feel.
I think that's it holds the key in all diseases, perhaps.
Yes.
On that note, predict and prevent is the mantra which is going to save a lot of lives in the times to come. So on that note, thanks a lot, Dr. R.R. Kasliwal, for joining us here today. And we are very glad that you took out the time to do this. Thank you.
Thank you very much. I really appreciate it. And your questions were really good. Thank you.
Thanks a lot, sir.
Moving now from the golden hour to the field of interventional cardiology, we have Dr. Praveen Chandra, Chairman, Interventional Cardiology, Medanta.
Another aspect of cardiology is interventional cardiology. We have with us Dr. Praveen Chandra, who is the chairperson of the Interventional Cardiology at Medanta. Dr. Chandra is recognized as one of the leaders in angioplasty in India and was awarded the Padma Shri in 2016 by the President of India. So, Dr. Praveen Chandra, thank you so much for joining us at BW Healthcare World. What is interventional cardiology and what are the procedures that usually get covered under interventional cardiology? And maybe if you can explain some of the common procedures.
Okay, sure. Certainly. So thank you very much for this discussion here today. And I'll be very happy to share some new information and new knowledge about the treatment of heart diseases. And as you were already knowing that the treatment of heart disease started with medicines and then bypass surgery, etc. came in. And now it is all being greatly taken over by the field of interventional cardiology, which means without doing any surgery, without doing any cut or any anesthesia, we are able to treat the blockages of the heart. We are able to treat the valves of the heart. We are able to, control the heartbeats, and everything is done through the process of veins and arteries. And there is no need to do any kind of anesthesia, etc. So this is in very precisely the summary of what we do. And basically, the treatment options which are available in interventional cardiology are, one is angioplasty or stenting, which means when there is a patient who comes with a heart attack or a angina or chest pain, we find out if there is a blockage by doing angiography. And if we find a blockage, then we put stents, or ballooning is done these days. Stentless angioplasty is also being done. And then we are able to make them better. The symptoms go away and they are back to their life. That is one. The second thing which we do in interventional cardiology is that we do the treatment of valves. So sometimes when the valves become narrow or they start leaking inside, there are valves in the heart. So they start leaking over a period of time because of the disease process and infection. In these cases, we replace the valve without surgery these days. And these valves are taken through the veins of the body. and no cut or stitch is done. And generally the patients are discharged the very next day. And this treatment is known as transcatheter valve replacement, TAVR. And then the last thing, which we also do is sometimes for prevention of, heart becoming irregular, we put pacemakers, we put, heart regulators, which are known as AICD. All these are, half an hour to 1 hour procedures, generally very safe. And the, in hospitalization is only 2 to 3 days.
So, Dr. Chandra, we know that interventional cardiology, like you just mentioned, is replacing surgeries. But now with the technology development that we hear, that artificial intelligence is coming in and these kind of things, where are we heading as far as interventional cardiology is concerned?
Okay, so let me tell you now. So, and initially, when they were very sick patients, very, serious patients in general sense of understanding. So when these serious patients, it was very difficult to do the angioplasty in these patients. But now we have micro pumps, which are known as Impella pumps. We put inside the heart so that the heart function improves. And then we are able to do angioplasty so that the patient can tolerate the procedure. And once the procedure is done, his heart becomes okay, and we remove the pump. This is known as Impella assisted or MCS assisted angioplasty. So which means now we can treat even sicker patients, more critical patients, more serious patients by these new technologies. Number two, sometimes earlier we used to have blockages which were absolutely hard, cannot be done, and we used to tell the patients we could not put the stent because it was very hard. Now we have the new system of known as shockwave therapy, or it's known as intravascular lithotripsy. In these patients, we put the small microcatheter, break those chunks of calcium and hardness, and then put the balloon or the stents, and we are able to successfully treat these patients who were untreatable earlier.
That's a brilliant development. I mean, but are there still some cases where we say that, we could not put the stent and we need to go through a bypass surgery? Can you explain what are such situations where we need to go in for surgery?
Yeah, so let me tell you, these are very small number of such patients now. And most of the times we are able to treat with angioplasty and these new technologies. However, if the blockages are very long, very diffuse, and multiple sites, then we advise the patients to go for a bypass surgery rather than going for angioplasty as a choice.
I know we have developed and we have evolved to a point where all these interventions are very, very safe. But are there still some challenges that we still face as a hindrance while doing interventional cardio procedures?
Yes. So, we have improved a lot. We have, made so much progress, but certainly, there are still situations where we have to kind of say that, okay, this is much as possible, this is not possible. And certainly there are patients where we have to say that now it is not possible. So that is why I say that bring the patients early in the disease process. Do not delay too much. Many times patients come very late, extremely late. So then the advantage of doing anything becomes absolutely negligible. So that is why it is important that once the heart is completely damaged, we cannot do anything. That is the only place where we are lacking now, that if the heart is completely damaged, then we cannot bring it back. Those cells are dead. So before these cells become dead, we have to take the action. And so early diagnosis, early treatment, early hospitalization makes the difference to these patients.
So this brings me to a very important question. Typically what I've seen and what I've observed, that when a patient is taken to the hospital and there's an angiography which is done. Now the doctor comes out and says that, we need to immediately put in a stent, right? And many times the patient's family is confused. Ki ye itni jaldi kya hai? Why are we getting pushed? So is there a lack of information? Is there a lack of understanding? And can you explain for the benefit of such kind of people so that they understand that it is not because we want to sell something, it is the need of the hour.
Absolutely. This is what I'm telling you, that 90 to 95% times, if advice is being given, generally the patients or the family must try to understand that this is very, very important, and they must agree to what is being said. Because if it is, as I said, if it is not being done in time, it is of no use. And once the heart cell is dead, then you cannot recover it. There is no technology today to make new heart cells, or any medicine which can make new heart cells. So that is why I will suggest that, in those situations where the patient is in the hospital, he's being advised a treatment, I think not too much time should not be wasted on making the decision, and just delaying the process will make the heart even weaker.
Right. So while I was researching for this interview, I came across that you did India's first percutaneous aortic valve implantation without surgery in India. Now, can you share what was this, and what came out of this?
Yeah, so this was very exciting, I can tell you, because up till about, this is, I think, the matter of 2012, about 10 years back now. And 10 years back, there was no treatment which was available for those patients who were having diseased valves and were not able to undergo surgery. So then, we started looking at this, and then some centers around the world started this procedure. And that is the time we also wanted to do this. So in those days, the device was not available. So we had to import the device, take special permission from the drug controller that, this is a very, sick patient. We cannot wait too long. He will die, if he waits for another year or something like that. And then doing anything will be of no, fruits, and he will be, he may not survive. So in those patients, we started doing these valve replacements. And I can tell you, we have gone a long way. Now we do it routinely. This procedure of TAVI or TAVR is now available in India. And the patients now get admitted for only 3 days. Earlier, it used to take so much time. So 3 days, the valve is replaced and he's back to normal. I mean, it's a kind of a amazing, magical procedure, I must say. Yeah.
Right. So coming back to stents, are there different kinds of stents that are there? And can you, for the benefit of our viewers, explain what are the different stents available and what are they used for? What are the different use cases?
Yeah. So basically, there are, various types of stents, but generally they are actually made of metal and they are covered with a medicine. So 99% times or 90% times, we use these metallic stents in various shapes and sizes. And basically they are covered with medicines to prevent a reblockage, and they work very well. However, now, we also have, in some patients, we use biodegradable or absorbable stents, which is like in very young patients or in those situations where, in future we have to do surgery. So in these cases, we use the absorbable stents.
So what are considered as a complex case? Because what I understand and what I hear is that stenting process is a simple process. When I say simple, it is for people who are trained in it, it is a simple process. Now, what are the certain cases where while stenting, there are complexities that you come across? And are there then situations where you need to do, say, a surgery or another kind of a procedure alongside?
Yes. Yeah, absolutely right. So not all cases are simple. Sometimes these are complex cases where the risks are higher. So in these cases, we do take help of more advanced technologies like use of intravascular ultrasound. Or we also use a imaging technique known as OCT. OCT is optical coherence tomography, where we can take micro-millimeter pictures of the heart inside the arteries and precisely know where to put the stent, how big should the stent be, whether the stent or the ballooning has been done properly or not, so that the chance of complication is reduced. That is number one. Number two is we have pressure wires now, where we can check each and every point in artery that whether we need to put a stent or just medicine should be okay. So this is known as FFR. So this technology is, we use in about 20% patients, where we want to make sure that everything is done rightly, and whether the stent is 100% required, or many times we can avoid a stent also, or angioplasty also. So that is about the imaging and the physiological testing of the arteries. Then the second is in these patients where the blood pressure is very low, their lungs are weak, their heart is weak. Then in these patients, as I said, we use the device known as Impella. The Impella is that micro pump. We use that, get the patient okay, do the procedure at the same time, and then he's discharged in 2 to 3 days time. So using these various kind of new devices, and sometimes even we use laser. Laser is something which we also use in angioplasty. So this is known as laser assisted angioplasty, which we do in our center, and not many places actually have these all kind of devices. So in Medanta, we have these every possible thing so that any complicated case should not go unattended or untreated.
So one of the biggest challenges that we face in India is accessibility of treatments and affordability. Now, accessibility is to a very large extent getting sorted, but affordability, even while India is the most affordable healthcare destination, but for people living in India, it is still expensive. So as far as stents are going, or the cardiac treatments are going, what is it that you expect to happen which will make this treatment very, very affordable for the masses?
Okay, so this problem is in every walk of life. What is affordable and what is not, because the cost of things, when newer things come, they are expensive because research comes in and a lot of investments are done by all kind of scientists and researchers, and then in development process. So definitely they are expensive in the beginning, but as you are seeing with stents, earlier they were expensive, now they're not so expensive and now can be used for a large number of patients. So I think, positively thinking, we will have more rationalization of prices once technology becomes more broad-based. Many more companies are making it, and then these patients who are wanting or needing to get this treatment done, then of course many people have the insurance, and many people have support from the government. Government has made some schemes now. This is like Ayushman Bharat scheme or the CGHS scheme. They also support patients' treatment, and so somehow or the other patients are being treated by some ways or the other, and we try to make sure that everybody gets the treatment and is not denied any treatment.
Dr. Chandra, how far have we progressed when it comes to robotic angioplasty? Are we already using it in India, or do you think we are getting geared up to accept this as a procedure of choice in the future?
Robotic angioplasty has actually been there for a while now, and we started in India also 10-12 years back. But the problem is it does not add value to the patient, okay? But it adds cost to the patient. So that is why we are not using it that much. If it was like 2,000 rupees, 5,000 rupees, we will use it in every patient because it's good for us. It protects me. A robotic angioplasty actually protects the doctor because we are away from the radiation. Because with every procedure we do, we get radiated, and that is something which is for life. So that is why it is a professional hazard for the doctors that they are doing this treatment, but there is no, you can't escape that. And having the robotic angioplasty will be absolutely welcome to all patients, but we are not able to use it because it adds, almost doubles the cost of the procedure without adding any incremental benefit to the patient actually. So that is why we are, kind of a little bit, hesitant on doing this, but certainly once the cost comes down, we'll use it more.
What food and what nutrition should be there to maintain a healthy heart? To one, maintain a healthy heart, and second is after you've gone through a procedure like a stenting or a pacemaker or something, what kind of food habits do you need to maintain?
Yeah. So basically, as far as the food and diet is concerned, the most important thing is one should try to eat basic raw natural food like vegetables, like fruits, like nuts, like grains, like these are natural things. And if you start taking the processed foods, what are the processed foods? Like Maggie, like pizzas, like burgers, like fries, like Coca-Cola, and because anything which has added sugar, added salt, or added oil and is stored for consumption after that. Okay, so like chips. What is chips? It's a highly processed food. So you can take it. I mean, I'm not saying that you cannot take it for whole life. You can take it, but if you start taking Coca-Cola every day, like in the lunchtime, or because I've seen many people have developed this habit of having Coke on the dinner table, having Coke during the lunchtime in the office or anywhere. So that's not the best thing to do. And also, drinking juice, those canned juices or Tetra Pak juices, they all contain added sugar. So anything which is like this is not good. Bakery products also should be taken in moderation, like, not every day. Like people have developed habit of having a slice of cake with tea, etc. So all those things have to be really, really controlled. And let me now simplify the whole thing, that for Indian people, the Indian food, the Indian balanced diet is the best diet, which is having a chapati and a rice and a dal and a salad and a yogurt and vegetables. That's all. I mean, there's hardly too much oil in that if you are taking the normal balanced diet, not the shadi food. Okay, so that has to be taken only at occasions, not on an everyday basis. And the intake of oil should be controlled. It doesn't need to be stopped. You can take oil, you can take butter, you can take milk, everything, but everything under moderation.
Is alcohol to be stopped, or is alcohol okay to have?
Alcohol is absolutely okay to have, but especially in northern India, people have developed this habit of taking a drink every night, every evening when they come home. They say, "Oh, I'm very tired, I want to have a drink." That's not right at all. It's not right at all, because they will start with 1 or 2 drinks and then they will start taking more. And then even if they don't take more, even 2 drinks every day is not good. So once in a while, as I said, in moderation, everything is okay. But in excess, any regularity of such things is not good. So make it occasional, make it, at, times when you are really having a good time, but do not have a good time every day.
Sir, I really thank you for taking our time. But before I let you go, can we have a message for our viewers on the World Health Day?
Yes, I'll certainly say that take care of yourself by just making things in moderation. Everything in moderation is good. And that includes lifestyle, which is diet, which is activities, which is like, you're managing your stress and, balancing the work-life balance. Okay. Do not overdo anything. And that is the success to good health, to good heart. And this will keep you healthy over a long period of time. Number 2 is that if somebody has a heart problem, do not try to ignore it. Heart is something which is the engine of the body. So take care of the heart. But whenever anything happens, any rattling is happening, go to the doctor quickly. Do not let it, just pass off, because it can lead to serious consequences. And take the advice of the doctor seriously. Do not, one should not try to suspect, because many times people have now developed this habit of suspecting and stuff like that, which is not good. 90% times, 99% times, no problems. Get the treatment done, you will be fine. Have trust. Have trust is my last, message.
Got it. Sir, I really thank you from the core of my heart for you to take out time for us on the World Heart Day. It has, I'm sure this information is going to be really useful to everyone watching it. Thank you so much, sir.
Thank you.
Now, to tell us all about stents and its sciences, we have Dr. Krishna Reddy Nallamalla, cardiologist and regional director, Access Health International.
One of the most common terms that we hear in cardiology is stent. It is our pleasure to have with us today someone who created the first indigenous stent manufactured in India. We have with us Dr. Krishna Reddy. When we talk about cardiology, one of the most common terms we hear is a stent. Today, it is my pleasure to have with me Dr. Krishna Reddy, who is a cardiologist and the co-founder of the Care Group of Hospitals. He was the principal creator of India's first indigenously created cardiac stent, an affordable cardiac stent for those who could not afford the high-priced imported cardiac stents. He later founded a company focused on manufacturing of these stents and catheters that were affordable but remained high in quality. In 2018, he joined Access Health, a global think tank on health systems. We will talk to him briefly about this as well. But let's begin our conversation on stents. Welcome, Dr. Krishna Reddy. Dr. Reddy, how did this association with Dr. Abdul Kalam happen, and how did it lead you to creating an indigenous stent?
Yeah, it was just a chance meeting with Dr. Kalam when he was the chief of DRDO. One of his colleagues was admitted at Nizam's Institute of Medical Sciences, where we were working. And to treat him, he was actually required to import a drug from Russia that time. And that was the time, I think this was in early 1990s, when cardiac stents started coming from the US, the world literature. That was the first time cardiac stents started appearing in the clinical usage. So during the chance discussion, Dr. Kalam said, we have so many research institutions, public research institutions of repute, the CSR labs, the Department of Biotechnology labs, the Defense Research Labs. Why are we still depending on imports for these basic drugs? That was his question actually. Why we are not self-sufficient in these things, why we are not putting the research labs for that. So that chance conversation led to our exploring, since you are heading the defense labs, and the new cardiac devices, which are life-saving. Can we attempt at working on indigenous technology for some of the cardiac products? So that chance discussion led to formation of Society for Biomedical Technology. That is a grouping of DRDO and CSIR and Nizam's Institute of Medical Sciences. So basically bringing the medical sciences and the technology sciences and industrial sciences into a single platform to work on indigenous technology. So this is the beginning of, this is a typical of Kalam. He worked on missile technology for the same purpose, the indigenous capability. He worked on atomic energy and the nuclear capability for the same purpose of self-reliance. So his principle was, we feel independent only when we are self-reliant.
I think, that has been the mantra of the new government now.
Yeah.
But, coming from somebody who was at that time working with the defense technologies and now talking about creating something in the field of medicine or medical equipment, devices, how did, it feel to start working on creating something which is going to change the way the Indian surgeries are going to happen or the medical is going to progress, and you start working from defense onto humanity? What was your personal experience of getting involved in this particular project?
Yeah, from our upbringing in PGI Chandigarh, one of the focus was the patient-centeredness. How do you take care of a patient? And modern science was rapidly evolving, whether it is heart stroke, thrombolytic therapy, or angioplasties. So the modern medicine as it was evolving, the three things come to mind. I mean, do we have, when the patient requires medical care, do they have access to it? And when they have access to it, do they get the right quality of medicine? And if they get the right quality of medicine, can they afford it? So these were the three things actually drove whatever we did in the last 30 years to work around that, whether it is medical devices or whether it is setting up of hospitals or whether it is participating in policy, research and advocacy.
So,
Central theme is that the driving theme is how can we contribute to these three objectives of medicine?
got it. Dr. Reddy, now you created a Indian manufactured stent. What was the acceptance by the medical professionals of these stents, and has it changed over a period of time?
Yes, I mean, like many other drugs also, because the drugs also we had to go through a process before the Indian community, both doctors community and the patient community, to accept it. When we started exporting as a bulk drugs, and then these companies started re-importing the same drugs to India, then people realized that we have the capacity of producing quality drugs. The stents also went through the similar cycle actually. See, one is as a clinicians, we need evidence that it is safe and it is effective. And given our constraints about financing a good clinical study and a robust clinical study, a multi-centric clinical study of the numbers that are required for a scientific evidence, naturally there will be constraints to accept it until there is enough use case as well as enough data that is produced by the stents. So we don't fault, I mean, these are some of the cultural baggages of so-called imported is always good, indigenous is bad. That colonial mindset that we have to get out of it. And the second, of course, is a scientific evidence that has to be generated for the clinicians to be convinced. So these are the two factors, took some time for the indigenous manufactured stents to be accepted. But when we started reproducing the same quality and putting the same quality manufacturing standards in the production, and when we were accepted on quality basis by the Western world for bulk manufacturing, then when they started coming back to India as a branded stents, then the usage also started increasing, because for most of the public health insurance funded schemes like Arogyashri or CGHS or PMJ, where it is a capped reimbursement system. It is not the price reimbursement system. So you give a package including a stent. That means like Arogyashri has a 60,000 package, which includes stent. So the hospitals are constrained to go for low cost, the affordable stents to meet this requirement. But when they started using these stents for that category of patients, side by side their experience with imported FDA approved stents, they noticed that the outcomes are similar. So that is boosted the confidence that yes, these stents can be used. And to the extent that slowly what was less than say 5% of the market for the usage, today I think almost 80% of the stents used in the country are indigenous stents. So it is a good turnaround. It is a good turnaround in building the trust and the confidence in the Indian manufactured stent quality and the cost.
No, absolutely. I mean, I think it's a good welcome change that has happened. And while I keep saying that while we are looking at India being on the forefront of IT when it is globally seen, I think it's time that we are known for our healthcare as well. Because we are proud of the best doctors, of having the best doctors in our country. I think it's time that we focus on healthcare services and equipment as well.
Right.
So I think it's a brilliant change. Now, Dr. Reddy, how do you think, Or what do you think is the role of the government in, kind of promoting the public-private partnership in healthcare? And how can it change the landscape of healthcare for our nation and the stature of our nation in the global healthcare industry?
Yeah, so healthcare today is so complex and advanced. The government alone will not be able to provide the needed services. So that is when actually the private sector evolved to meet that unmet needs of the people's health needs. So given the fact that there is a mixed system, that means there is a government provider system, public hospitals, public clinics, rural health centers, and there is also advanced care in terms of the private healthcare. Because the public system may not be able to meet the growing aspirations of the people, because people are experiencing a different standards, different quality, and different experience. So their expectations are not being met by the public system. But at the same time, some of the elements which only the government can do, for example, the social determinants of health, whether it is education, whether it is housing, whether it is clean drinking water, whether it is pollution, the cleanliness, these are the things which the government can do, and government is investing into that. In fact, the social determinants account for 60% to 70% of longevity. The healthcare provision actually accounts only for 30% of longevity. So that is where the government has a role. Secondly, the preventive care in terms of the vaccine, preventable diseases, in terms of population screening, like what the government is doing for 30 years plus, just checking the blood pressure and blood sugar. It goes a long way in preventing the future non-communicable diseases. So these are the areas where the government is capable of doing, because the private sector is not interested in these areas because they do not make business sense. Of course, the wellness industry is growing, but private sector will tend to focus more on hospital-based tertiary care and high quality care, or at least the 5-star type of infrastructural care. So each one is meeting certain objectives of the healthcare system. Similarly, the government, based on its tax realizations, at least it can pay for the poor patients' healthcare needs, which it is unable to provide for. I mean, that is where the public health insurance is coming. Because it is easier for the government to mobilize resources, financial resources, and then purchase from a private provider if required. That means wherever it can source services from the private provider, where the public is not able to provide, what we call selective purchasing. In fact, it should not purchase everything. If it is providing primary health care, if it is providing preventive health care, and if it is providing free medical education and the teaching hospital-based care like All India Institute of Medical Sciences in every state, that the government should continue to strengthen it.
Got it.
It should partner in technology development, for example, on the health goods, health devices, health vaccines. The private sector is well placed to manufacture them. But at the same time, there is a partnership because the government has an excellent R&D network, like we have seen during the vaccine development. The partnership between the National Institute of Virology, ICMR, and the Bharat Biotech resulted in an indigenous vaccine in 1 year time. So that is a clear-cut example of how public-private partnership works. Similarly, when the government is paying and the private providers are providing, but there has to be a mutual trust, there has to be a rational package design, and there should be a joint shared purpose. I mean, are they working towards the population health? Suppose if the private sector primary objective is maximizing the returns on the shareholders' money, it may not be aligned with the public health requirement.
Got it.
So there is a need for, I think, both the sectors, both public and the private sectors, if they join together and work towards the shared objective of population health, there is enough business for everybody.
Got it.
It is only a shared purpose. I mean, nobody denies that the shareholders' money has to be multiplied, but there has to be a rationality as to how much returns is reasonable.
Got it.
There is a limit to greed versus need, right?
Yes. Yeah, I completely agree with that. I mean, it is about making profit because as a private organization, you must do that. But profiteering from this is not something which is...
Yeah, that is where the ESG principles are coming up globally.
Correct.
So you have to care for the environment, you have to care for the society. At the same time, you have to make money by growing.
Correct. Correct.
So nowadays, that is a global architecture, that it is not just, this is called triple bottom line.
Right.
It's not just the profit alone, but every industry should be aware of their social responsibility and environmental responsibility.
Yeah, you're absolutely right. I mean, the companies have to, if I would use the term, behave responsibly while they're operating.
Yeah.
So, Dr. Reddy, since we know that you are a cardiologist yourself, you have created an indigenous stunt with a very purposeful manner, and we can see the impact when you say that today around 80% of these stents being used in the Indian healthcare system are manufactured in the country. So we know the impact that you have created. Now, what I want to, since it's the World Heart Day, I want to use your knowledge and expertise for the benefit of our viewers to understand the role of stent. So what exactly is the role of stent in the heart care? And also, how has that evolved over the last few decades? We know it has become affordable, but in terms of quality and in terms of the impact that it is creating, if you could shed some light on this, please.
Yeah, so we have to look into the overall comprehensive component of cardiovascular disease. That means the disease of atherosclerosis, the lipid deposits that happen in the blood vessels, leading to the blockages, leading to the heart strokes or the brain strokes, or the blockages in the blood vessels supplying the limbs, leading to amputations. So the underlying etiology is same, whether it is a heart stroke or angina, chest pain angina, or whether it's a brain stroke, or pain in the legs and walking because of the blood vessel blockages in the legs. So the disease is same. The preventive modalities are same: controlling hypertension, controlling diabetes, avoiding smoking, controlling blood cholesterol. And the treatment is dominantly medical. Most of the cardiovascular disease, majority of the patients, I would say 90 to 95% of the patients with cardiovascular disease due to atherosclerosis can be optimally managed by the drugs. Where there are blockages which with medical management alone, the risk continues to be there. So there is what we call it as a risk assessment, because not all blockages carry the same risk. Suppose a blockage involving a blood vessel which supplies say 50% of the heart has a different risk compared to a blood vessel which supplies only 5% of the heart. So that is where what we call it as a risk assessment. And based on the risk, suppose the risk assessment wise, it falls into criteria of high risk category, which we assess by stress testing and angiography. I mean, these are the two tests which will give us information. What is the risk of the patient? And based on the risk assessment, then we will define whether patient requires only medical management or patient requires some intervention, whether it's surgical intervention or non-surgical percutaneous angioplasty and stenting intervention. So this is the general approach for patients with stable angina or stable coronary artery disease. That means it is not during an acute heart attack, but during a stable state. This is the approach we adopt. That means those falling into high risk or those continuing symptoms despite optimal therapy. That is where we advocate revascularization. And one of the modality of revascularization is opening the artery blockages or bypassing the blockages. In surgery, we bypass the blockage. In stenting, we open the artery. So this is, if I say about 100 patients, if they have evidence of blockages, about 10 to 15% will require stenting, and about 10% require surgery. So the balance 60 to 75%, if you go by evidence-based medical therapy, require just optimal medical management. So if you say only optimal medical indication, this is the distribution.
Got it.
If you say business indication, then we do more angioplasties. So there are two indications. There is a business indication and there is a medical indication. So people are becoming aware of these dual indications. And that's why they go around trusted people where they give only medical indication.
Got it. So
the second, I will complete the most important thing where stenting actually saves lives is when patients present with acute heart strokes. That there it is not question of where is the blockage, how much is the muscle involved. There it is how soon you can open the artery. And the best way of opening, because surgery takes a lot of time, the shortest time in which you can open the artery is by stenting. Because in an acute heart stroke, the time is muscle. With each minute of passing after occlusion, if you don't open it, you are losing muscles, heart muscles permanently. So this is one subset where stenting saves lives and there is no controversy in usage of stenting. In fact, not using angioplasty and stenting in acute heart stroke nowadays is not considered as the correct practice.
So, you brought up two things. So you brought up one, the need for stenting, and you also brought up the medical as well as the business aspect. Now, there is the healthcare system is plagued with distrust and suspicion. And so many times when the patient is taken to the hospital because of an incident, and when they do an angiography and the doctor comes out and says that, we need to put in a stent, so they need an approval. The first, thought that comes into the attendant's mind is it really required, or are they taking advantage of us being in a situation? So what I understand is that it could be an immediate requirement to safeguard the muscle, which is going to impact the heart health for the future. Now, how do we change the perception of these people on their trust onto the doctors? What is it that we are doing to educate these people that this is a genuine requirement and it is not because we want to make money?
Yes, so it's an important thing. In fact, the trust deficit is a very important thing in how patients behave. Even the vaccine hesitancy is because of the trust deficit. Right? So one is creating this clear awareness among the people that where it is must and there is not much time for us to explain. That means you have to take a decision as soon as possible. So that is during an acute heart stroke. That awareness has to be created among the public that when somebody is suggesting angioplasty and stenting for a patient with acute chest pain and a heart stroke, they should not hesitate. They should not have any doubt whether doctor is telling right or wrong. But when the patient present to a cardiologist with a stable chest pain, that means they get only on walking, it is not happening at rest, it is not acute chest pain, or it was just detected on a routine stress testing, because nowadays the master health checkups happen and suddenly a treadmill report comes as positive, and suddenly when it is positive, people advise angiogram. And when they go angiogram, so when they go to a cardiologist with a stable condition, stable chest pain or stable symptoms, even if cardiologists say that you require urgently, they can re-emphasize and seek a second opinion. That is from a patient perspective and creating awareness perspective. But more importantly, the education standards at a cardiac. So whatever the professionalism in terms of the medical ethics should be inculcated in medical schools and medical colleges, because that is where the ethics will start actually. Then the third thing is there is an opportunity for the payer system, because now the insurance is accounting for 60 to 70% of payer systems. And they should exercise their lever to ensure that the patients are getting right care. That means there is a right indication for these procedures, and they have the power to control that by pre-authorizing in a rightful way or doing a proper medical audit, whether there is an overusage of certain procedures, and then bringing it to the notice of the hospital management and the cardiologist that this is the expert opinion that these procedures may not be required. So it has to be through a scientific medical audit by experts done, experts of integrity and renown. So there is a way to actually ensure quality. In fact, it's the responsibility of the payers, what we call strategic purchasing, like whether it's a PMJ or even a private insurance. It is claims processing is only one aspect of health insurance. What is the more fundamental thing is, are you ensuring that your beneficiaries, the policy holders, are they getting safe and effective care? Right. So it's not enough just to say that we have covered you.
Got it.
That is part of just a small part of health insurance.
Yeah, I think insurance sector is one area where I think we need to realign ourselves, because it is more inclined towards for example, I heard a doctor mention that the insurance system in India currently is focusing on you getting admitted. So they're actually forcing you to start spending money, whereas they should be focusing on preventive healthcare so that lesser number of people actually need to go to a hospital, so that there are no claims.
There is a slow shift in the insurance industry as well. In fact, in the West, it has already happened. What we call population health management.
Right.
So they have a entire data, right? So suppose they have patients with diabetes with policies. So they have access to monitoring how well is the diabetes controlled.
Correct.
If it's not controlled, they send alerts that your diabetes is not controlled. You have to visit your physician.
Right.
So by focusing on this preventive care and better controls in the outpatient setting, they actually prevent hospitalizations.
Got it.
So if you prevent hospitalizations, you reduce claims.
Yes.
So that means the claims ratio gets optimized.
So Dr. Reddy, are there different kinds of stents which are available, or there is only one standard kind of a stent which is there?
No, there are broadly two types of stents are there: bare metal stents and the drug-eluting stents. Bare metal stents currently are used in very, very exceptional cases where we may be required to stop the blood thinning agents for a major procedure. For example, somebody requires a non-cardiac surgery, but pre-operatively he needed to undergo stenting to reduce the risk during a non-cardiac surgery. Suppose if you have to give drug-eluting stent, you cannot stop the blood thinning agents, which might increase the risk of bleeding for the surgery. So these are some of the exceptional cases, but worldwide, the industry has virtually shifted to the drug-eluting stent. Of course, within the drug-eluting stent, then there are some subtle variations in the drug that is used, the polymer base in which the drug is used, and the stent characteristic. Is it a thin strut stent or a thick strut stent? So these are the minor variations which are there in the drug-eluting stent, but broadly, there is no significant difference within the drug-eluting stent category, except some minor variations where we use in select cases a specific drug-eluting stent.
So, Doctor,
there was an attempt at bioabsorbable drug-eluting stent. That means there is no metal actually; it is a absorbable polymer which acts like a scaffold. There is no metal.
Okay.
So over a period of time, it gets absorbed. But in the clinical trials, it did not stand up to its expectation. And in fact, there was a adverse events. So
Okay.
it has been withdrawn from the market, but there is a continuing research to improve. But in my own assessment, I think we have reached that plateau stage of the development. I think it is only, I mean, if we can develop stents as a vehicle to deliver drugs in targeted areas.
Okay.
Those are the applications that might happen. For example, a blood vessel which feeds a cancer. Suppose you want to deliver the drugs only at that site. So that might be a new application of the stent technology, because stents are now being applied for the acute stroke, brain stroke. They are being applied to improve the leg circulation. So their applications are expanding, but technology per se, I think it has matured enough.
Got it. Got it. So, Dr. Reddy, what is the usual cost of a stent in India when it is for the heart? And how do you think that the government should be taking initiative to make it even more affordable for the weaker section of the society or the rural India where the affordability is still a challenge?
Yeah, so I mean, the government has brought in the price regulation on the stents, right? So they fixed the stent price at 30,000, irrespective of which make or which brand or which approval. So earlier, I mean, hospitals which were procuring the stents at 30,000, they were pricing at 1.5 lakhs. So at least there is a price cap on the stents. But did it translate into the actual benefit to the patient? Because there is no price cap on the hospital services and the procedure services. So the hospitals only shifted whatever the margin they lost on the stent pricing onto other bills, other services. So the net effect is that the patients did not get the benefit.
So what do you think needs to happen, sir? So, this is going back to my earlier question that if the hospital is taking advantage of you.
Yeah, so the only recourse is, because as I said, the insurance, the payer system is getting consolidated. And they have a better bargaining power in terms of the package pricing. For example, as I mentioned, Arogyasri or PMJ, they have a stent inclusive packages. So that means the price capping package system, which CGHS is the pioneer. So that itself has a controlling mechanism on the pricing, because naturally, once you have the financial protection to the beneficiaries, so you have already taken care of affordability issue of the patients, the poor patients. For example, the PMJ covers virtually 100 million families or 500 million people. ESI covers 130 million people. CGHS covers another 15 million people. So it is only the missing middle, that means informal labor, the lower middle class, because upper middle class anyway, they will get private insurance. The employees, they have either ESI or group health insurance by the employers. So it is only the informal labor, I think the government is seriously considering how to bring them onto the platform. So a lot of policy dialogue is happening. What is the best method of bringing this informal labor? Because if you look at, I think there is a STRUMP portal where now informal labor is encouraged to actually get registered, so that they get certain life insurance benefits and other benefits. So that is one mechanism of formalizing informal labor. Right. And the digital economy is also formalizing informal labor.
Got it. So, Dr. Reddy, I remember in the initial part of our conversation, you mentioned that in India, we now have acceptability of the India-made stents because the world started ordering bulk manufacturing from India. What is the acceptance of an Indian-made stent globally?
Yeah, there are two methods are there. I mean, one is as a OEM. That means they get bulk manufacturing done in India and then export. The second is now the Indian manufacturers selling their own brands in foreign countries after going through their regulatory processes. So there is a growing acceptance. In fact, for example, our own company exports to virtually 25 countries. And it also supplies bulk stents to Western countries, including a country like France. So there is an acceptance at a quality level, both as a bulk manufacturer, as well as the brands are also getting accepted, like Latin American countries, Southeast Asia, South Asia countries, even gradually there is now acceptance even in the Middle East, because Middle East used to go for the Western products or the FDA approved products. But given the COVID and a lot of geopolitical issues and the supply chain disruptions, a lot of countries are trying to go for a dispersed sourcing. So there is a growing acceptance of the Indian products. And as I mentioned, ultimately it is the experience with the product that gains the trust and the confidence. So as people start using more and more Indian products, naturally there is a more and more acceptance and confidence on the Indian products. So yeah, I would say the brand India is gaining credibility among the Western markets as well.
So, Dr. Reddy, is there a life to this stent?
No, once deployed, it is for life. But there is a chance of re-narrowing because of the healing process. Because when we deploy the stent, we are actually causing injury to the blood vessel. I mean, we deploy it at a pressure of cortile, right? So that naturally induces certain injury to the cells in the blood vessels. So as a reparative process for this injury, some blood vessels heal up much more than required. I mean, in fact, the drug-eluting stents came to prevent this re-narrowing because of the over-exuberant repair process. So because most of the drugs that we use are basically used as a cancer medicines. They prevent cell proliferation. And that is the basis for re-narrowing. But because we cannot give in a oral form or IV form, for the doses to be not toxic to the other organs like cancer medicines, we release it locally, coated over the stent.
Okay.
So these are the cancer medicines which are preventing re-narrowing.
Okay.
But despite these things, we do still see anywhere from 5 to 10%. They can develop blockages in the stents.
Got it. Got it. So, are there any myths that you have in your practice heard about stents that need to be demystified?
One myth is that stent is a cure. It is not a cure. Like surgery is not a cure. In coronary artery disease, they only reduce the risk or they relieve the pain, but they are not cure. I mean, because it's a biological disease. So either drugs or the stents or the surgery, they reduce. So we always look at what is the risk versus benefit, what is the cost versus benefit. So that is one myth, that the stent is the second myth. I won't say second myth, but the mistake people do, especially drug-eluting stents, is inadvertently when they're asked to stop the blood thinning tablets for some other procedure, like dental procedure. So sometimes if the dental surgeon is not informed about the stent, or dental surgeon is not aware that the blood thinning agent should not be stopped, like aspirin, clopidogrel, ticagrelor. So by inadvertently, if they stop, or patients forget to take these drugs, there is a risk of these stents getting suddenly clotted and causing death. So it is not a myth, but it is an important caution every patient receiving a drug-eluting stent should remember.
Got it.
And every surgeon treating a drug-eluting stent patient should remember that they should not insist on stopping all the blood thinning tablets.
So, Dr. Reddy, this actually brings me to our next very important question, that what is the precautions that a patient must be asked to follow after they have gone through stenting?
Yeah, so one, as I mentioned, is these blood thinning tablets, because the drug-eluting, the same drug which prevents the cells, abnormal cells, it also prevents the healthy lining endothelium. Normally, the metal should be covered by endothelium. Because it is a drug-eluting stents, there may not be complete endothelialization. That means the stent is partially exposed to the circulating blood. So this will insist that the blood thinning tablet should be forever. They should not be stopped even for 3-4 days. So that is one precaution in terms of preventing any clots over the stents, acute clots. The second is we prescribe everybody statins to maintain the bad LDL cholesterol less than 70 milligrams per deciliter. This is to prevent progression of disease in unstented blood vessels. Okay. So these are the two critical preventive steps post-stenting. Then other drugs depends upon, of course, if heart is already damaged, there are some drugs which have to be taken lifelong, like beta blockers, ACE inhibitors. So that is only for patients who have damaged hearts. Yeah, so there are, so medical treatment continues to be of prime importance, even after stenting, to prevent future cardiovascular events.
So, Dr. Reddy, you just mentioned that in case you've got a stent and you are taking the blood thinners, you should not be stopping it even for 3 or 4 days, despite you having, say a dental problem or what. So what does a patient do at that point in time if the dentist is telling them to reduce the blood thinning?
Normally, we caution them. As a cardiologist, we caution them that if anybody wants you to stop these drugs, please immediately contact us. Then we can talk to the dental surgeon why they should not stop it. And nowadays, that awareness has increased. In the beginning, we used to have tremendous problem, but that awareness has increased now. Even high-risk surgeries for bleeding, they accept with aspirin continuing.
Okay.
Like even eye surgeons, like for the cataract surgery, now they don't insist because they have improved their own techniques where you don't have to stop aspirin.
Got it. So, Dr. Reddy, we've spoken about stent. We've spoken about your contribution to the Indian industry when it comes to stenting, the locally produced manufactured stents. You recently, or not recently, a couple of years ago, joined Access Health. Can you tell us a little bit about what Access Health does and what is the impact it is creating in the industry?
Yeah, maybe in layman's terms, see, as a doctor, I diagnose a patient's problem and I plan the treatment, and sometimes I do surgery. At a health system level, in Access Health, what we do is we diagnose the system level problems. And then we offer treatment, means offer solutions and suggestions that these solutions might improve the problem. For example, if 60% of people are paying out-of-pocket expenses to meet their health requirements, and a lot of them may be subjected to impoverishment because of the health expenses, what we call catastrophic health expenses. But the government is constrained by their fiscal space to fund this, right? To protect these people through a public insurance. So we study what other countries did in this situation. Other maybe low to middle income countries, what methods they have adopted. So we have kind of a set of solutions for the policymaker to consider, right? Similarly, when there is a implementation of a policy, for example, the Digital Health Mission is a policy, major policy, country level policy. Ayushman Bharat, PMJ is a country level policy, or health and wellness clinics implementation is a country level policy. Or with the COVID pandemic, building resilience through a robust surveillance system is a national policy. So while policies are taken, sometimes there may not be capacity in implementing these policies. Okay, so that means the administrative or the management capacity or the technical capacities may be lacking. So that is where we provide the technical support and implementation support. I mean, as I mentioned, one is prescribing the drugs, second is doing the procedure like stenting and surgery. So when we do the hand-holding and technical support, that is called as surgery. Right? Sometimes we may actually generate evidence to inform policy making. Okay, because you can take policy making on a gut feeling or a ad hoc methods or a populism purpose. But increasingly, just like in medicine, we have what is called as evidence-based medical practice. In policy, public policy, increasingly every country is putting in place evidence-informed policy making. That means there should be a scientific evidence on which basis we have taken this decision. Okay. So this is I think in simple terms, I would say what Access Health does is it is the doctor of health systems.
Got it. So I think this is brilliant, because I think especially post COVID, there have been new schemes that have been brought in healthcare. There is more awareness among patients. There's an acceptance of technology both at the provider end as well as the care seeker end. So I think there is a lot that needs to be done, and I'm sure that what you're doing at Access Health is going to create a very important impact on the industry. But Dr. Reddy, before I let you go, I would request you to please share a message for the World Health Day, both for the care seekers as well as the care providers.
Yeah, see, if all of us desire that we have to be healthy, we have to be wealthy, right? If that desire is there, then everybody is equally responsible. People are equally responsible. The government is equally responsible, because governments are elected by people to take care of them. Then the private sector is equally responsible, because they have a responsibility to their customers. So this is, I think, that responsibility, that everybody has a responsibility for health for all aspiration. Then I think we have no problem. Only when we don't take the responsibility and when we are not accountable, like even as a patient, just healthy diet and a physical fitness to prevent my future heart stroke. If I'm not responsible, why should I blame the government for not taking care of my health? So my message is simple. I mean, all these three actors of health systems, the public sector, the private sector, and the people, all three are equally responsible in terms of achieving the desired health of the people.
Well, Dr. Reddy, on that note, I must thank you for taking out time to be with us on this very special day. There are lots of questions that I still have for you, but I'll reserve it for our next conversation, when it's going to be about the treatment of the healthcare industry. But really appreciate your taking out time to be with us. Thank you so much, sir.
Thanks again. I enjoyed the conversation.
Thank you, sir.
Next, we have a conversation on pacemaker, heart rhythm, and pediatric cardiology. And to decipher this for us, we have Dr. Vanita Arora, Senior Consultant Cardiac Electrophysiologist and Interventional Cardiologist, Indraprastha Apollo Hospital, New Delhi.
On the World Heart Day, we cannot ignore electrophysiology, the need to correct the rhythm of your heart. To discuss this, we have Dr. Vanita Arora, who is the Senior Consultant Cardiac Electrophysiologist and Interventional Cardiologist at Apollo Hospitals, New Delhi. In simple words, she is someone who deals with the heartbeat. When the heart starts beating fast or slows down, we need help of devices that control and optimize the pace of our heart beating. Dr. Vanita Arora is known for her expertise in the field of cardiac pacing and electrophysiology, including RF ablation of complex arrhythmias, ICD implantation, biventricular, as well as leadless pacemaker. Welcome to BW Healthcare World on the World Heart Day, Dr. Vinita Arora. So, Dr. Vinita, let me begin with a very basic question. What is a heart failure and what causes heart failure?
Thank you, Mr. Narula. That's a very important question. So people don't understand about heart failure. Whenever a person dies, they think he's died of heart failure. But heart failure is a syndrome complex. It's a syndrome. It's not single thing. It is multiple things which are associated with heart failure. So the most important cause of heart failure in our country is actually coronary artery disease. We are the diabetes capital of the world. And diabetes is the most important causative factor for coronary artery disease or blockages in the arteries as we understand it. And because of the blockages, there occurs heart attack. Once the heart attack occurs, the heart muscle is dead. Okay, so to save that heart muscle, you have to get either a clotting therapy done or an angioplasty done or a surgery done in time, actually when it is required, so that you can preserve the muscle. That is why you must have heard people insist on doing a angioplasty immediately as soon as the heart attack occurs, because they want to make that vessel to flow so that the muscle doesn't die. It is what we say is time is muscle, muscle is time. That means if you are able to save the muscle and time, you will not go into heart failure. People don't understand this, so they just keep thinking and har ek ko stent dal dete hain or har ek ki angioplasty kar dete hain. I mean, it's a very wrong thinking which we have. We are trying to save the muscle, because if the muscle is saved, you will have your heart function maintained at a normal of 60%. 55 to 60% is the normal heart function, which is measured by echo. So if it drops below 35%, the person today or tomorrow will definitely go into heart failure, which means there will be a cascade of things which will start. You will start feeling breathless, the energy loss will be there, getting out of absolutely feeling listless and fatigue by evening, that will be there. There will be facial or pedal edema. You will start retaining fluid, and it will be like just imagine a donkey who is pulling a cart loaded with sacks full of material. You know, how will he feel? He will feel listless, sweaty, all out of energy. So that is how our heart feels. You know, the donkey analogy is the best analogy I've ever seen being given for heart failure. So if you have heart function less than 35%, you will for today or tomorrow land into heart failure. Then there is another aspect of heart failure, which is heart failure with preserved ejection fraction. That means your heart function is normal. Your contraction of the heart is normal, but you are still going into heart failure. Now, this happens in patients who have either uncontrolled blood pressure, uncontrolled diabetes, because of which the heart has actually become very stiff. It has become so stiff that it has forgotten to relax. Let me make you understand here that when the heart is contracting, 24/7 it contracts and relaxes. It beats like this, right? So it 24/7 till you are born out of the womb of your mother till you die. Your heart keeps on working. So doesn't it get fatigued? No, it doesn't get fatigued, because when it is contracting, it is working. When it is, diastole, the contraction is the systole, relaxation is the diastole. When it is, that is the time when it relaxes. So if you do something to that relaxation, you don't let the heart to relax, the heart will go into failure with preserved ejection fraction also. That is the relaxation abnormality that occurs with the heart. So that is why it lands up into failure. These are the two important causes of heart failure. Then there are other causes like, genetic causes like cardiomyopathies. You can have a viral infection of the heart, which may affect the muscle, which is known as dilated cardiomyopathy. Then you may have something like genetic abnormalities like ARVD, hypertrophic obstructive cardiomyopathy. So these all are another, different causes of heart failure.
Got it. But Dr. Vinita, what happens is that this is when the person actually lands up at the hospital. That is when the angiography is done, and that is when you realize that you need to protect the muscles and you want to put the stent or a pacemaker or whatever. But most of the people who land up in this situation, this is the first time that they're facing a heart problem, But how do they even know that they are undergoing a heart issue at that point in time? What are the symptoms that one must keep in mind and immediately consult a doctor or reach a hospital without wasting time?
So if a person has had a heart disease in the past, you have to keep a check on your ejection fraction by doing an echo regularly, right? Now, suppose it is the first time you are having problem, then you have to look for symptoms. Breathlessness is very common. Getting out of breath in the activity you were doing it about a week ago. Suppose you say, I can climb the flight of stairs, 2 flight of stairs I can climb without any problem till about a week back. But today you are not able to do it. Today, with 1 flight of stairs, you start feeling that something heavy is on the chest, or you're feeling out of breath. You have to pant for air, right? So these are this is a very important symptoms, right? That you are not able to do the activity which you were able to do about a week or 2 weeks ago, right? Your functional capacity goes on decreasing, and you are having breathlessness. You're panting for air while doing the normal activities. Secondly, you start feeling absolutely fatigued or worn out. You start sweating a lot while exercising or while walking. When you're getting out of breath, you sweat also a lot. Your urine output goes down. Keep a check on that. Your urine output starts to go down. Then you start having pedal edema. Your feet are swollen up. Your body is suddenly swollen up. Your face, when you get up in the morning, is all swollen up. So these are some symptoms which you have to watch. Your weight starts to go up, right? Without your eating much, but your fluid intake is retained in the body, and that fluid is making you increase the weight.
So Dr. Vanita, some of the symptoms that you mentioned are very similar to the symptoms when someone undergoes anxiety, right? And especially after COVID, there is a lot of conversation around mental well-being, etc., and people going into anxiety because of whatever fears may be related to profession or personal life. Now, how does one differentiate between the symptoms appearing because of anxiety versus the symptoms that could be related to a heart problem?
Okay, now, Mr. Narula, yahan pe, we have to let the doctors do their work also. I think the differentiation should be with the doctors rather than the patient. It is better to be overcautious. If you are seeing any of these symptoms, go and see a physician, go and see a cardiologist. Let them decide whether you are having anxiety or you are having symptoms of heart failure. Because you can not everybody can become doctors. If you have not done the medical, you are not from a medical background, please let's not become doctors. Let doctors do their job.
So this is actually a very big takeaway, that if you face any symptom, go take medical consultation to at least rule out the challenge that you could be facing. Brilliant. Thank you so much. Now, Dr. Vanita, when a person has a heart failure, as a doctor, what is it that you do?
Okay. So primarily, first and foremost, you have to take care of why you are having a heart failure, right? The cause of heart failure is very, very important. If you are having a heart failure because of coronary artery disease, or because of the viral infection of the muscle, or because of relaxation abnormality, the cause is very important, because the treatment of the patient varies according to the cause. The first and foremost, we start the patient on medical therapy. Earlier, when I was doing my MD medicine, right, that time I was told you can only give symptomatic benefit to heart failure. That's it. Just give the symptomatic benefit to the patient, and that's all. He's getting breathless, you can remove the symptoms. He's not passing urine, you can remove the symptoms. But there was nothing to correct the actual etiology which has caused a problem of heart failure. Now, with the time, Mr. Narula, that's why I'm telling you that patients should see the doctors, because we have very good answers to not only symptom modification in heart failure, but to improvement of heart function, quality of life, and quantity of life. Once the heart function gets compromised, you have compromised your quality as well as quantity of life, because 50% of these patients die of heart failure and 50% of these patients die of sudden cardiac arrest, which are the arrhythmias which occur because of heart function which is reduced. So both the things can be taken care of. We have excellent medical therapy now, and we have seen, if you are able to improve the heart function of a patient who has ejection fraction of 35%, you can make it to 45%. The entire scenario for that patient changes. He falls into a different category altogether. So these are we have wonderful drugs which have come up in last decade. We start the patient on those drugs, their heart function improves, the incidence of sudden cardiac arrest goes down, and patient has miraculous improvement in their symptoms, and they do very well. Now, in case the patients are not able to do excellent on the medical therapy, we have to give them additive benefit. Then there are certain devices that we use. Devices. There are about 30% of patients of heart failure, 30% only, have a conduction system defect, whereby the lower chamber of the heart is actually, both the chambers are not contracted in sync. They are not contracting in sync with each other. They are contracting against each other. That is known as dyssynchrony. So to correct this dyssynchrony, we give a 3-lead pacemaker, which paces chambers of the heart and brings this motion back to this motion. And that, in addition to the medical therapy, gives a miraculous benefit to the patient. But first and foremost is the medical therapy. Here I will also add that there is something known as lifestyle modification. Patients cannot go away from that. If the patient has heart failure, they have to modify their lifestyle. They cannot have their lifestyle in the same way as they had it before. They will, and this lifestyle modification is as simple things as keeping a watch on how much fluid they are taking, the liquids, total liquids in 24 hours, how much salt they are taking, how much weight they have. They have to reduce their weight. The less the weight of the patient, the less the load on the heart, right? And plus, in addition to that, things like smoking, alcohol, I never tell anybody to stop these things, but smoking has to go away. Alcohol has to be reduced. There has to be a metered thing on that also.
I actually asked in one of the interviews to a doctor that, why do you tell the patients to stop drinking? They said, क्यों अगर मना नहीं करते, वो कहते हैं एक ड्रिंक ले सकते हैं तो एक के बाद दूसरी तो चली जाती है. So I think that is something that people need to be educated on that. No?
But my experience is that if you tell them to stop drinking, the stress that they have to resist that drink, is more than the torture that the drink would do to them. So it is better keep them liberated, tell them to be metered on that.
Got it. So doctor, your specialization is electrophysiology, which means that you're also putting devices. So my question to you is that you said the first thing you need to do is a medicine therapy.
Absolutely.
And then if required, then you go in for devices, implant of devices. What is the condition where you choose to go in with implant of devices? And can you explain what are the different devices and what do they do?
So, I told you the patients who have heart function less than 35%, about 30% of these patients have a defect in their ECG, which is known as left bundle branch block. That means the ECG is not narrow, it is wide, and the patients have a bundle branch block, which means that the lower chamber, normally what happens is that first the left chamber contracts, then the right. This contraction is almost simultaneous. It is differentiated only by 80 milliseconds. I'm talking of milliseconds, not seconds, right? So they are contracting in sync with each other. Now, instead of this movement, they do an opposite movement because one of the bundle, the conduction system, is blocked. Now, in these patients, they benefit a lot in case we are able to convert this motion back to normal motion, right? Now, how do we do that? Earlier, we used to put in 3 leads. We used to put 1 lead in the right upper chamber, one in the right lower chamber, and 1 through the coronary sinus, we used to put in the left lower chamber, right? And patients used to benefit a lot. Now, there are a couple of things which have to be taken care of here. One, that you have to select the patients very well. You have to be very meticulous about selecting which patients to be given these devices. If you are not good in selection of these patients, then the result will not be good and you will be blaming the therapy. Secondly, you have to select who is going to implant this device. You cannot go to any cardiologist to implant these devices because implanting device is not is very easy, but the putting it in the right branch of the vein, that is the most important thing. And generally, I have seen people taking a shortcut, and since they are not trained well and they do not know how to do a good job, they leave the lead anywhere and then they start doing the therapy that this therapy doesn't work. So it is miraculous improvement in the heart function if you select the patients right and it is done by the right hands. The person knows what he is doing. Now, in addition to that, I want to add here, Mr. Narula, that there is a new modality of pacing which has come up, which has shown miraculous improvement in heart function in these patients, and that is known as conduction system pacing. Instead of putting 1 lead in the right lower chamber and left side lead, we actually, the bundle is broken. I told you the left bundle is broken, right? We go and repair that bundle. We put that lead directly on that bundle, and that is how this contraction of opposite movement becomes synchronous. So this is known as conduction system pacing. In this category, we are able to help those patients also who have a right bundle branch block and LV dysfunction, that means heart failure, and who have an interventricular conduction defect, that means which is neither fitting into right bundle or left bundle, and they are having a heart function which is low. So these patients also benefit with this because we are able to pace directly at the conduction system. We are able to do the conduction system pacing. But here again, my statement remains the same. You have to know the hand where you are going to pace. You have to select that person very carefully.
So, Dr. Vinita, what are the various devices that are available? I believe there was a pacemaker some time back, but now you have AICD, LVAD, and can you explain what these devices are and what does each device do?
Sure. The conventional pacemaker is done for heartbeats which are slow. The first human implant was, I think, done in 1967. So this is a conventional pacemaker. But now we are doing pacemaker with conduction system pacing, which I just explained to you, which is used in patients of heart failure and has very good results. Then we had 3-chamber pacemaker, which is known as cardiac resynchronization therapy. This started in somewhere in 2004 or 2005. Cardiac resynchronization therapy improves the heart function with 3-lead pacemaker. It synchronizes the heart function, the movement of the heart, right? We have ICD, AICD, that is automatic implantable cardioverter defibrillator. This is implanted, the first ICD was, I think, implanted in 1996 in India, right? And this is a device which actually takes care of the life of the patient. It saves the life of patient by delivering a shock. The patients who have heart function which is low or are in heart failure, they are at high risk of sudden cardiac arrest because of ventricular arrhythmias which may occur because of the scar in the heart. there is short circuiting, electrical short circuiting in the heart, and it causes it sparks arrhythmias, and it takes care of the arrhythmias by delivering a shock. It's like carrying an emergency box in the chest of the patient, right? So ICD has been there to save life. Once you combine cardiac resynchronization therapy and ICD, it is known as a combo device. It's a combination of two devices. It can be done together, right? Now you talked of LVADs, that is left ventricular assist devices. In patients who have end stage heart disease, where nothing is working, or patient has come to us very late, and there are patient is getting admitted in the hospital with worsening of heart failure again and again, like there are more than 2 admissions or 3 admissions in a span of 1 month. These patients are given left ventricular assist device to support the heart as a bridge to transplant, where in patients where heart function doesn't improve or has gone into a total end stage heart failure position, these patients are candidates for cardiac transplant, and as a bridge to transplant, because for transplant you need a heart, right? A person who is brain dead has to donate his heart, or his family has to donate the heart. So if that is you are in the queue, you are in the waiting list, then you can have left ventricular assist device which takes the load off the heart and makes you clinically fit enough. It perfuses your brain, kidneys, lungs, everything, so that you are able to meet the requirement of cardiac transplant. Wait till that time, and then you are able to undergo that cardiac transplant.
So for all these devices, you need to undergo a surgery to implant this?
For pacemaker, CRT, combo, ICD, these are the procedures which are done in cath lab. You don't need a surgery. You just need a minor surgery. A pocket is made below the collarbone to put these devices, and the leads go inside through the vein. For LVAD, yes, the chest has to be opened. That is a surgical procedure. It is done under general anesthesia, of course.
So what are some of the precautions a patient should be taking after getting a pacemaker or any such device implanted in the body?
See, getting a pacemaker doesn't mean your life has to change. Your life remains the same. In fact, it becomes better. The precautions for first 1 week are the movement of the hand in case a surgical device has been put in. The leads have gone into, they have to become the part of the body. So the movement of the hand has to be restricted for about a week. That means rotatory movement on the left shoulder, if it has been put on the left side, and the overhead movement of the arm of the left side has to be prevented for 1 week. You have to prevent yourself from infection because you should be in your house. Don't go outside the house, because chances of infection go up in case you are coming in contact with a lot of people. And once you have a foreign body inside, you don't want infection. Then, in case you play football or basketball, or you any contact sports have to be prevented, because you cannot have a direct injury on the pacemaker site. It can cause hematoma, and then there can be a trouble. In case you slip or you skid, try not to fall on the left side, because if in case you have a fracture of the collarbone, the leads go just below the collarbone. They can also get fractured. Now, to prevent all these things, at least for the pacemaker patient, we have a leadless pacemaker. I implant leadless pacemakers. So that doesn't require a surgery. That doesn't require any cut to be given. It is implanted like you have an angioplasty done through the catheter of the leg. You just put a stent and you come out with everything, nothing, no cuts and nothing is there. Similarly, we have a catheter mounted small pacemaker. It's just the size of the vitamin pill. And you put it through the groin, through the leg vein. You put it in the heart, the right lower chamber of the heart, and you take out the catheter, and there is no surgery required. There are no leads involved. I have just recently done a pacemaker, such pacemaker through the neck vein. So patient had an interruption of the lower limbs, the veins of the legs. So we had done it through the neck, probably the first time it has been done in the country. And through the, imagine, just going through the neck, you put the pacemaker, you come out from that, you are walking within 1 hour of the procedure.
So it's just a small.
Yeah, just
done.
That's correct. The venous puncture has been taken, that also is stitched and the sheath is removed immediately.
I mean, I'm amazed at the way technology is evolving today. But what is the usual life of these devices once implanted in the body?
So the battery longevity of pacemakers is much higher than ICD or CRTs. For pacemakers, the longevity, best of pacemakers have the longevity of about 10 to 12 years. And we have longevity up to 15 years also in very recent pacemakers. But the battery of patients with ICD and CRT is around 6 to 7 years.
So we were talking about how technology has advanced, and we hear a lot about what AI is doing in the field of healthcare, medical equipment. Has such kind of development happened in cardiology, both from the perspective of the devices that are getting implanted? So are we looking at a device which does not need to be implanted in the body at any point in time? I'm just thinking aloud. So are we heading towards that? And second is also from the diagnostic perspective, to detect problems related to heart, at home.
Well, that's a wonderful question. And I'm surprised, Mr. Nurula, you asked me in this interview, because AI is something which people are not so aware of in medical profession and in cardiac electrophysiology. We are way ahead in AI. It is helping us a lot. Okay, now the questions that you ask, I'll answer them one at a time. For the pacemakers or devices which you say that they may not be implanted at all, we have not reached that stage, and I don't think so AI is going to reach that stage. In fact, AI is going to help us tell you that you need a pacemaker now, or you need a pacemaker within 6 months, or you need a pacemaker within 1 year, right? So AI is going to go there. We have biological pacemakers which are coming in, right? But they are totally, I would say, the research is going on, research and development is going on. We still don't have enough data to say. There have been some stem cells which have been used to stimulate the conduction system, but we don't have promising results as of now. But maybe 10 years from now, when we are talking, I may be telling you about this thing that we have biological pacemakers, no surgical implant required. Just go through the catheter, put in those cells, and that's it. What we are doing. Because this leadless pacemaker that we discussed till 10 years ago, it was just an imagination. It was just theoretically going on in the minds of people. But now, since 2016, it has become a reality, right? So this is what I would say my answer is towards this. Now, coming to the second question about the diagnostics. Diagnostics in AI and AI help in diagnostics is humongous. It's huge. We have collected data. One of my friend is working in Bangalore. We have collected data of ECGs of various patients, right? We are adding those ECGs to the entire database in the computer. Now, according to the age, according to diabetes, hypertension, ethnicity, whether you are a South Indian or you're a North Indian, so depending on these things, it has been divided, and it is able to predict arrhythmias and MI in patients. So I will be, suppose I take your ECG with the help of AI. I will be able to predict whether you are up against any kind of a cardiac event in future, or how early can this happen, whether you can have AFib or not, whether it may occur in 15 days. And I can tell you, yes, it may occur in 15 days. Let's take the precautions today. The heart attack may occur in next 1 week. So let's take the precautions from today. That is how AI is helping us. And for pacemakers and devices, the way AI has helped is that we have started doing remote monitoring. My patients have to come to me to do the programming of the pacemaker or the devices in the pacemaker clinic. But now we can do the remote monitoring. So there is a small box which gets in contact through the SIM card with the device, And through that device, we get the data through email. So it goes to the central server, and from there, the email comes to me with the entire data, which is analyzed from the patient. Even the smartphones have become so smart now. We can have the app on the smartphone to do the programming of the pacemakers.
Lovely, lovely. Since you brought up this, this thing about being able to understand prior that, you could be heading for a problem. Now we have a lot of genetic testings that are taking place. And a lot of people say that, heart problem could be hereditary. Your parents had it. Because you're diabetes, you're also prone to this. Do you think that we are now in a situation where we can predict that you could be, there could be an incidence of occurrence of a cardiac problem in the future, and this could be the cause, so that you can change or modify your lifestyle so that you can either reduce or remove the occurrence of cardiac disease?
Absolutely. We have reached that stage. We do have reached that stage that the genetics we cannot go away from. We can take care of different kind of, when we talk of lifestyle modification, we can take care of different types of things like smoking, like sedentary habits, like diet. We can take care of all these things. But how do we go away from our genetics, our genes? So in case your parents have had diabetes, hypertension in the family, there is a genetic defect that is attached. And you will definitely have it through your XY chromosomes or XX chromosomes. It is going to come to you. And then doing genetics can give us an idea if we are up against or we are prone against coronary artery disease. And we can start taking the precautions right now. Dyslipidemia is very important, and I have seen families running in having high cholesterol, and that giving us trouble with the children. So we are able to identify children in time to start their medication so that they do not develop a full-fledged coronary artery disease by the time they grow up.
In fact, my next question will be on this, that it is understandable that adults may go in for a heart failure because of lifestyle issues, of how they've been abusing their body for many years, and the challenges that they face of diabetes and hypertension. But why are children facing heart failure? What are the causes that you have observed which are leading to heart failure among children?
I would say, the main reason of heart failure in children is actually congenital heart disease. It is the diagnosis doesn't occur in time, or it is delayed. The treatment is delayed, or the complexity of the anatomy is so much that the patient cannot be helped. Then these children, they develop heart failure in the long run, and it is more life threatening in these children than it has been in the adults, because adults carry on for years together with heart failure. Children are not able to. And apart from that, I would say not children but youngsters. Like coronary artery disease is occurring in patients who are 25 years of age, 26 years of age. They are having heart attacks, and they have major heart attacks because they are smoking, their eating habits are bad, their cholesterol deposits occur in the arteries. So they have major heart attacks, and so their heart function gets compromised to 20-25%. So their quality of life goes away, because it's such a low heart function. How will they live a normal quality of life, right? And so these patients, it is a good idea to do screening for as young as 15-20 years of age, so that you know your risk factors. If in case your family has coronary artery disease, go through the entire cascade of getting a lipid profile checked in. You can even go in for genetic studies. Now there are so many centers available to do the genetic studies. They can, from your blood sample, they can analyze the gene of coronary artery disease if you're going to have that in future. So that can be taken care of, and your modifications can start right now.
So, this is very interesting because my what is going on in my mind is that how do we even discover a problem in a child? Because when a child is born, the last thing that comes to your mind is that they could be, child is still young. You don't expect the child to have a problem. And while genetic testing is the option, but that's not the first option that people are looking at. Are there any signs that young parents should keep in mind to, raise a red flag that, they must get the child tested?
Okay. Before the child getting tested, let me put it in very straightforward and strong words. The antenatal care of the mother is absolutely and mandatory important. We do not do the antenatal checkup well, Mr. Narula, and that is the truth even in the urban population. I'm not talking of rural areas, I'm talking of urban population. Now, what has happened is with the stress of lifestyle that we have, the girls are opting more for their for the occupation and professional life rather than just sitting at home and cooking the food and doing things, and are eating out, having gallivanting outside the house much more than that, then using the public facilities and everything. The care that we take of our genitourinary system is very bad, right? And over and above that, the stress that we have, the eating habits that we have, the girls have it nowadays, and then they want to go in for the child at the age which is 29, 30 years of age. This is a later primary, late primary. It's not the actual age which we used to discuss when I was doing my MD was around 22 to 28 years of age, but it has already changed, right? And then they don't get the antenatal checkup done. So the children who are born with the congenital or genetic defects actually come because of the infections in the mother, because she has not taken care of her infections well during the antenatal checkup. Most of the time, the doctors, the gynecs are able to pick up during the pregnancy whether the child is going to be totally normal or not. So for the cardiac, we can do a fetal echo nowadays. We can take care of the fetal defects during before the child is born, right? But we need to diagnose it. So for diagnosis, you have to go to the doctor, right? You have to get all those tests done. So my very strong message here is the antenatal checkup of the mother is of prime importance, so that the child, whether it's a girl or a boy, whoever is born, is healthy. That is our aim, right? So this is how you can avoid congenital heart defects. Now, in patients who are born with these defects, suppose you have taken all precautions, but still the child is born. How do you know about it? Well, there are various various symptoms you can look at it. One, the child's growth is retarded. There are certain milestones you have to meet, that the child should be gaining weight per month. Secondly, when the mother feeds the child starts to sweat or starts to turn blue, right? Or child starts to have some seizures. Some seizure activity is happening to the child. So, or the child keeps on crying all the time, or develops lung infection very frequently, like cough and sputum is coming out, right? So these are the signs and symptoms you have to look at. That means there is something not right with the child.
Brilliant message on the checkup that women need to go through. Second is, I think this is a very important aspect which the parents need to take care of, because these signs can easily get missed.
Absolutely, yeah.
So, since you brought up the question about the child can be a male or a female, doesn't matter. But my question to you is that are women more prone to cardiac problems than men, or vice versa? Does gender play a role?
Gender does play a role, but it plays a role in favor of females. For a change, coronary artery disease favors females. It doesn't like males, especially Indian males, right? And earlier I used to think that females. It is not my thinking. I'm sorry about using this word. It used to be the data showed that females are protected from coronary artery disease till they achieve the menopause. The hormones protect them, but this is no longer true. It has become a myth with time, and the causative factor of that is that the way women are going ahead in their careers, the stress, the level of stress that they have, in careers and family life balance. The eating habits are so bad. The incidence of smoking is so high in females that they have actually lost that protection of hormones, and the coronary artery disease develops in females also. But if you weigh males versus females, yes, the incidence is high in males for sure.
No, I think it's one good thing that nature has done, or the God has done, because I think women in India do much more work than the men. So I think they need to have a protection around that. But jokes aside, do people who go through angioplasty are also at the risk of heart failure? Or once you get your angioplasty done, you feel that, you're now done?
You have had the elixir of life. Now you're not going to die. It doesn't happen that way, Mr. Nurullah. The thing is that, interestingly, people think they are safe for life, but whether it is bypass surgery or angioplasty, you have to get your echo done after 30 days of any of this procedure. If your heart function still remains after 30 days remains to be less than 35%, go and see a cardiac electrophysiologist. I can say come to me, but that will be too mean on my part. I would say go and see a cardiac electrophysiologist, because you need further care for your heart function, for your heart failure. Otherwise, definitely with time, they will develop heart failure.
So, since you're talking of that, you need to keep yourself checked, during the course, which we are talking of continuing care that needs to happen all the time. Now, there are these new devices that have come up, which are talking about remote heart management, which is being used by people at home, as well as is getting connected to your cardiologist. What is it that you think about it? Do you think these are actually helping in saving lives?
Okay, so there are two kind of remote monitoring devices which are there. One is remote monitoring, which is done for your pacemakers or devices. And second is your own basic parameters remote monitoring done, which means that there will be a small device given to you at home, which will keep a check on your heart rate, on your blood pressure, on your saturation, on your pulse, respiratory rate. And that will be through data transfer seen on a screen by a doctor, right? I can't say it's a cardiologist. So such kind of remote monitoring devices are available, right? And the second remote monitoring devices are the devices which we implant as pacemakers and devices, and their remote monitoring can be done even through a smartphone. There are apps available that even through smartphones we can do the remote monitoring, and we can look at any event which has happened in the devices and forewarn you that such an event has happened. Come and show me in the OPD. We need to change the medications. So similarly, these remote monitoring devices actually help us to forewarn the patients of any complications or any admission which can happen because of the worsening of their symptoms. So that can be avoided by adjusting the medication in time. This is kind of a real-time monitoring which can be done for the patient.
So, Dr. Vinita, I've already taken a lot of your time, more than what I had planned for, but I can't let you go without this one last question that I'm very keen to ask. You know, you got into this field when it was dominated by men, and you've been asked this question several times. I've seen that. What, did you face any challenges? Was there a pushback that you got? And do you think things have evolved and changed for the better now?
That's a very tricky question, Mr. Nirula. And you are right, I've been asked this a lot of times. When I joined this field of cardiac electrophysiology, I'm actually the first, what should I say, lady electrophysiologist of the country. They were all men around me who were doing their jobs. Now, things were not easy. Things were there was a lot of struggle, and the struggle was to the level that, as compared to my male colleagues, I had to work to prove myself that I am worth it and I am worth them. You know, as they are capable, I am also capable. I had to work 3 times more. It was a very very alarming and a difficult situation to stand by your own. But then, over the time, I realized that if there are people who are not supporting me, there are people who are supporting me also. And I don't think so. It is totally dependent on the male or female mentality. It is just the closed mentality of, I thought it was for India. But then I spoke to a couple of my colleagues abroad, especially in Asia Pacific, Europe, and US. And you won't believe, I got the same feedback from them also. So it is not that it was typical to me, or it was in India alone. It is outside also, that when you enter a man's field, there is a lot of resistance. It is your persistence, prevalence, which matters. And if you are persistent to it, I think people see you through for what you are. And then that bias goes off, whether you are a male or a female. I started going to back to Punjab. Punjab is my homeland. I am a Punjabi myself. So I started going back to Punjab, and you won't believe, in Punjab, there is a lot of resistance to this kind of discrimination. As a female, I'm just taken as a gynecologist. People come and ask me as questions, ye ho gaya, wo ho gaya, and I'm like, I don't know anything about gynae. I don't understand that subject at all. But for them to accept that I'm a cardiologist and that also a cardiac electrophysiologist, it's a very rare thing. But I'm sure things will be for the better. I'm sure. The person who has supported me is also a male. He's. I love my Professor M.L. Bhatia, he has been the head of department of All India Institute of Medical Sciences for 20 years. I did my DNB under him. So he is a male, he supported me so much through my career. So, but yes, the people who resisted my progress, what I believe, Mr. Nirula, is that a person who has to move forward, and a person like me who doesn't have an option, I have no option of going back. I have an option only to move forward. Will definitely move forward. If you help him or her, if you help her, she will go forward in little faster. If you don't help her, she will make her way. It may take a little bit of time, but she will make her way through that.
But tell me one thing, what makes people think that electrophysiology is not for women? Why is this bias there? What could be the reason?
Okay. Yeah. See, out of all the branches of cardiology, I would say, cardiac electrophysiology is most challenging. It requires more time, more training, more studying, right? And more time in the cath lab. Our procedures are much longer. When we are dealing with arrhythmias, when we are dealing with devices, our procedures are much longer. And, angioplasty seems like a very simple job, 15 minutes job. And I can never say ablation will be finished in 15 minutes because my study will not be finished in 15 minutes. How can I do the ablation in 15 minutes? So I will take, where angioplasty takes 15 minutes, I will take 1 hour. So the amount of radiation that you take is much more. You are standing with the lead cord, the occupational hazards are there. And then females have to balance the profession with the family life. That balance actually does not let females come in electrophysiology a lot. I have stayed single till date, because of that.
Got it. Got it. But Dr. Vinita, it has been such a pleasure speaking with you. I've really enjoyed this conversation. Really, I'm sure that this is going to be super useful to anyone who watches this. So thank you so much for taking out time to speak with us.
Thank you.
Thank you.
Thank you, Mr. Narula. It was a pleasure meeting you.
Same here.
We now move on to cardiac heart diseases and early age heart ailments. And to make us aware about cardiac diseases, we have Dr. T.S. Clare, Chairman, Fortis Heart and Vascular Institute, Fortis Memorial Research Institute, Gurugram, and Fortis Hospital, Vasant Kunj, New Delhi.
Padma Bhushan Dr. Clare is the chairman of Fortis Heart and Vascular Institute at Gurgaon and Vasant Kunj, Delhi. He was one of the founding doctors of Escorts Heart Institute, where he served as an executive director as well. He's an active interventional cardiologist and has performed over 25,000 coronary, renal, carotid, and peripheral angioplasties. He was the first doctor in India to implant ICD, CRT-P, and CRT-D. He has trained over 200 doctors in the field of interventional cardiology and electrophysiology in India as well as overseas. He has received the Lifetime Achievement Award from the Indian Medical Association and then also received the Padma Bhushan from the Government of India in 2005. I welcome you to BW Healthcare World on the World Heart Day, Dr. T.S. Clare. Dr. Clare, my first question to you is, are Indians more prone to heart diseases, or is the progression of heart disease among Indians more serious? Are more people landing in hospitals with serious conditions? What is your thought on this, sir?
Right. This is a very valid question. And Indians, when we say Indian, mean Indian subcontinent. It includes, Bangladesh, Pakistan, and this area. We are certainly more prone to develop heart disease. And when we are talking about heart disease, that means we are talking about coronary artery disease, where you get blockages of heart arteries and people get heart attacks. Now, there are studies available in the Western civilization, like in America and even in UK. They compared the prevalence of coronary artery disease in Indian versus local Americans versus local British people. And it was found that the Indians are 2 to 3 times more prone to get coronary artery disease. There is no doubt about it that we have more chances. Why this happens? There are some reasons valid, some reasons are not known. Now, one is that genetically we are more prone to get coronary artery disease. Our good cholesterol is less. Our bad cholesterol is a little bit high. The triglycerides are high. And Indians, they are more prone to get truncal obesity, the fat accumulating on the tummy, and they are also much more prone to get diabetes, particularly type 2 diabetes as compared to the Western civilization. In India, now we get a lot of patients below 50 years, which we call it premature coronary artery disease. That's a reality.
Sir, one of the things that I'm taking it from your this particular answer is that it is said that people in India are getting heart attacks and heart diseases 10 years prior to people across the world. Is that a reality?
Yeah, that's a reality. No doubt about that. Actually, the heart attacks are even increasing, if you compare even 10 years back versus today, we see more patients getting heart attacks in their 30s and their 40s. And certainly we get a lot of patients below 50 years of age. Again, why this swing is occurring is something a little bit confusing. But I think the major thing which have tilted this in the wrong direction is our food habits. A lot of processed food, a lot of tobacco, and a lot of diabetes in the Indian population. Again, increasing obesity. India is now the third most important capital of obesity. We have the third most number of obese people in the world. So, it is so-called relatively poor country, but we have a lot of obese people in the country. In fact, I always say that we don't have a pandemic of COVID. There is a pandemic of obesity and heart disease in India.
Do you think that this could be attributed to the lifestyle that people are leading? And
absolutely. I think three major killers in India today: heart disease, diabetes, and hypertension. They are by and large lifestyle diseases, and there is a clear-cut documentation and through scientific studies that if we improve our lifestyle, we so-called develop the ideal lifestyle, which we can develop later, the premature death can be decreased by 67 to 80%. Everybody has to die. We don't want to prevent death, but we want to prevent premature death. So the premature death can be 67 to 80% prevention can be done by just lifestyle modification.
Right. Dr. Claire, we have seen that young celebrities are now succumbing to heart ailments. And what could be the cause? I mean, I've also seen that younger people are taking supplements, protein supplements when they're going to the gym. Is it okay to take these supplements, or is this an area of concern and could be causing more heart conditions?
Right. See, when we talk about the young celebrities getting heart attack, that's a reality. But the thing is that when the celebrity gets a heart attack, it is known to people. It is the media will tell everybody that somebody has a heart attack. But to be honest with you, there are a lot of so-called uncelebrities who get heart attacks in much more number, but nobody talks about them. Nobody thinks about that. Now, one has to, differentiate between apparently healthy person and a medically tested healthy person. See, you must have heard so-and-so was very nice, he used to gym and there was no problem. Suddenly he has a heart attack and died. Now, the thing is that they are apparently healthy. We don't know what is underlying in their body, what is the disease inside. So when we have to say that somebody is reasonably healthy and he has a very low chance of heart attack, that means that he has been examined by a competent doctor, either a physician or a cardiologist. His cholesterol are good, he doesn't smoke, and his weight is under control. And not only that, a proper exercise test has been done on him and which has been declared as normal. So that is the category we will say that they are really low risk individuals. But even somebody is running 5 kilometers a day, but he has not been tested by a cardiologist by proper stress testing and proper investigation, we cannot say that he was a healthy. That is number one. Number two, there are diseases other than coronary artery disease where high intensity exercise can cause cardiac arrest, which people hardly know in India. For example, there are 2-3 diseases I can tell you. One is called hypertrophic cardiomyopathy. This is a disease which is genetic based and runs in the families. Here the heart muscle becomes very thick. It's a thick myocardium. And if you exercise, particularly high intensity exercise, you can develop ventricular fibrillation, so-called cardiac arrest. And this is one of the modes of death in hypertrophic cardiomyopathy. There are other diseases like one disease called rhythmogenic right ventricular dysplasia. Here, the right ventricular heart muscle is replaced by fibrofatty tissue. And even these patients, if they do high intensity exercise, they can have a cardiac arrest. And then there are some other diseases like we call it channelopathy, where there are electrical disturbances. The heart on echocardiography is normal. So there is another disease called QT prolongation, where people can get cardiac arrest. So when we talk about sudden cardiac arrest, sudden death, below 35 years, many of them, they may not be coronary artery disease, but still there are a lot of people who have coronary artery disease. So that is one thing which has to be understood.
You know what I can understand is that every person needs to be very conscious about their prevention and get themselves checked regularly to understand if they're medically fit.
Right. See,
Right.
one note of caution I want people to understand, particularly those people who are hopefully listening to this program, that if somebody wants to do a high intensity exercise, that means you want to become a professional player, footballer, you want to do marathon, you want to do squash playing, then these patients, these people should have a cardiac checkup. And two things minimum we should do. One is the ECG, and another is echocardiography. If somebody wants to do routine exercise, mild to moderate exercise, then there is no need of people at large to check them, because that is not cost effective. But people who desire to do high intensity exercise, I think they should have a cardiac checkup.
Got it, sir. So you have been using this word coronary heart disease. What is coronary heart disease and what causes the CHD?
Right. See, when we talk about, we call it, cardiovascular atherosclerotic heart disease. What is cardiovascular atherosclerotic heart disease? We have the circulation of the body consists of basically two systems. The heart pumps blood, and the idea of the function of the heart is to send pure blood, the red blood, oxygenated blood to the various parts of the body. Now, the tubes which carry this blood to the various parts of the body, they are called arteries. But the tubes which bring back the deoxygenated blood, so which is a relatively blue color, these are called veins. Now, when these are tubes basically, arteries and veins, they are tubes which carry the blood. The arteries particularly, they develop deposits inside them, inside the lumen of the artery. It's just like if you imagine, there are MCD pipes, and the longer the pipes run, there are materials that deposit inside those pipes. So similarly, there are building of these deposits inside the blood vessel. These are called actually atherosclerotic plaques. See, when the plaque burden increases more than 70%, that means the circumference, the diameter is compromised more than 70%, then people start getting symptoms. Below 70%, they don't have any symptoms, and nobody knows that they have these plaques. So when they develop these deposits inside the coronary arteries. The coronary arteries are those arteries which supply blood to the heart muscle itself. See, there are two coronary arteries, right and left. Left is more important because it supplies around 75% of the heart muscle. So when we say coronary artery disease, that means the deposits are inside the blood vessel, they supply the heart muscle. And they are responsible for angina. For example, you have a chest pain when you exert, or you get breathlessness, or you get heart attacks. That is what is coronary artery. And but the same phenomena, the same process occurs throughout body. For example, people develop blocks in the arteries which go to the brain. That causes stroke. Right. Similarly, these deposits inside the kidney artery will cause a kidney failure. Similarly, these deposits in the leg arteries will cause leg claudication. That means they get pain in the legs while they are walking, and even the extreme cases, people get gangrenes.
Got it. Sir, since now you're explaining that, these are basically pipes that are carrying the blood. Now, obviously, there is a wear and tear in everything. That right. is there. So is there a usual age by which these blockages start appearing?
Yeah, it's very, very good question. This phenomenon starts at a very young age. If you study the post-mortem arteries of people in their early 13, early teens and early 20s, you will see very, very mild plaques or deposits. So the disease starts very early, and it takes years and years to build up. So it's not, if somebody is getting heart attack at the age of 70 or 60, the disease is, it doesn't mean that it's a new disease. It's an old, long-standing disease which has caused the problem. And that is why when we say prevention of coronary heart disease or atherosclerotic heart vascular disease, it should really start in very, very early life, in early 20s at least.
Sir, like you said that you usually face symptoms or start feeling the symptoms only when your arteries are blocked more than 70%. Right. Until that, you don't even come to know. But are there some early indications that people could be mindful of so that they feel that, okay, let me go and get a check done, let me consult a doctor?
Right. See, as I said, that unless the lumen of the vessel is blocked more than 70%, most of the people don't have symptoms, because by the rule of physics, the blood supply is normal in those patients, even on exercise. Even if they work hard, there's enough blood supply to the that part of the heart muscle. But when the blockages go beyond 70%, 75, 80 or 85%, then initially the person will have symptoms only on some activity, not at rest. But let's say if they are walking, climbing stairs, or they want to do some exercise, then they will start having symptoms. Now, what are those symptoms? The symptoms are usually either in the form of some chest pain or chest discomfort, particularly in the center part of the chest. If I'm showing like this, if you get some pressure in this area on activity and it gets relieved on taking rest, it is a 99% cardiac problem. That means this patient is having angina. Some people don't have pain. They may have just discomfort, very kind of uncomfortable feeling. Some people may have pain on the symptom on the left side of the chest. Some people may have right side. Some people may have in the arm. Some people may have in the jaw. That when they walk, there is something bothering them in the jaw, and they take rest, it gets better. Some people just get breathlessness. When they walk, they don't get pain, particularly people with diabetes. They may not have pain or discomfort in the chest. They just get breathless. So, but basic thing which I want people to understand, that any symptom, any pain, any discomfort, any uneasiness in the chest, particularly center part of the chest or left side, which occurs on activity and gets relieved by taking rest, should be seriously considered as a cardiac problem. If some patient says that I have a chest pain, but I walk, when I climb stairs, when I start exercise, I feel much better, it is highly, highly unlikely that this is a cardiac
problem. Sir, when we do a routine checkup, when we say that preventive, especially after COVID, people have become a little more aware. So they get their blood test done. But many of the time, they get the blood test done, but they don't get their ECGs done. Now, is there any indication from these blood tests that can give you a hint that you could be heading for a problem?
Right, blood, annual checkup is, I think, should be recommended for everybody. I would say that more than 20 years of age. We should go down to 20 years now. When we say a yearly checkup, that means, at least blood pressure checkup. We check blood sugars, we check the cholesterol, the lipid profile. And because we can catch very young people if we start doing these investigations early, because there are families where there is a high cholesterol, high LDL. LDL is bad cholesterol. We can catch them very young. If we don't do tests, then we never catch them people, and that's one of the major risk factors. So we must check the lipid profile. We must check the sugars, kidney functions, and when we find somebody, like for example, somebody is having LDL of 175 or 200. Those patients, I would recommend that we need to do some kind of exercise test also. But when you reach 35, then I think exercise test should be done for every person, at least every 2 years. But people with the high risk individuals, like people who have family history of heart disease, people who have got diabetes, or they are smokers, then I think in those cases, some kind of test should be done every year. So ECG normal, another misconception in people is that my ECG is normal. ECG will remain normal until and unless you have developed some kind of heart damage, which is called heart attack or myocardial infarction. So ECG normal does not mean that you don't have a cardiac problem.
That's a very important piece of information because usually people don't understand this.
Yeah.
So we've understood the causes, we've understood the symptoms. Now, what are the treatment options available in case somebody has a CHD? And so let's understand the treatment options.
Right. See, first of all, I would say that there's a lot of role of prevention. You know, I think it will be a sad story that we have to treat patients with coronary artery disease, because as a nation or as a medical fraternity, we should try to implement preventive strategies which are not happening in our country. You know, there is no state in India, even Delhi, for example, which has a heart prevention program. Like we have a national malaria program, we have a national, some other program. Similarly, we need to develop now on a very urgent basis some kind of national cardiovascular prevention program in the country. Because now what is happening is that 67% of total deaths, even in India, they are because of non-communicable disease, not because of the infectious disease, as was the story in the past. So we have caught up with the best that our most mortality is from the non-communicable disease. And when we call about non-communicable disease, out of that non-communicable disease, 50% is cardiac mortality, 50%. Others may be, for example, lung infections, cancer, and other inflammatory disorders, rheumatoid problems. But 50% of the non-communicable disease is cardiac in nature, either heart attacks or stroke. It's the same story. So that is the reason that there is an urgent need. I think Ministry of Health should take it very seriously to start a national prevention program for cardiovascular disease.
I think that's a very
that is the prevention aspect, I think, which we have to take very seriously. For example, there should be television programs, Doordarshan or anybody else on a regular basis, where we can teach people. I mean, there are a lot of Asta channels and a lot of gurus speaking all those stories. There are 70, 80 people teaching about God, but there is no channel in India which tells people about their health. So I think a national health prevention program is the need of the hour. Now, your another question that when a person develops coronary artery disease, what are the treatment options? Well, there are three kind of treatment options. One is the medicines. The second is minimal invasive treatments like coronary angioplasty or stenting. The last kind of option is a bypass surgery. Now, the trend all over the world is going either towards treating them with medicines and prevention. But if somebody has significant blockages and he has significant symptoms, then as far as possible, we try to treat them with angioplasty. That means this is a non-invasive, this is an invasive strategy, but this is minimal invasive. And you can open those arteries with the balloon and implant a stent. But patients where there are multiple blockages, patients who got particularly diabetes, and patients where there is a left main disease. Left main is when the left artery, when it starts, it's from the aorta. If there is a left main disease, those patients are recommended bypass surgery. Each patient, in heart disease, in coronary artery disease, there are, I would say roughly, if we divide these patients between angioplasty and bypass surgery, almost 40% patients, clearly they should go for angioplasty. Around 30%, everybody should agree that they should bypass surgery. But then there are 33% patients where both the treatments are valid. You can go for angioplasty or bypass surgery. That depends on many factors: the age of the patient, diabetes or no diabetes. Then the difficulty of doing angioplasty. For example, complex cases, or then what the patient wants. So we look into various aspects to decide whether angioplasty should be done in that particular patient or bypass surgery.
So in case a person has diabetes and he's at the edge, so he's the kind of person in which either the bypass or angioplasty can work. What is the doctor's choice usually for a diabetic patient?
Right. This is a very, very important question. And to be frank with you, it is not easy. There is no easy answer for general public because there are a lot of complexities involved in decision making. Now we consider age of the person, number one, number two, how many blockages are there, number three, whether the angioplasty is a simple process or a complicated process. Then there is something called syntax score. Syntax score is a score which we calculate on the basis of seeing the coronary angiography. That also tells you whether it's a complex disease or a simple disease. So if the syntax score is less than 22, then usually angioplasty is a reasonable option. If the syntax score is high, then those patients are better to be going for bypass surgery, particularly if they have got diabetes.
Are there some natural remedies which can help you open the clogged arteries?
See, once you develop these blockages, there is no medicine so far developed or any natural methodologies which can reduce those blockages. But the one thing is very clear that if the people with any degree of blockages, if they adopt a healthy lifestyle, that means you do regular exercise, you look after your diabetes, your weight is under control, you do some kind of meditation, yoga, keep your coconut cool. There is no doubt that in those patients, the blockages will not decrease, but they don't get heart attacks. The chances that they can develop cardiovascular events is decreased significantly. So prevention, even after the blockages have occurred, has a lot of.
Sir, some kids are born with congenital heart diseases.
Right.
Now, what kinds of congenital heart diseases or heart conditions are there, and how can they be treated? And also, if you can let us know that if a child goes through a treatment of a congenital heart disease, does he stand a chance to live a life as normal as the other normal kids?
Right. Again, a very good question. And I will tell you that roughly 3 out of 1,000 live born children, they have a congenital heart disease. Now, this is of various types. One is that the person may be, child may be born with a very slow heart rate, which is called as congenital heart block, where a person may need even a pacemaker on the first day or second day of his birth. Apart from this, then there are structural abnormality. That means either there are holes between left and the right ventricle, or between the left atrium and the right atrium, or there could be, at various levels, even at the atrial level or ventricle level, people may be having a combination of atrial septal defect, ventricular septal defect. And then there are diseases where there is abnormal mixing of the impure blood and the pure blood. That those babies are blue, they have blue lips and blue nails. That's called cyanotic heart disease, where the nails and the lips are pink as normal people. They may have what is called as acyanotic heart disease. First of all, there is a tragedy in India that a proper examination when the child is born is not available. So many of the diseases, a child is born, they are missed because there is no proper examination. That's number one. Number two, that if you detect the congenital heart disease in children in time, most of them, they are reasonably curable problems, except a few cases like there are some diseases which are complex congenital heart disease where you can ameliorate, but those children may not have a normal longevity of life. But I would say 80% or 85% of the congenital heart disease, if treated in time, then give you a normal longevity of life. I would suggest that the government, the society should adopt this policy that every child when born, he should be examined at that particular stage. Then when a child enters school, there should be a cardiac checkup at a primary level, and then maybe a final a cardiac examination when the child enters sixth class or seventh class, something like that. So if we do this through 2 or 3 examinations at the time of school admission, I think we can pick up 99% of the congenital heart.
That's brilliant.
But again, there is no philosophy, there is no program in our country. For example, even the private school, they may ask what is the income of your parents, but nobody is persisting that the child should have a cardiac checkup is normal or not.
Yeah, I think it's a brilliant idea, and I think we should act on that. So my last question to you is, there are some private doctors and hospitals that resort to unnecessary treatments for whatever reason. Now, they may be very small in number, but this has brought us to a point where patients and their families do not know if they can trust the doctor or not, and which is why when the doctor suggests a treatment, and we know that in heart case time is very, very important, they're unable to make a decision, or they choose to make a wrong decision, and the loss is usually irreversible. On the World Heart Day, what is your message to these doctors?
Mr. Harvinder, first of all, I will tell you that a wrong treatment or unnecessary treatment to patients is done because of 2 reasons. One reason that the doctor is not knowledgeable enough or competent enough. It is his bad judgment. Okay, and we have still at least some doctors who may not be up to date. The second reason for doing a over treatment or when the procedure is not required is that somebody doesn't have ethical values in medicine. Though it is a requirement by the the fraternity and everybody else, but people have different kind of personalities. So there may be treatments done when it is not required because of unethical reasons or financial reasons. So this is world over. It's not an Indian phenomenon. But how to decrease it? How a patient, for example, how it can be decreased at a national level? First of all, I would suggest that there should be medical auditing in country. It doesn't exist at all. Even in Delhi, there is no medical auditing. Auditing means that, for example, if I do 50 angioplasties in a month, there should be some, experts, 2 or 3 experts coming to me, my hospital, checking random files and seeing their angiogram and deciding whether it was done rightly or wrongly. And this is what is being done in the West. So we have to introduce medical audit. For example, a lot of unnecessary cesarean sections are done. Lot, I tell you, lots and lots. Again, there is no medical auditing. So we need to introduce medical auditing. See, human beings are same everywhere. Why people don't do wrong things in the Western civilization is not that they are better human beings, because there are checks and rules and regulations. So that's what we need to introduce. And number 2, that how a patient can, at this stage in India, can save himself from a wrong treatment. I think whenever you are in doubt, one person, I would suggest seriously that they should take a second opinion from an expert.
Dr. Claire, thank you so much for taking out time for Business World Healthcare. And on the World Heart Day, it has been a pleasure speaking to you, and you are gracious enough to take out time for us. I really, really appreciate that.
It's a pleasure to interact with you and Business World, particularly with you. It has been always a very thought-provoking discussion, and I'm very grateful for that.
Thank you so much, sir. Thank you.
Bye-bye.
Heart failures are indeed unfortunate, but its treatments are many. One such treatment is bypass surgery. To give us more insights into heart failures and bypass surgery, we have Dr. Balbir Singh, Chairman and Head of Cardiology, Max Healthcare, Saket, New Delhi.
Dr. Balbir Singh is a prominent cardiologist, well known not only in India but globally. He is also a Padma Shri awardee. He is also a fellow from the American Institute of Cardiology and has written many chapters in books and journals worldwide. He has always demonstrated the zeal to innovate and explore new horizons to serve the mankind. Welcome to BW Healthcare World on the World Heart Day, Dr. Balbir. My first question to you is, why are more younger people getting challenged with heart conditions than ever before?
Right. So it's very unfortunate, but it is very true that the young population is growing into a lot of diseases, particularly the heart disease. There are many factors. As a youngster, I didn't see so much fast food. I did not see so many cars. I did not see people eat so much, smoke so much. We used to walk a long distances. This has completely finished. The stresses that we see now are unimaginable, unthinkable on the youngsters. The youngsters have targets to fill. They have many exams which are extremely competitive. Not that we didn't go through competition, but I realize now millions of people sit for exam which has limited number of seats. And that stress on these children and the youngsters is just going to carry on into some effects which is going to be through the heart. So many young heart attacks are happening, many young are dying. But it is not that it is not preventable, it is preventable. The youngsters have to understand that life is not just eating, dancing and drinking, because they do a lot of that. It is not partying every Saturday and doing binge drinking, because it is very harmful. So they have to understand all this, but it is true that the youngsters are increasing in heart attacks.
So women have always felt that they are relatively more protected compared to men. Is that true? And second, is it changing?
Right. So God has been kind to women that in the premenopausal age, they have less incidence of coronary heart disease or heart attacks than men. This is true. There's no doubt about it. And God is had made it for a purpose. So nature does everything on a purpose. There's every formula calculated by nature, and it does work on that formula, and there are no rules or exceptions to it. So why did he want women in a premenopausal age not to have heart attacks? Is to that they can bring up their children, and he was sure that the women are required to bring up children, and so premenopausal women were protected. We initially thought it is their hormones which protects them. So as a scientist, people thought the estrogen that happens in the premenopausal period may be protecting them. So let's give them estrogen in the postmenopausal phase and try to prevent heart attacks. But unfortunately, that didn't work. So that means the nature has done something very different, very special to protect them. But as the menopause happens, or as they reach the menopause, the protection is lost. And then you suddenly see more women come with heart attacks. Unfortunately, women reach the hospital late. There are more deaths in women with heart attacks. There are more complications of procedure which I do, like angioplasty or other things, in women than men. So after the menopausal age, the women have to be extra careful, and you would have seen that women tend to put on a lot of weight after pregnancy and particularly after menopause, which also may be actually increasing the heart attacks.
Also, what we have observed and what we have heard of, that Indians are more predisposed to heart problems. Is that a correct statement?
It is correct, because Indians are genetically more predisposed, has been sorted out in many studies in UK and in America and even in Singapore, where they compared the Indian population living natively versus the Caucasian, the West population, the white population, and it is clearly a very huge jump in the Indian population. So Indians have higher degree of three things. The Indians have more: higher degree of diabetes, higher degree of abdominal obesity, that means a pot-bellied weight gain. Americans may be tall, hefty and overweight, but they don't have abdominal obesity. So abdominal obesity is a risk marker for heart disease. And the third thing is hypertension. So three things are more in Indians than. So we are genetically predisposed, and there is no way that this can be denied. I am certain on that.
So you are into interventional cardiology. Now, how do you decide that this patient is okay to go through implants to protect the heart condition versus who needs definitely a bypass? How do you differentiate?
So when a patient has heart disease, he has blockages in the artery, we have three options. We have medical management, we have surgery, and we have angioplasty. So angioplasty and surgery are now competing against each other because both branches have developed. Angioplasty develops by every year, there is a new thing coming. So the procedure are getting simpler, faster, patient is able to get home next day, and sometimes the outcomes of both surgery and angioplasty look similar in many group of patients. However, there are some patients, particularly diabetics, who have long diffuse disease, multiple blockages, calcium, then we recommend that please go for surgery. You will have a better outcome rather than getting multiple stents where the chances of reblockages are more. So this is how we decide, but every patient is an individual patient. So the final answer is rests with the counseling that happens between the patient and the surgeon. So many times patients come and tell us, I gave them this option may be better than that, but sometimes they say, no sir, up stent dal do. So it is a decision between patient and but patient has to be explained what all medicines thereafter, what he has to do thereafter.
Right. So we are talking of prevention. We are telling people to go through screening, etc. But somebody who's already healthy and does not have any visible symptom, when they go in for screening, they're limited to blood tests. So what are the blood test symptoms or results that signify that you need a further checkup or you could be predisposed to cardiac problems, sir?
Right. So if somebody has a strong family history, he is every reason to be investigated more than just blood test. Anybody who's a diabetic and on blood test is also found to have high cholesterol levels, there's every reason to do more tests. But anybody who's asymptomatic, his blood tests come out to be normal, there is no need to go for further testing. So blood tests are very important because they can pick up many risk markers which can be useful for us to treat and prevent a heart disease.
When somebody goes through a cardiac surgery or a implant, has the technology advanced to a stage where people post-surgery can start living a similar kind of a lifestyle as a normal person?
Right. So it is our duty to give a normal quality of life to the patient. So whenever we talk of a process of whether it is stent or whether it is surgery, our two things are very clear. We have to increase the longevity, we have to make the patient live longer, and also have to give him a better quality of life. What is the point of increasing the years in life without giving that quality of life? So every aim is to get a better quality of life. So how can we be helped by the patients? If they present to the doctors, to us early in their course, we almost assure them that you will have normal quality of life. But if they come to us after 2 heart attacks, heart pumping is already down, and now we are struggling to save his life, this may not be the right answer.
So my last question to you is that we have seen young people getting into cardiac problem. There's a lifestyle challenge that we have seen. You have already explained. What is your message to the world today that can help get inspired to start living a life where cardiac challenge should not be something on their mind?
Right. So my first thing is that cardiac diseases are really dangerous. They are worse than cancers. So cancers give you time to treat, to think, discuss. Here you don't get a time. You just catastrophic here or there. So if you have that fear in mind, we also know cardiac disease is preventable. So a good lifestyle, good control of diabetes, good control of hypertension can actually produce outstanding results which can save so many lives and have a better quality of life. A diabetic comes to me, sir, अब तो diabetes होगी, अब क्या होगा? मैं बोलता हूँ, if you try to control it and follow what we say, you will have a normal lifespan like a non-diabetic. So the medicine field is evolving so much that why not take advantage of it?
Got it. Sir, I really thank you for taking our time to speak with us. It's a pleasure. I think we can together contribute towards making a healthier country.
Yes, I hope so.
Thank
you very much.
Thank you so much.
Heart transplants in India are picking up. As heart diseases rise all over the world, heart transplant have come as a transformational solution. To tell us more on this, we have Dr. K.K. Talwar, Chairman Cardiology, PSRI Hospital, and former Chairman, Medical Council of India.
Dr. K.K. Talwar is a cardiologist. He's a medical academic and a writer, and the former chairperson of the Medical Council of India. He performed the first implantation of the implantable cardioverter defibrillator, which is ICD therapy in South Asia. He also introduced cardio resynchronization therapy in India. The government of India awarded him with the Padma Bhushan in 2006. Dr. Talwar was a cardio physician in the team of Dr. Venugopal when Dr. Venugopal performed India's first heart transplant. Currently, Dr. Talwar is working with PSRI Hospital, New Delhi as a chairman of the cardiac sciences. Welcome, Dr. Talwar. You're also very passionate about taking this information
You see, let me share you why. And this was my area of weak heart management was my area of little involvement research when I was in AIMS.
Gee.
And the first transplant that we did on 3rd of August 1994 was the first one that I had to keep this patient for 3-4 weeks in the hospital just to make sure that we get a heart. So that's why my involvement has been very close in this field.
Right, sir.
And so I'm involved from the day one that the heart transplant started in the country.
Lovely. So, Dr. Talwar, thank you so much for joining us on BW Healthcare World. My first question to you is that people are scared of heart procedures. Can you explain how the cardiac related procedures have evolved over the past few years that have made it safer and given us better outcomes?
You see, one is the technology that now we have a better imaging. You can define the disease more precisely. Now you have equipment which can help you during even procedure, whether surgical or in the cath lab to be more safer. When we started catheterizations, we used to put cannula which were larger in size. Now we can have smaller size which can give you the same kind of access. So I mean the technology improvement, of course, no doubt, there has been learning and there has been skill improvements also. So I think all these things and some of the innovation in cardiology has been very exemplary. I mean, in the last 3 decades, I think when I passed my cardiology DM, the knowledge that we had at that time and knowledge that we have today is a huge kind of development. Newer things come and our thinking have changed. I mean, 360 degree. I mean, there have been that if in the late 70s, you tell the examiner, I will treat this disease with this, he might fail you. Today, if you don't tell me, you can't pass. I mean, so much changes has occurred. So I think the enormous growth has occurred in field, in every field, but cardiology particular, I think there has been very, very significant advances. I think that's the research, understandings. And the people are now a little more, like you tell earlier, bypass surgery will have so much risk. Now people know it's done in most places, very safely done. So I think gradually people.
So, Dr. Talwar, before I deep dive into questions related to heart transplant, you have played a key role in bringing and implementing some of the multiple heart-related procedures in the country. What were the challenges that you faced while bringing these procedures to India, as well as creating the adaptability and acceptance of these procedures over a period of time?
See, my main sort of professional kind of commitment. I worked in these two major institutions, AIMS and PGI. So I joined AIMS in faculty in 1980 after doing my cardiology training from PGI Chandigarh. You see, in these institutions, there was always a passion to do newer things. And how to give the kind of a therapeutic option to our patient, which are available outside. So this was a kind of a challenge with the faculty when we were working there. So there was always something which is coming new. We must adopt quickly, and we must see that we can give the benefit to our society. So for that you have to. There was for all professionals, it was a struggle that you have to work very hard. You have to see where this is being done, how to learn it, how to get a hand onto it, and then start doing it here. But that's beside, I think the major difficulty that we used to face used to be cost issue. Because that was when you bring a new procedure, I mean, it costs so much that patient, whether affordability was a major issue. And then institution, of course, these two public sector institution is always try to, the government pays for a lot of every infrastructure, government pays for the salary of the professionals. So the patient doesn't have to, those are not the concern. Concern was the consumable or the equipment that you need, that to bring that technology. I can just share with you, and there is one technique in cardiology which has been my major area of also as a involvement, clinical and research. This is arrhythmia management. Now, earlier, so we used to have only medication for that. This is that people get very sometimes fast, right? Which may be sometimes very serious issues also. They can be less serious, they can be also more serious. We were depending upon medication. And medication probably success is limited, and there were also side effects. Now, I mean, this was a very great, I will suggest, I feel that as a cardiologist, one of the major innovation in cardiology, understanding that how this occurs. There are some electrical connection in the heart, which were probably there from the birth, and they can get active anytime and can cause these kind of problems. So was that that if you can define the location of the electrical channel in the heart, by a catheter only you can heat that area and it will become inert and the patient will be cured. Now this technology changed our outlook to arrhythmias. Now when we brought this, it was 93 or so when we did our first aims. Number one was to have a technology. If you go wide, technology wise was expensive. But we try to innovate in our way that we use our available infrastructure. Though we compromise on, you have to then struggle more, you have to work hard more, you have to spend time more if you have not the latest technology. But anyway, we wanted to start. So we actually, so this is what way you try to innovate. But when we brought, if you look at the catheter costs in a given patient, if we use everything new outside, like it will couple of lakh. But we said we can guess these things. And to our rescue was some of the central even abroad were doing. So we could justify it to our ethical people. And the cost, we were hardly charging an institution 15 to 20,000 rupees, which would be 3-4 lakh if somebody goes outside. So I think we could address the cost of the procedure technology certainly sometimes creates issues to bring it to the society. Of course, then the expertise, that's why attempt by this institution is to produce more and train more people. They can go to the periphery and can do this. So I'll say the major issue has been to get the technology. Because of the money involved, sometimes institution may not have that much funds available. There's many other departments. And other was consumable cost, which most patients usually pay. And in both, I think, AIDS, PGI, it was because it's not possible to give them totally free. If you start doing that after a few months, you will have no funds and your procedure will be not. So I think no harm to charge some amount from the patients who can pay, and those who are really poor, you can use that and some subsidy to give them free also. That's what so I think the getting equipment, the financial issues and cost to the patient, these are some of the concerns which were sometimes like ICD when we first started in the country. 95 first ICD was implanted, implantable cardioverter defibrillator. This is another for arrhythmia. Some people who suddenly die because of fast, serious arrhythmias. This device is in the body and it can rescue at that time. It was costing around 3-4 lakh that time. It's more even that today. So, and for a common person, you can imagine how to spend this much. So these are some of the concerns. That's why I think we need to indigenize our technology. That is one way we can, PM Saab's make in India, made in, so I think we need to work on it. We and some or the other been depending on technology, even consumable from abroad. I think here we need to little get in.
I totally agree with you because accessibility and affordability is a major concern. And we've seen that in stents, it has made a difference by creating manufacturing indigenous stunts.
No, but then I'm happy that the government slashed the prices.
Absolutely.
Imagine the same company was selling in lakh plus one, and then they now sell 35. They're willingly giving it.
Correct.
So
Correct.
they were taking us for a ride.
Absolutely. Absolutely. So, Dr. Talwar, let me bring the discussion towards something which you are also very, very passionate about: heart transplant. What was your experience? How did you take that challenge to do the first transplant? Your experience?
You see, I'm a cardiologist. I'm not a cardiac surgeon. We were a cardiac surgeon needed and a cardiologist. Both are needed. Of course, the procedure is done by the cardiac surgeon, but evaluating patient both before transplant as well as after transplant, therapeutically giving that's purpose of cardiologists. Like, so first case was done, Dr. Venugopal was the one who was our cardiac surgeon in AIMS. When we did this first was 3rd August 1994. That was the first heart transplant in the country. And I think June 94, Government of India came with the act of brain death. Prior to that, it was not possible. And June, we started working on it. We started collecting our patients so that so we should have all group of patients. You never know when you get a donor, which blood group, because the blood group has to match. So we started working on that. I was involved in patients with heart failure. We were doing regularly biopsies in them, which is the important procedure when you evaluate foreign transplant for cardiac rejection. So like it was, but I mean, it made a great satisfaction to us because these are the patients we call end-stage heart failure. There is no option. We have exhausted with whatever medication we have. Even today, I will say it's about 94, we are 22. 21st, you can say 28 years. Even till today, the medication that we have for heart failure patients, we have number of them which has come up in the last 2 decades or so, but still 5 years survival is around again 50. We lose 50 in spite of what we have. So the only treatment for these patients at the moment, till we have a artificial heart or till we have a knowledge that we can regenerate the heart muscle, we have to depend on heart transplant for these patients who are end stage. So that's the need. So I think it was interesting that we started this procedure. Of course, now this procedure is being done all over the country. Many good centers. South has taken a lead than North. The North started the first, but now South, I think, has gone far ahead than the North. And there are certain reasons which I can say.
Right. So, from the time you started to now, have you seen more success in heart transplants than failures?
No, even our success at that time was very good. I think we rarely lost a patient during the surgery. It's only in the post-transplant period, some of our patients who were from little periphery or not that well-to-do, and that infection was one major reason, like some people came with tubercular problem afterwards. But otherwise, I must say that the procedure success-wise, no issue. And now with the availability of immunosuppressive therapy that we have, I'll say 90% patients are okay at 1 year and 80% plus maybe okay at 5 years. So I think as far as now with these drugs that we have or monitoring that we can do for these patients, the outcome is quite, so right from the beginning, I'll say success was, failure was less than success. It was very encouraging, I must say.
What are the prerequisites relating to heart transplant procedures?
Is it prerequisite like that person who is a candidate for heart transplant? You have to evaluate them properly because it's a major procedure. And you, number one, like you must be sure that patient doesn't have any other chronic issue or problem. Somebody may have malignancy, somebody may have a severe psychiatric issues. So I think that is one. That we look at the other, that does he have any other comorbid issue, or somebody had a stroke, suppose in the last 6 months. We look. So that is one, to look for any disease which will limit the life of the person. If somebody has a cancer and he may not live more than 1 year or so, to why to give a sometime today there are certain blood leukemias which are treated, and if person is treated from that, I think if you need transplant, no issue. So it's a evaluation of from that angle. And then the cardiac evaluation as such. For example, that patient, because if a person has a very long standing heart failure, or sometime the patients may have a congenital heart problem, then there are certain diseases, your pulmonary pressure, pulmonary artery, lung pressure may go up. For heart, suppose we are looking for a lone heart transplant, somebody has a very bad heart, end stage heart failure, but because of a chronicity, his pulmonary lung or pulmonary artery pressures have gone very high. We measure it like more than 6 wood units. Those are the situations we know that they may not do well after that. So like proper evaluating the pressures, doing the right heart cath. Then there is another blood test which is on panel reactor, anti-PRA we call it, because this is some people, they are very highly immunized. I mean, they are danger that if you transplant them, rejection is very high in them, acute rejection. So there is a blood test we call PRA. You try to measure the antibodies, and if it is more than like 10% or so, we know that this is a little high risk. We have to then take, there are now medications that you can take care of that to treat them before you take for transplant. So I think looking at the comorbid states, like somebody should not be having any cancer issue which is limiting his life, a chronic lung issue which is limiting his life, chronic psychiatric issues or brain stroke. So if there's none, then the cardiac evaluation wise, we only go by the that there's no pulmonary artery pressures are okay, PRA, pan-reactive antibody is okay. So these are some pre evaluation of a patient. And at the same time, sometimes you should be also, there may be some patients which may say very poor heart, he may be for a transplant. Some people may have a very severe coronary artery disease. We have seen a couple of our patients, we thought he will have to go for transplant. We did a angio. We found they have significant disease, but they can be bypassed. So they were taken for surgery and they did well. So I think it's a proper evaluation of the patient is very important for all angles before you say that he's a candidate for transplant. Right. Of course, one more, then we also have tests to see the priority. Like you do echo, LV ejection fraction should be around 20% or low. Their VO2 max, we call oxygen consumption, like less than 14 cc. There are certain parameters which also that no, he is a candidate for transplant. And then there are some people you feel they should be on more priority, like some people who are on anatropes, or somebody is mechanical support, his heart is so big that he may die. So these are some situations. So comorbid, looking properly and evaluating the heart problem. That's it.
Now, one thing that comes to my mind is that when you are evaluating a patient, and like you said, that heart transplant is in a case where everything else has been, we know that it will not work. So in that case, and you find that there are chances that if you do the transplant, he's at a danger level because of comorbidities, etc. How do you then choose? I mean, don't do the transplant because the donor heart is going to go wasted, or you will still take that chance and maybe, if there is a slight chance of the revival?
Well, usually because the recipient number is very large, you will really feel that, okay, that we don't have a recipient. I mean, now, today, if you don't have a recipient in Delhi, you can transfer the heart to some other city where the recipient is there. The government has made this NOTO organization, so which tries to monitor. So I think wasting chances are less today. But you must make sure that whatever heart is available is used in a way that we can have the best benefit, rather than transplanting to a person who has some other comorbid issues and then may not be. So I think today we have more number of people who are awaiting transplant than the donor. We have a scarcity of not here. Word over, this is the issue, because heart transplant is only possible in a brain dead donor can. It's not a live donor, is not there.
Correct.
So this is the issue. So I think you have to be careful when you're using a heart.
Right. How long does this procedure last?
You see, this is involves, one is harvesting, another is transplanting. Now, harvesting, sometimes you even harvest somewhere outside and then bring it. Like in our end center, when we started, we used to harvest, we used to have a donor right in our center. You harvest in one OT and transplant in another OT. So I think harvesting takes about hour or so, because you have to other, and then transplant procedure is not that very long, or like other surgeries. And I think surgeons say that it's more simpler than many of the complex surgeries. But it's a question of, I mean, person who have, but people have learned the technique. But it's take about, you would say, 1.5 hours, just attaching all, maybe maximum 2 hours.
So, Dr. Dalgar, do you think that people are accepting the idea of donating the heart of their loved one when the person passes away, when the person is brain dead? Or because, you know, a lot of people pledge their organs while they're alive, but the family may not be acceptable to, you know, let the...
No, I rightly say this is still a concern when it comes to accepting, no, that he's no more, because otherwise his heart is working. It's only the brain is not working. To convince first the family, no, is not possible to, now he will not. So there is always a, I mean, I'm sure all of us, but I think here comes the education to the society. And here I think that I'll say media, NGOs, religious organizations, I mean, they depend a lot how to change the people's mind. Now, I mean, particularly religious organizations, you have temples, you have gurdwaras, you have, if they educate, because main people, sometimes religious reasons, वो कहते हैं ना जी अगर आपने organ लगा लिया तो शायद आत्मा नहीं, मतलब these kind of belief which are there in the society, we need to little educate them properly. And I think sometime when we have seen also those who agree and then they donate, how sort of satisfied they feel that they've done something very. And sometimes I know some people call. I remember we had a donor. There was a family traveling from USA. They had an accident. I'm talking around 2000. And they're a young boy, around 17. The accident, he passed. I mean, they brought to Apollo Hospital here. And then brain dead. They themselves said, I'm talking of late 90s, 2000. They said, okay, if possible, we'd like to donate organs. Luckily, that time at AIMS, we were doing heart transplant. We got a message. Our team went, brought the heart, and the transplanted, and that girl is now 22 years post-transplant.
I think, you know, these are the kind of stories that we need to bring out and make people aware of as to what.
But the family was so more younger heart, 7. It was very healthy heart.
Yes.
And that's probably what helped this young girl. She was also around 30 that time. And she had just married a year back when she came to know of heart. So I think educating the society and with these kind of examples, I think in our country, I'll say it has to be mainly from NGOs, media, like, and of course the religious organization to little educate the society for this.
By when do you think the artificial heart will be a reality and commonly used? Because that could change the whole scenario.
I think two areas which are under a lot of evaluation, lot of innovation for over now 20 years plus. One is to have a very effective artificial heart, which still we have not been, and there have been even some years Berlin hearts like that we will get quickly, but I think there are some technical problem. And recently you must have xenotransplant that you genetically modify that like pigs and all that, their heart may be used. Recently it was done as a kind of a last resort, though of course the person. So I think these are two things which are coming, and I mean, let us hope will sort of that we have a something more that we feel that we have conquered this area. But still, at the moment, I think a lot of work is going on. I think let us hope. But I mean, at the moment, apart from the donor heart of the brain dead individual, the new thing has come to expand your donor pool. That is the taking a heart from a dead person within few minutes, 5-7 minutes of the death. And then there are certain now available sort of perfusion kind of equipment that you can perfuse the hearts to keep it alive. So that is one thing which has come as a donor pool to expand. Of course, age also, earlier we used to say take donor only below 50, now probably 55 or 60, you can harvest the organ provided the heart is normal. So I think these are way to increase the pool. But what you said about the artificial heart, so we have a now what we call left ventricle assist device. It is like a now this also has been used now. Today, a person who is eligible, you have to, all may not be eligible for LVAD, for a, we call left ventricle assist device. And it has been seen, those who have a normal right heart, only left ventricle is affected. If you put the LVAD, the outcome may be as good as the transplant over a period of 5, 7, 10 years. Though I think it's also now becoming like a destination therapy that you implant it and it's like that's all, you don't need a transplant. But most of the time, this is also used as a bridge to transplant. If you don't have a donor, you put this person may be okay for some years, and then probably you might have a transplant. So this pattern destination therapy of LVAD is like a artificial heart, but it can be only given in patients who have only left ventricle. They have two ventricles. The right is affected, then probably it has limit.
So whose heart cannot be used?
You see, one is the person who has a heart disease, then you can't use. If a person also has a heart ailment or so that limits, I mean, sometimes as we suppose somebody only has a valve issue, but heart is muscle is normal, you can harvest and do the repair of the valve. That is possible. But if the heart itself is not functioning well, that is one. The second is if somebody during injury, the brain death, mostly accidental patient, somebody's heart has been injured and all that, that becomes a, or if you have been resuscitated, a long resuscitation. So there are few places where I think that heart may not be. And then you also have to match the heart to the body. Within 20% of the way, somebody, you have a heart from a child and donor is adult, you may not be able to match it. So these are some of the limitation. But as I mentioned to you, with the help of notebook today, you can know where the heart is needed of that kind of heart, that size of heart can be used, and where is the recipient available. So I think you can transport. There, I think transport is a concern sometimes because it's very expensive. The private jet, you normally now using the field flights. Maybe I think government can try to find some base or a like a, it should be suppose some heart has been transferred from Delhi to Hyderabad or Chennai. That they should not charge any money for that. I mean, this kind of thing option just to make it more attractive, more affordability.
Yeah. In fact, my next question is this: that what is the role of the government in making heart transplant and this treatment accessible and affordable? So,
see, as far as the government has a very important, huge role rather. Apart from that, asking, I mean, the advocating to the society the benefit of this, the major few area which I think is the question of affordability also. I think government can pitch in there. They have done it in many other things. Now, for example, as I said, transport of heart maybe. Acha, recognizing different places for harvesting, where harvesting can be done, may not be transport that, then transport, making it like the government, like green corridor, you must have heard this. Like suppose the organ has to go from a airport to a hospital, which may take the venue traffic. They used to make green corridor that to make sure that there is no delay during this. And now there is another approach of drones that you from, suppose you have a heart at the airport and you have to bring it to like aims. Instead of that 1 hour, just by a drone, 5 minutes can drop it into the. So these are the ways we can. The other area that I think government should be is the drugs that we use for post-transplant. We call immunosuppressive therapy. They are also expensive. I think they can be also put in like essential drug list so that they become cheap. The other, I think it's more on the state government. The central government has already encouraged it, part of the act also. They should make every state, the brain death should be notified. You see, once you notify a death, you have to tell the family. And then you have to tell the family that you can donate organs. I think notification, this is one area where I think Tamil Nadu taking a lead, other states in South, where the North has lagged. I mean, so we should, this kind of thing should be there. Because patient may still, family may still not agree. But at least law-wise, the doctor has to say, okay, this is a patient with me who is brain dead. Once you do that, then you are committed. You have to educate them to for this. So if you, so that notification, I think, to my mind, is probably another approach which will help us to make it more awareness also, and to probably get more organs for transplantation.
Got it. Got it. So before I let you go, what is your message for people on the World Heart Day?
You see, first is I must say that we know most of the heart disease that we have are lifestyle related. Living congenital that you have, life. So I think people should, we must realize, society must realize that we need to adopt healthy lifestyle, because that's the major. I think there are pressure of all kind. Now, though stress is a risk factor, stress to everybody. If you have to grow in this present world, you have to face stress. So you have to train yourself how you can take care of stress, how you can tolerate stress, and how you can your eatings and your exercise. I am happy today the corporate, even the government sector also realizing the importance of encouraging their employees for exercise, preventive checkup, identifying if there is something else. But at the same time, I think it's important also if somebody has, he should be supported. It should not be the health issue, though I think we have now insurance and all that. But I feel health is one where government should spend. I think it should be for everyone, irrespective of whether he can afford or not, whatever is possible. So I think, I mean, need to draw a line sometime. But otherwise, my message will be, please adopt good lifestyle measure so that you save yourself. And of course, if go for preventive checkup. The worry for preventive checkup sometimes is people are scared. And then sometimes doctors also scare that. We come across, ये आपका तो आप एंजियो कराओ, आप ये कराओ, तो आता है पेशेंट में ये थोड़ा it can be false positive. So ये भी थोड़ा सा है. But I think people should adopt lifestyle measures, I'll say, to save oneself. And if you have something, don't hesitate to find a good doctor. Go to public sector hospital where there's less of, I mean, though I'm in the private sector, I'll say privates are two kinds. One is commercialization is bad in medicine, privatization is different. Don't make the profession as a commercial kind of. ये थोड़ा because health or ये I know it's not easy. I think so. Let charitable organization government should a little more support, facilitate the private so that they can also, the important, of course, invest in the public sector. And people should go for a proper lifestyle.
No, I think I hear your message that, I think going forward, public-private partnership is the way forward, where government plays a key role in not just supporting, facilitating, but also ensuring that healthcare can be accessible and affordable, not just to foreign, people who are looking at Indian medical tourism, but for the Indians living in the country.
I mean, that part also, tourism, whatever will be, tourism, what to mean doesn't help, whether they come for some kind of, because, but the question is that shows we have the capabilities to help the society globally. We should use these opportunities. I mean, here I think the private sector has to play a major role because our government sectors are ruled with our own patients. You cannot ignore our own society, but private sector can have because that then give them more resources, generate more money. That's also needed, and you maybe subsidizing the same whatever you earn from our own public. So I think, I think it's good that we have now we can claim that we can provide much more cheaper care, quality care to abroad people who want to come here as compared to what is in Europe or America.
Correct. Great, sir. Thank you so much for your time. It has been such a pleasure speaking with you. And I think this conversation is going to be not just, value, but inspirational to people. And I just hope that more and more people decide to take positive action in contributing towards donor hearts.
Thank you so much for this opportunity, and it's a pleasure.
Now, moving on to the mindset shift towards a healthy heart. For that, we have Dr. Mohit Gupta, Professor of Cardiology, GB Pant Hospital, New Delhi. Let's listen into the conversation.
When we look at what causes cardiac problem, the things that come into our mind is diabetes and hypertension. The causes for diabetes and hypertension is our lifestyle, and which is typically bad food, which is lack of nutritional diet, as well as lack of exercise. But there's a third element that makes significant reason for the cardiac problems, and that is stress. To talk about stress and to understand what is it that we need to do, we have with us a cardiologist, Dr. Mohit Gupta, who is the medical superintendent of GB Pant Hospital and the professor of cardiology at GB Pant Hospital and Maulana Azad Medical College. Let's listen to what Dr. Gupta has to say about managing stress. Dr. Gupta, thank you so much for joining us on BW Healthcare World. After a lot of conversations with various medical professionals, on which I learned about medical terms around cardiology, and specifically I wish to focus today on something called stress and the challenges of stress, as this is one of the causes of the cardiac problem. What I want to understand from you is, what is stress and can people control stress?
See, today's lifestyle, psychosocial stress is emerging as one of the very powerful top 5 risk factors for occurrence of coronary artery disease. And I'll explain it to you in a very simple language. You see, when we talk about the word disease, the disease word comes out of 2 words, dis and ease. That means when you're taking out easiness from your life, you become diseased, logically so. Now, where does this easiness come from? It comes from not only of your body, but also of your mind. And let me ask you, Harvinder, very clearly, that when you meet a doctor, don't you say that by meeting this doctor, half of my pain goes away? How does that go away? This goes away only because by comforting somebody's mind, you are able to take away the mental agony. So that is why almost 99% of the disorders have their genesis and start and the beginning in the mind. And here is the genesis of stress. Stress is an abnormal reaction. It's an abnormal reaction to a situation which is always present there. So people try to say that I will deal with stress, I will remove stress, I will do this particular thing. I will have 10 strategies to deal with stress. I say that why do you want to allow this word stress to enter your life? It's truly not needed. You know, absence of peace, absence of joy, absence of proactiveness, absence of happiness is what is called stress. And once I'm not able to focus on more positive things, I start changing my perspectives toward life, and that is what brings stress. Stress is only a consequence of losing balance in one's life, transforming your own self from human beings we were supposed to be to human doings. We are just doing today, right from morning till evening. So, controlling stress actually is not the right word. We have to only take care of our own mind. Inability to take care of our own mind has led to imbalance in our life, and that imbalance is now reflecting in our thoughts, in our behaviors and words, and in our action. Our thoughts are asynchronous, they are not comfortable. Look at this. आज सोच कुछ और रहे हैं लोग, आज बोल कुछ और रहे हैं, आज कर कुछ और रहे हैं. There is loss of balance, there is loss of that synchronicity in our life, and that is what creates stress. So if you want to have a really blessed and a comfortable life, the key is making your mind your best friend. Never try to control situations. The control word itself is wrong. Be friend with that particular situation. Be friend with your own self. Be friend with your family, with your surroundings. When you are friend, everything falls in place. Everything falls with a lot of comfort, a lot of joy, and that is how you see. So I've never allowed this word busy, and I've never allowed this word stress to be associated with me. So today, on this platform, I will say that two words that have become synonymous with our life, synonymous in our life, they are I am busy and I don't have time. These two words are an integral part of our life. You and me are not different. Every one of us who is listening to us today, busy hu, jaldi karo. And studies in Stanford University, California, very clearly show that those people who believe that they are busy, those who believe that they don't have time, their stress level almost double up and their performance goes down by 50%. So, how do you control stress? Simple answer is delete this word busy from your life and include this word be easy in your life. You are easy inside. When your mind is very comfortable, mind is very nice and relaxed, everything that you do, maybe it's challenging, you are able to do that thing with a lot of joy, a lot of love. And once you're doing something with joy and love, there is no question of stress, irrespective of how hard and how difficult your schedules are running. My typical schedule starts at 3:15 a.m. in the morning and it runs up to 11 p.m., 11:30 p.m. in the night. But I still remain very comfortable and easy. Why should I be stressful? I'm enjoying that particular work and I remain very, very comfortable. So all the youngsters and everybody, it's time to take care of your own self. You cannot pour from an empty cup. If you don't have something here, what are you going to give outside to others? It's very, very important for us to understand that we have to empower others. We have to ourselves. We have to take care of our own self before we take care of others. So this is my perspective of stress.
You just mentioned that you begin your day at 3:15 in the morning and you end it by 11:30 at night. Now, there is this theory going around that, you need to be relaxed, you need to get enough sleep. Now, what do you have to say about that?
True, absolutely. There's no doubt about it. I myself strongly recommend that you should have 6 to 7 hours of sleep, 5 to 6 hours of sleep. But my question to you is, for those people who choose to sleep for 6, 7, or 8, or 9, or even 10 hours, is your body sleeping or your mind is also sleeping? That is very, very important. Relaxation is not just for the body, relaxation is for the mind also. You know, remember a day, this must have happened in your life also, Arvind, that sometimes you have done something terrific for somebody, sometimes you have helped somebody really so much, you come home really tired, your body is giving away, but your mind is jumping with joy and happiness. At that day you get only 2 or 3 or 4 hours of sleep. What is the quality of sleep? It's beautiful, it's phenomenal. that 4 or 5 hours of sleep is enough to recharge because your state of mind is very relaxed, very giving, and very, very comfortable. So that is why these theories are fine. Truly speaking, 2 hours is a sleep cycle, and that 2 hours of sleep cycle is enough to charge our body for 4 hours. So two such cycles charge our body for 8 hours. And history is, really showing us a lot of reflecting on a lot of evidence that in old times, our yogis, they used to sleep for only 2 or 3 hours or 4 hours only. Still, they were able to empower themselves. Still, they were able to lead a very balanced and a happy life. So more important than the quantity of sleep, it is important to have a quantity of sleep. I'm not saying it is not important. It is also important to have a good quality of sleep. Very, very important. So take care of the quality of sleep. There are ways to, do that. It's all about creating a healthy lifestyle. It's all about balancing and creating magic in your own life.
Right. So, Dr. Gupta, we just know that one must exercise, one must eat nutrition and balanced diet to keep a healthy heart. What is the missing ingredient? Because I see a lot of people who do these things. They're maintaining a healthy lifestyle in terms of food and exercise, and they're young. There are people who do not even smoke. They don't have alcohol, but yet they are ending up having cardiac problems.
I'll tell you. You see, to have a healthy lifestyle, there are three pillars. There are three very important pillars. And those three pillars are: one is good diet, the second one is great exercise, and the third one is adequate rest. Now, I just told you, I just reflected on this particular fact that when you are somewhere somehow disturbed, you are not mentally very comfortable on that day, do you really feel like working? Yes or no? Please answer this. Do you feel like working? Of course not. You would say, no, Dr. Gupta, I feel that I'm not very in a state of mind where I can really work. I'm not uncomfortable. Please check my blood pressure. I'll go and check my temperature and I'll do 100 kind of things. On the contrary, a day when you are really tired or you have some kind of an injury on your body, but suddenly you get a great news, something that really gives you a lot of joy and happiness. On that day, you forget the pain of your body and start celebrating. So this shows that it's always mind over matter. It's always our mind that scores over our body. Why this is relevant before I start speaking on all those three aspects is because we are taking care of the healthy diet for our body. We are trying to have a very designed diet for our body. What about having a good and a great diet for our mind? Very, very important. We have a great diet for a great exercise schedule for our body. We try to compete, we try to do great gymming, we try to do isometric and isotonic exercises. But what about exercising your own brain and mind? You give rest to your body, but what about resting your mind? And this lack of synchronicity, lack of connect between your mind and body is the root cause of all the disease. That is what I was initially saying, that disease is lack of happiness and joy, easiness first in our mind. So that is why today you see youngsters, young people, out of 200 cases that I operate in a single week, what happens? Almost 25 to 30%, 33% of my heart attack patients are between the age of 18 to 30 years. Now, what I carried out these experiments and making it very relevant for you and for all the audience to understand, you must understand what was the fact. These people, these youngsters, not about these celebrities I'm talking about the mass people, mass, where our India lives. These youngsters were coming to me. They had no diabetes, they had no hypertension, they were non-smokers, they had no family history. Still, they are getting heart attack. And I thought that we should work. Why this is happening? This has never happened before. We started studying their psychosocial stress, their family stress, their general stress and work stress. And also we measured their telomere length or the chromosomal length to study their biologic age. What were the results? The results were that physically they were of the age of 18 to 33 years. But when we studied their biologic age using the length of the telomeres and the chromosomes, their age was equal to the age of 60 to 85-year-old person. Now imagine, these are published results. These are documented results. We got an award for that also. And this shows that, physically they are of 18 to 33, but their genes are completely destroyed and expressing rampantly, hence the disease is occurring. Now you would say, why this is happening? Okay, even if it is there, why this is happening? Then what we saw was the only risk factor that these young children had was highest level of psychosocial stress. Highest level of psychosocial stress. Okay, even if they are having stress, then how does this affect their body? What is the science behind it? Then we started analyzing that those people who lack love in their life, those people who lack happiness, gratitude, and joy, they have improper relations, not healthy relations. These are the people whose telomerase enzyme is destroyed, and the telomere length, the chromosomal length, is significantly lessened. On the contrary, those people who are happy, who are having gratitude, who are having joy, who exercise daily, having great relationships, these are the people whose telomere length is preserved, and hence the expression of disease is less. This is science. Hence, this shows that our own mindset, you may be doing any kind of things, you may be a successful person, you may be having ₹1 million in your account, you may be driving a Mercedes, you may be having a 2 or 3 floor mansion, you may be having everything materialistic that you want, you may be so-called the achiever. Check that what is the level of happiness and joy and satisfaction. Three things: happiness, joy, and satisfaction. If these things are not there, that probably we are one of the most poor people on this earth, isn't it? So you may be doing gymming, you may be doing everything, but where is that joy and happiness? And this is why what is happening today, Habib? Today we have created our lives to be high tech. Gone are those times when we are totally technology dependent. Yes, it is important, but I strongly understand and I've learned to live that today, instead of just having high tech, we need high touch in our lives. We need compassion in our life. We need love in our life. We need connect in our lives. This is what we need today. You know, today everybody is rising and running towards pride, towards power, and towards fame. This is what we are trying to earn. We may be having everything, but where is the joy? We lose that, and hence we are having more and more, heart attacks, and not only heart attacks, brain attacks, gastrointestinal diseases, early aging, brain illnesses. All these things are increasing logarithmically. Not just about heart; it's about every disease that is expressing rampantly a decade earlier, or in fact 2 decades earlier, in our young children and young population. Hence, balance is the key. Once you talk about a healthy diet means not only for the body. There are 4 or 5 principles for a healthy diet. And those 4 or 5 principles, in very brief, I'll explain it to you. Those basic principles are that your food habit should be like a pyramid. You should eat like a king in the breakfast. You should have a moderate or a good meal in the afternoon. But remember, the night meal should always be light. Today, in this technology world, in this world we call ourselves busy, we reach home at 8, 9, or in fact 10, and I see almost 80 to 90% of the Indian population, they are having, or younger population is having their meals after 10, sometimes 11, sometimes 12 a.m. or 1 a.m. in the night. And now we must understand that any food or consumption after 8 p.m. or 8:30 or 9 after today, 8 or 8 p.m. in the night, is acting like a poison for us. It is very, very important. This is pure science. We need to have or give our bodies 2 or 3 hours to start that digestion process, so that is not harming ourselves. So that is why I changed my dietary patterns, and today I have always my dinner before 8:30 or maximum by 9. Exceptions are always allowed. That's not a rule, but not as a rule. Never have the privilege of having meals on the drawing room or in your bedroom or in your study room. Look, these are the privileges we are given to our children. In the home, we are connected not through by talking to each other, but we are digitally connected with our family on WhatsApp. In the same room, sitting next to each other, we have created walls. And the only message, the connection is through the WhatsApp. How are you, mom and dad? They'll say, yeah, we are very fine. What is there in the meal? Oh, this is prepared. Okay, please send it here. Okay, we are sending. Oh, this is so advanced world. It's been 47 years in my family. I'm a cardiologist. My both parents are doctors. My younger sister is an entrepreneur. She runs a big company, web designing. But we never have the privilege of having meals in our room or drawing room. We all 4 of us continuously, without fail, we have our dinner together on the dining table. That's what we need to inculcate. It's a great habit. So these things we have to inculcate. These are healthy habits, and these are the principles. So having good diet, good move, and there are certain principles like having food, like having like fruits and vegetables. So fruits and vegetables and salad should be an integral part of your diet. And remember, the problem is what with us is that food and vegetables and fruits we always have generally with or after diet. Fruits we'll consume after that. No, it is not recommended. It is strongly recommended that salads and fruit should always be consumed before our meals, 15 to 20 minutes or maximum at meal. So these are basic principles, never eating directly from the pocket or from the packet. We always pour it on our, these are in our, plate, taking small portions, decreasing the size of the plate, savoring the food, enjoying the food, feeling the aroma, and then consuming the food. These are great habits. And then there are various food patterns. I've never focused on a specific diet. There are hundreds of diets that are available. It's a keto diet or LC, low carbohydrate, high fat diet. People follow these things. I believe eat everything, balance is the key. Everything you eat. I never refrain myself on spoiling from on a chocolate or on an ice cream or something like a samosa kachori. I love them. There's no problem. But maintaining the balance is the key.
So, Dr. Gupta, I want to ask you about your own life. You have yourself transitioned and transformed in the last couple of years. Can you please share your journey so that it becomes an inspiration, not only an inspiration, but people can know what needs to be done and what could be the result of that action?
So Vinda, this was actually not just 2 years, it was 21 years back when I came from America. I was studying there and, I was 96 kgs at that time. And somebody in my family on 16th July 2001 told me that you want to become a cardiologist, you should look like a cardiologist. That is very, very important. These words really, had a lot of impact on my life and my thought process. 19th July, I started working on myself. I really started working on myself. Never consulted a dietitian, never went to a gym, but I changed my food habits into very positive and proactive food habits. Decrease the portions, increase the frequency, small portions, and increase the quality of food, having everything. Besides this, I always started exercising without fail. 1 hour of exercise schedule was fixed into my schedule. That is very important. These two things, determination is very important. Remember, no amount of exercise will ever be able to take care of a bad diet. So Kiko principle is calories in should always be less than calories out. This is what I balance. And in 6 months, I lost 23 kgs. At that time, I had diabetes, hypertension, and thyroid disorder also. I'll share the pictures with you. You can show to the audience that it's a fantastic revelation journey. And in 6 months, I completely lost. My diabetes disappeared, my hypertension disappeared, my thyroid disappeared. And it was not about that 6 months of transformation. The great thing is that 21 years down the lane, I still try to maintain that lifestyle. I'm without fail. I every day exercise. I go to my for my workout, for strengthening my body, for maintaining a good aerobic schedule, so that my weight and everything is balanced. So this is the reformation. And what did I do? I just changed my dietary patterns. I'll give you a simple example. All of you must listen to this, how these things and this work and diet is working in our life. Let us say we are sitting in our home and your child wants to have a samosa or a kachori, and you order to a fast food chain, not mentioning the name, and you're pretty sure that that particular thing is going to come in 10 minutes or 15 or 20 minutes. Otherwise, they will get to free. So now everybody logically knows that no food actually fresh can be prepared in 15 to 20 minutes. It's practically not feasible. How do they do is that they already have a half prepared samosa or a kachori which is lying there. And that half prepared samosa or kachori in a already boiling oil immediately after the order is immediately poured. And within 2 minutes, it comes out fresh for eating. It is packed and it is delivered to you and you enjoy it. Now remember, once a half cooked kachori or a samosa or any other particular thing is put into a already boiling oil, these two things are disastrous for health because they release something what is called as trans fats. And these trans fats are highly toxic, poisonous for our arteries. They will literally clog our arteries. The food will be tasty, but they destroy our arteries practically. We get heart attacks once we do these things. So this is the science that is working behind this. So I am not against eating them. If you want to have them, get them freshly prepared in one go. Even at home, never keep half-fried things in your home. It should always be done in one go. These are simple tips that we should follow. You can eat everything. You can have cakes or pastries occasionally. You can oil myth, people say, oh, I'm using olive oil. I like olive oil. I'm using this particular thing. Now, let me clarify this simple myth of oil for you also. This is what I follow. People say, I've used olive oil. I say, what? How do you use it? They say we use it for frying, for, shallow frying and everything. But remember, the benefit of olive oil has been shown in Mediterranean population, and that too of a extra virgin olive oil, which is costing 3,000 to 4,000 rupees a liter. It's practically not affordable for most of us. So I recommend for Indians, typical and good oil is a simple mustard oil. It's a phenomenal oil. And once you use the olive oil for cooking or deep frying or seasoning, it loses its essence and its value. So the mantra is you balance and rotate oils, have all the oils on your shelf and keep on rotating them 15 to 20 minutes. But once a oil is used for deep frying, don't reuse that particular oil. You have to reuse only for seasoning and what we call as chauk lagana ya shallow frying. That's all. Similarly, having fresh fruits and fresh juices is very, very important. It is strongly recommended by guidelines not to have tinned juices and tinned fruits. It is not, because even if the juice is fresh, the calorie concentrate becomes so powerful that will increase the chance of one getting diabetic. So it is strongly recommended. I've stopped consuming tinned juices and fruits for almost 2 decades now. I always eat them fresh. And if I have to juice vegetables, I will juice the vegetables fresh only. No juicing of fruits, absolutely. This is how. Nuts consumption is very important for a healthy diet. Very important. Having a badam or a akroot or chia seeds every day, 4 or 5 in the morning, 20 to 30 gram every day is good. It's very great for you. Legume consumption, dale in all forms, green vegetables, they are as much as you can consume them. Tea and coffee, black. There is no limitation. You can have as much black tea and black coffee as you want. These are recommendations. Mushrooms are very heart healthy. So these are the diets that you have to use. Homemade curd, water, all these things are going to give a lot of help. So there is a huge, there's a proper symposia that we conduct for this, and we can give you some very deeper insights into simple do's and don'ts into dietetics. But it is important to have a very good and a balanced diet. Along with it, I'll just supplement that as you give food to the body, it's important to maintain the nutritional psychology. It's not about the proteins that we are eating, but with what vibrations we are eating. Vibrations of purity, vibrations of joy, that my food becomes a prasad when I offer it to God. There is scientist Dr. Masaru Emoto has clearly shown by his experiments that our food gets empowered once we have pure and positive vibrations in it, and it heals my body and mind. It's very important. So that is why, as a vegetarian, strongly, there's no doubt we have now 4 longitudinal studies published in consecutive journals, which have shown that vegetarian food completely changes our mindset. Vegetarians outlive meat eaters by 7 years. The mortality decreases by 41%. 4 studies, one after the other. Predimed study, Adventist heart study. We have immense evidence that today we need to have a sattvic and a pure diet 24/7. It's not about just having Navratras or festival when we become absolutely pure and leave everything. It's about leading and having a pure diet every day, because our vibrations are working. This heals our mind.
Dr. Gupta, since we are talking of, spirituality in food as well, and we've seen the benefits of it, I want to ask you one question which has been on my mind for a very, very long time. It is that people speak about the law of attraction, and they said, your body has the power to heal itself. And do you think this alone can help you live healthy and protect your heart condition? Does it conflict with science and what the specialists have to say?
Law of attraction is a consequence of a balance between a healthy mind and a healthy body. Law of attraction is a consequence of a balance between, or a harmony between, or a blend between great science and a great spirituality. They are never against each other. And I'll tell you why we think, because we want to achieve something else, but our inner self is not believing in that particular thing. And our lack of belief, I always believe that whatever you want in your life, it's already on its way. It's reaching you. But it's only our lack of belief, our lack of firm mind, our thoughts makes it distant from us, takes it away from us. So that is why if we really want to achieve something, we need to have a very powerful and a very healthy mind. Your every thought is creating your destiny. You are what you think, and there is no doubt about it. Studies by magnetoencephalogram, studies by our various electrode experiments, they have shown that your brain can be mapped without touching your brain. It can be completely mapped into a healthy or an unhealthy thought process. So our thoughts are manifesting outside, and this is called the science of neuroplasticity. Why? I'll tell you. There is a lot of science behind it. Dr. Eric Kendall in 2002 got Nobel Prize for a beautiful study, and that is summarized in one line that is called nerve cells that fire together, they wire together. Simple. That means once we are consecutively thinking the same thought again and again, our brain has a natural process to form new electrical connections in our new synaptic connections in our brain. And once we repeatedly keep on saying the same thing, they get stronger and stronger, they get harder and harder, and our brain gets rewired for whatever we are thinking. It could be a positive thing, or it could be a negative thing. It could be success, or it could be failure. So what is law of attraction? Law of attraction is that I want success in my life. I'll share my example. 2001, when I came back, I wanted to do cardiology. I wanted to study for cardiology. And those are the time when we had only 5 seats in our country. So obviously nobody used to, practically very few people used to get it in first attempt. And I went to my mother and said that it's very difficult for me to clear. She said that how many seats are there? I said 5. She said, how many you want? I said, I want only 1. She said, remove the other 4 and focus on only 1. And what I did was, in my front desk, I posted a sticker that this 1 seat is for me. I'm going to get it. This is already coming to me. I'm attracting it. I'm reaching towards it. Every day I'm getting closer and closer, closer and closer to my goal. This is what I'm doing. So I used to study, of course. It's not that I'm not studying. Law of attraction works only when you're working for it. But I never had a second thought that I won't get it. I never believed that I won't get it. 9th February 2002 was the exam, and I came out and gave the exam. I went to my friends that they would be discussing the question paper with me. You won't believe, nobody discussed the question paper with me. They said that we'll give you the key, Dr. Gupta, Mohit, so that you can prepare for the exam next year very, very well. You know, imagine these kind of things on a Saturday afternoon when I came back after giving exam. I was really, but I said, no problem at all. And I went home after a haircut. I started enjoying. 15 days later, when my result came, my rank in the country was first rank. I got 95%. And the second rank was 78%. Why? You are already attracting that. You're already seeing yourself, visualizing your success in a perfect and the most beautiful way. Only if you believe. Only if you believe. So it is actually a science that is working. It is not a spiritual. It's a balance of both spiritual. Because spiritually, I believe, yes, I'm powerful. I have the power to do it. And once I consecutively do it, science and the whole nature conceives and works together to make it happen for me. There are 3 rules of law of attraction. Very simple law of attraction. There are various books. Rhonda Bryan has written Secrets. There are many other people who have talked about it. Unfortunately, most of the people don't use it in the right way. And that simple 3 rules are ABR phenomena. ABR is what? Ask. Whatever you want in this world, ask nature. Ask God, I want this thing. It should be a good thing, not negative. I want this particular thing. Believe. Believe that that is already on its way. It's coming to you. It's reaching you. Nobody is going to take it away from you. And the third one is receive. attract like a magnet. It start receiving those things automatically every day. Success is mine, success is coming. It could be business, it could be money, it could be spirituality, it could be relation, anything that you want, it's already on its way. This is how you do. So there is no contradiction at all. Only our thought process is making it more and more complication. And I'll tell you, Harbinder, the practical application of it. Look at your family or everybody who's watching. Look at the words that we use in our family. मेरे बच्चे हैं वो तो पढ़ेंगे ही नहीं. My children, I don't think they're going to succeed. Oh, I am always a failure. I don't think this task is easy for me. I won't be able to do it. I am always ill. I always feel that I'm down. I'm always let down. Look at the programming that we are giving to ourselves every day. Look at the vocabulary that we have created in our family every day. Look at the words. ये तो ऐसा ही है. ये तो बाहर का, ये तो घर का खाएंगे नहीं. I mean, look at, we are doing the work for them, but still instilling negative energy. That means that this is the contradiction. This is why this law does not work, because our brain is a wonderful tathastu machine. Whatever you will say, it will start saying yes, tathastu, and it will start forming new synaptic connections in your brain. Positive or negative, it doesn't matter. Whatever input you are giving, it will start forming that. So that is why it is very important for us to start believing properly, using the right vocabulary. Yes, success is mine. My children are wonderful. They're going to perform very well. My business is always a success. I'm going to do very well. This thing I'm going to get. This deal is mine only. Everything is perfect in my life. And brain will say, tathastu, tathastu. Your brain will start hardwiring. 21 days, a new habit. 3 months, a completely new destiny for you. This is law of attraction. This is magic. I can quote hundreds of examples of my own healing, how I've healed myself by the law of attraction. My brain illness, when I had lesions in my brain, I have those pictures with me. That when medicines were not working, it's my own law of attraction, spiritual principles, the Raj Yoga meditation that really transformed my life in a beautiful way.
This is so brilliant. I mean, the way you've explained it, I mean, at least it has opened up a lot for me. And I'm sure it is the same with people who are watching this. And my last question to you, Dr. Gupta, is how can we provide, we are a country where, we have now become world's destination for quality healthcare in an affordable manner. But this affordable is a word which is subjective. It is affordable for the world, but yet for our Indians, it may not be as affordable as we think. What is it that you think can make healthcare affordable for the Bharat as we know? By creating awareness, managing costs, what is it that we need to do?
My basic principle for this is changing the mindset. It's our mindset that is an obstacle for the healthcare. Today we are living in a world where we form great policies. We are living in a world where we talk great things. We are living in a world where we try to talk and try being ideal in most of these situations. We'll talk about poor people, we'll talk about farmers, we'll talk about everything. But when it comes to doing things, we are completely contradicting our own words. And that is what I initially mentioned, that there's a lack between our acharan, our uchcharan, and our man ke vichar. Om Shabd. Om Shabd is AUNM, actions, utterance, and thoughts of the mind. This is when it is lacking. Our policies will always remain policies. We will be having a most beautiful policy, but they will be rewarded only as a policy. So mindset change is very important. This world, as Gandhi said very beautifully, that has enough for everybody's needs, but not for greeds. Today, unfortunately, all of us, you, me, and everybody in this world have become greedy and more greedy for more and more and more, a never-ending lust. Hospitals were healing centers, and today they have transformed into corporate business hubs. This is great, you can do that. But don't you think that if we design such a policy that out of 80 or 100% work that we are doing, 20 to 25%, if I believe, is for the poor people. For the poor people who cannot afford. Look at this, those who do, for them, if I charge them, forget about lakh rupees, 50,000 or 20,000 rupees. If for them, if I even charge 1,000 rupees, that 1,000 rupees is often a pay for their 10 days. You imagine that they are not able to do. I had a patient who said that, he was ready for a procedure via government setup. And I was surprised when he said that he had to sell off his home to get the treatment for his child. This is strange. This is not what we want in our life. So it's change of mindset that is required. Affordability is first thing. Availability is second thing. And third thing is accessibility. We as policy makers, we as opinion leaders, we have to strike on all these things. We have to subsidize all the things. Remember, there are two ways to earn. Either we keep the price of the things very high, we will treat fewer people with higher margins and we'll be able to earn so much. There's no problem at all. Or we keep less margins. We keep a reasonable profit and we give it to the masses. That's another way. You are treating volume, we are benefiting other people. No doubt that research and development and everything incurs a cost and that should be taken care of very, very well. There is no doubt about that. But we need to have a mindset to help people. We need to have an attitude to help people. The moment we do and work together, let me tell you, the whole country, our Bharat, we'll be able to provide this care to most of the people. We can, if we have enough, we can open small healthcare centers. We can provide government great support in form of medicines, in form of infrastructure. All this only requires mindset. Today, unfortunately, even if we collaborate, even if we give something, that's only with the aim that our name should be there, that fame should be there, my picture should be there. That is not the way. The real dhan is, the real kalyan for our families is that, you are doing the same thing when others are watching you, and you are doing the same thing when nobody is also watching you. That is what is integrity. That is what is integrity. We need to have an integrity and attitude both in our mind and in our personality. Rest all thing is history. We can formulate a beautiful policy, but are we ready for that change mindset? That is important. I can design a 10-page pro forma or a 10-page protocol. It's be beautiful and doable protocol. But will we have the mindset to imply it or put it to practice? And not only this, as public people, we all should be responsible, not about just doctors. As public people also, we are all doctors. We are all doctors. We are all doctors because our attitude, our words are also healing other people. We all should come together and help poor people in the society. There are numerous people who donate money for getting a poor people of their society and they send into a government hospital. There are people like this. This world is not devoid of such beautiful candles. They are lighting a candle in their own life and lives of millions of people. So once we come together, with a beautiful mindset, I think these things can be made accessible, affordable and available to all. Instead of opening just great hospital, we should reach out to the periphery and the poor people so that this healthcare system is available to almost the most poorest of all at a reasonable cost and an affordable cost.
What a beautiful way to explain it. I mean, what I see is that the intent and the action requires that mindset shift, which is what is going to be the underlying success towards affordability, accessibility, and availability. Very beautifully explained. I thank you so much, Dr. Gupta, for taking our time to be with us and explain such a different perspective to cardiac care. And in fact, I would not even restrict it to cardiac care, but a human care or self-care. What a beautiful way to explain. Thank you so much for joining us.
Thank you. Thank you so much. My pleasure and privilege to be here.
From keeping an apt mindset, which plays a big role in keeping us healthy overall, let's move on to a new subspecialty of cardiology, that is preventive cardiology. We have Dr. Sanjay Mittal, Director, Clinical and Preventive Cardiology, Heart Institute, Medanta, the Medicity, Gurugram. We are here to learn about preventive cardiology. Now, as the name suggests, it is the prevention of cardiological diseases, but it is not that simple. To decipher the new subspecialty of cardiology services. So to tell us more on this, I have with me Dr. Sanjay Mittal, who's the Director of Clinical and Preventive Cardiology at Medanta Heart Institute, Gurugram. Welcome, Dr. Mittal. Grateful to have you here today.
Same here. And thanks for inviting me and giving me this opportunity to discuss a few things which are so much pertinent today with the people. Hopefully, this would end up helping a lot of them and reducing the burden of the disease in our country.
So, and I want to start the conversation with just as understanding what is preventive cardiology. I'm sure it's more than just the, the what the name suggests, and what all it entails, and at the end, how does it help a cardiac patient?
That's a good question, Shivam. The biggest thing which we are handling today as cardiologists all across the globe is the menace of heart diseases. It's killing majority of the people day in and day out. If you look at the heart disease killing rate in India, it's been around 30 to 35%, which is a huge number. That means if there is an adult death in India, the commonest cause is cardiovascular diseases. And these cardiovascular diseases, as the name implies, majorly are responsible because of blockages in the arteries of the heart and the brain, leading to damages to those organs and a permanent loss of the function of those organs. Unfortunately, majority of times we realize about the heart disease when the heart disease is troubling you. And I'm talking about the blockages, the anginas and heart attacks majorly. And these diseases are only symptomatic, that means creating problem once they are very advanced. And unfortunately, majority of the people who come to me, they say, hey, one thing, I was okay till yesterday, suddenly how come this thing happened? So important is that these diseases don't develop overnight. They have lots of decades of nutritional deformities, leading to slow deposit of the fats in the arteries of the heart, and one fine day there's a culmination in the form of a heart attack or angina. More than 70% blockage has to be required for that. So preventive cardiology, if I look at the structure of it, is responsible and attempt to reduce this menacing problem from developing in itself. Why? That is the first question. Point number one is, by the time the heart disease is recognized, it's already too late. The heart is either damaged, and mind it, one thing which is very important is once the heart muscle is damaged in heart attack, there is no recovery. Even if you do angioplasties or bypasses, this is not going to come back. Point number two is that these blockages, even after handling with the angioplasties and bypasses, have a huge chance of recurrence within a few years. And then this is a cycle which goes on. So angioplasty and bypass is not a definitive treatment, it's just a temporary arrangement to prevent the heart from damaging and hold it. So the treatment for that essentially is prevention. Prevention of, even after the heart attack, it's prevention of the future heart attacks. Before the heart attacks is basically the prevention of further damage to the heart problems. So there are certain individualized approaches which has to be there, but generalized concepts are that why do the blockages happen in the first place? And this is majorly because of our faulty lifestyle, which is the thing which we can control. And this is a part and parcel of a prevention. Correct your lifestyle. Find excuses to exercise. Control your diet so that the calorie intake in your diet is just enough to compensate for the requirements and not excess enough to be deposited in the form of fat, obesity, diabetes, hypertension, cholesterol, and heart attacks and heart diseases. So that is something which is absolutely there. Culmination of smoking. Tobacco has no role. It has to go. No smoking, no tobacco, please. Even if you are fine today, there's no guarantee you will not be tomorrow. So the fourth thing is learn to relax. In this competitive world, there is a definite chance of relaxation. So these are the components of lifestyle assessments. But last but not the least, every individual is unique. They carry their own genes infrastructure, the genetic infrastructure. And that actually determines how predisposed to development of fat deposits they are. So this science of preventive cardiology is actually huge. It takes huge bit of time and assessment of individual risk factors, which is obviously cannot be generalized. individuals' genetic makeup, habitus, capacities, and then idealizing a kind of a framework in which the person can be put to actually reduce the chances of heart disease. It can include lifestyle measures, it includes drugs and management of those risk factors in very stringent way.
Right, right. If we talk about how the preventive cardiology field has come about in recent years, how do you think the field of preventive cardiology has evolved over the past decade? And what are the trends in the field that we are seeing right now?
Shivam, this is again a very good question. If I give you the data, 2016 analyses, there was a huge bit of surge of cardiovascular disease. Almost 53% increase is in the last decade. And the same program is going to be continued because our lifestyle remains unabated. We do have a genetic predisposition. So in the last 10 years or a decade or so, there has been huge realization of the fact that angioplasties and bypasses and the treatment of acute coronary syndromes does not just mitigate the risk of having it again. And there has been renewed interest both in the public side and the doctor side to actually help the population to reduce this burden. And actually, this leads to young people, elderly people who actually lose their active life because of this disease. So there has been huge advancement in understanding, application. Most of the big centers are actually running programs, actually educational programs, public awareness programs to actually let the people know that they are not just having a disease does not mean that the disease is not developing in them, and they have to work a huge bit on around them to actually get the risk factors assessed, analyzed, and controlled and treated. So this is what is happening. New risk factors are coming up, individual studies are being conducted. Also, there's a concept which has changed now to look at absence of disease to prediction of disease. Very important. This is we call as predictive, not preventive, predictive cardiology, because predictive cardiology is going to be responsible for preventive cardiology. So predictive cardiology is to have individualized risk assessments, which has been, the scores have been developed, Indian scores have been developed, and the other things are, there are new investigations which have come up, CT coronary angiogram, intima medial thicknesses and other vasculopathic assessments which have come up. Genetic markers have been developed, which can also be individualized and available in India very much so, which can help us in actually assessing the individualized risk and prevent the predictive model. And then on the basis of this risk factors, we can act and prevent the future events in that particular individual.
Right. To better understand preventive cardiology, I think we should start. We should understand it by how should a patient understand it. If I were a patient, how would I be treated in say preventive cardiology, and also tell me what are the best current approaches that are being followed in the field, and also can a patient follow these on their own?
Yes, the answer to, there are a few questions together, but let me, to by best understanding, answer those questions one by one. Say, for example, you said you are a patient. The problem is, most of the times, the concept of young population is that the heart disease is a disease of the old age. Unfortunately, it is not. 13% of people, that is the maximum in the world, young people die of heart disease. So that's not so innocuous that we have power to ignoring these facts. Younger people also develop disease. There could be different risk factors. So we actually start by educating the people to understand their vulnerability. And the simplest of the fact of understanding the vulnerability is to go back to their parenthood. If they have parents who have developed heart disease at a younger age, that means less than 50 years of female or 45 years of males, or they have multiple first degree and second degree relatives who have heart disease, these people have a higher risk of developing heart disease in as soon as they go to 45 plus words in males and 50 plus words in females. That is point number one. Point number two is that if they realize that they are vulnerable, they actually have the full right to control their lifestyles much in advance. Because if a person has a concept that, okay, when the things happen, then they would see, this is too late, because by that time the heart may have irreversibly damaged, and they would be getting into the cycle of angioplasty surgeries, redo angioplasty surgeries, redo angioplasty surgeries. So it's better to invest some time, efforts as early as possible. Rather, in my opinion, these good lifestyle practices should be inculcated into the school education program. And every home, because homes are the best teachers for the children, they should actually also be educating the good lifestyle program. At least there's no harm in having a good lifestyle. Indulge into exercise, control your diet in accordance to your exercise activity. If you are an athlete, please have higher calories. But if you're not a desk worker, control your calories, find excuses to exercise, control your tobacco. In young people like you said, the biggest risk factor for heart disease is tobacco. Tobacco products, drugs, and all those things. So those things have to be best avoided. Look at your risk factors, look at your genetic predisposition, and please get yourself evaluated for those three silent killers, the diabetes, hypertension, and high cholesterol, because they don't produce any symptoms in you as early as possible. So as the answer to question number one was that nobody is safe. You have to actually inculcate a good lifestyle, work on it, and as I say, that you have to earn health. You cannot buy it from the market. So that is something which is the big eye-opener and should be inculcated in every young person so that they don't develop the heart disease down the line.
I think that's a very good sentence that you said there, that you have to earn health, you can't buy it. So the second part of my question was that what are the best approaches that we're seeing in the field currently, and can a patient themselves, do preventive cardiology?
Yes. So as I said, one of the components of that answer I had already given, that yes, there are components that you have to control your lifestyle. No doctor needs to advise you that. You have to have an awareness. So if you are aware that you have a high risk, you can inculcate good lifestyle measures. And my mantra for those lifestyle I have already reiterated as 5. The first, the most important is find excuses to exercise. There's no teaching for that. You can start as early as possible. Please find excuses to physical exercise, not mental. Second thing is keep your diet under control. That nutritious diet should be very important rather than tasty diet. So keep away the tasty foods and go for nutritious diet more often. The third thing is no tobacco in any way form, avoid drugs because they are silent killers. Fourth thing is find time for relaxation, exercise, don't compromise on your sleep. And that is the biggest thing which you have to do, find time to relax in your day-to-day life. You can't do away with stress, but you have to learn to fight with it. And last but not the least, if you are a vulnerable category, don't waste time, get your risk factor evaluated, the 3 vices I said. And there are so many programs, in my opinion, all the good cardiac facilities and good hospitals, they are running those tests to predict the cardiovascular risk. The last but the not least, I would like to also suggest to everybody that if you have a good lifestyle from the very beginning, the chances of you developing heart disease are automatically minimized. However, if you are definitely vulnerable because of your young family history, please look at the medical treatments going to the hospitals, getting yourself evaluated, doing your genetic profile, everything is available. In our health center, we are running that predictive cardiology model where we have different evaluation patterns for different set of people so that we cannot tailor make one evaluation for everybody. We have to look at what an individual's requirement is and then do that. Even genetic testing for younger people who have vulnerability is available today in our facility as well. After that, the medical aspect is to have an individualizer. So your answer is generalized treatment strategies. Yes, everybody is responsible for their own health. Nobody else in the world is responsible for my health. I am. So if I can correct my lifestyle, I can mitigate the chances of having heart disease in the future to come.
Right, right. So one thing that I want to ask you is a lot of people conclude that it's about smoking, that, you know, I'm an occasional smoker. I don't smoke daily, or I don't smoke a pack a day or a pack in a week. I just take one cigarette a week, or, you know, whenever I'm out with friends. So are they, I mean, are they at the same risk as the people who are, how do you pacify this myth?
Okay. So thanks, Shivam. This is an important question. And most of the people, especially young people, actually have huge difficulty in quitting smoking. I'll give you a case example after something which I have mentioned to you. First thing is, your answer to your question is, yes, there is data to suggest that even if you smoke a single cigarette a day, your risk is higher than a person who has never smoked. The other side of the story is the higher number of cigarettes you are smoking, the higher risk you have. That is absolutely fine. So it's a dose-dependent risk escalation. The third thing which I want to mention to you is, if you give up smoking completely today, it takes 1 year for the poisonous effect of the tobacco products in your body to actually reduce by 50% over 1 year.
Be it occasional or not.
Even occasional, even a single cigarette. And last but not the least, I would like to also say that chewed tobacco is equally bad. Some people say smoking. So I had a example. I asked a person who came to me, young person, 30 years, having heart attack and massive damage to the heart. I usually ask such kind of people, how much do you smoke? Cigarettes. He said, I don't smoke cigarettes. Then I was so convinced that his lips were all black and all those things. I said, Bidis? Bidis chal jati hai. So any kind of smoke, whether it is cigarette or cigars or hookahs or bidis, they are equally dangerous. So it's basically inhaled smoke. Some people say the filtered smoking is probably safe. But I say no, because once you are smoking and you are not smoking thereafter, there is a smoke which goes out of that chimney, and then you are inhaling that. To the extent, there is a risk very clearly described about second-hand and third-hand smoking. And to your surprise, the second-hand smoking is your wife and your kids who are sitting besides you while you are smoking and they are not, but they are inhaling that unfiltered smoke, which you are not inhaling, but they are. So they are much more vulnerable. So that is called as second-hand smoking. And the third-hand smoking is those pets and those organisms or those even small kids, because when you smoke, it goes into the air and then deposits into the surfaces of the things which are around you. And that is the third-hand smoking. It's also cancerogenic and very dangerous. So this is something which has to be understood, that even a single cigarette or single smoke is devastating. It increases your risk to development of heart disease, even cancers. And the higher number you smoke, the worse you are. And if you give up smoking, you'll have to quit it for at least 1 year to reduce the risk by 50%. So that is not so easy a task. The story I was wishing to tell you is for a gentleman who had 20% heart pumping, just 1/3. breathlessness, angioplasties and bypasses. Despite that, he was having angina. I asked him, why do you smoke? I said, can't give up smoking. And I tried my level best, I can't give up smoking. So what do? Balki, sometimes I have to stand up and smoke. I said, why do you have to stand up and smoke? He said that because if I sit down and smoke, it gives me angina. So these are certain guys who actually have absolute knowledge that they are sitting on a volcano, anytime it can erupt, their heart function is down, and they have angina with smoking, but they are not able to quit smoking because of that dependence. So there are centers available today who can help you to quit smoking. There are mechanisms available to you which can be helped to quit smoking, but the desire and the awareness and an intent should be there. If there is no intent, you can't quit smoking.
Right, thank you. The intent is always, the first initiation that needs to be there. So, talking about the field of preventive cardiology again, do you think there is a need for uniformity of care and a system of training and certification for the experts, providers, because it is in the nascent stage in India currently? So, how do you think the care uniformity of care should be, and should there be a system of training or certification of experts?
Shivam, this is absolutely right. There has to be a proper training and proper justification of what we are advising in what kind of person, because once we are talking about individualized approach, that individualized approach is requiring huge bit of expertise and assessment. The second part is that the data and the knowledge is constantly upgrading and changing. New data is coming, new knowledge, new risk factors, new assessments, new possibilities are definitely coming, and even the medications. So the training and tutoring is important, and certification is important, not only just for licensing them to do that, but also keeping those people up to date of the available data. If you look at the preventive cardiology, in all major cardiovascular societies and conferences, there's a separate session on preventive cardiology because such a more important thing. If I can compare the two things together, if I have an angioplasty done, I can save one individual, attempt to save that. But if I have a correct approach given to my people, the population, I can prevent hundreds, thousands of people from having heart disease and succumbing to it. So what I am saying, it is a cost-effective strategy, which if inculcated early on in life is much more effective. And it's a different science altogether, which is constantly evolving. And your point is absolutely well taken. There has to be a uniformity in the communication. Because if I say something and the next doctor says something else, there is a huge bit of confusion. Majority of the cardiologists today, unfortunately, they are too much centered on angioplasties and recommendations on just medications, but they have less time because of such a burden of patients and all, that we have to actually take time to explain things rightly to the people so that their lives can be protected from the future cardiovascular events. And that uniformity of communication is very essential. And that is why your point is very well taken. There has to be a kind of approach where the science is depicted intelligently to all the service care providers, and there is a mechanism of actually uniformizing the sounds which we create for the population to come.
Right, right. Now, if we, if we see the dynamics of India currently, in the future, we will have an aging population, and currently our life expectancy has also risen. So, do you feel the preventive cardiology or the preventive kind of approaches in other diseases will be the need of the hour going forward?
All the more so. Because you are absolutely right. One is that we are advancing in our life expectancy. And one of the reasons for that is better healthcare systems available. But beyond that, better awareness of avoiding diseases is such more important too. If I keep on developing diseases, there is going to be a limit to the treatment solutions also. So there is no second thought about it that the reason why the age is advancing and we want to advance it further. That means if our life expectancy is 65, 70 years, I want it to be 80. Why 80, 90, 100? So if I have to reach that, we have to inculcate not only the cardiological prevention, but also other disease prevention. Because one last comment which I would like to give you, it's a philosophical comment. If you have a fire anywhere, you can douse the fire, but any fire would leave a mark, a scar, a burnt out area, which you may be lucky to have a small one, but it may be devastating that the whole house is burnt. So these diseases is just like those fires. You wait for the fires, there would always going to be an aftermath of a permanent damage, which may be luckily small, but it may be unluckily huge one. So don't give the fire chance to actually come into your house. So if for that particular sake, you have all preventive measures in your house. You have watch for the gas stove, you have the fire alarms, you have everything, because you don't want the fire. Same thing is for our body. We don't want diseases because those are fires. And this prevention of those fires is what we are indulging into as far as cardiovascular disease.
Now, to understand the hospital side of it, currently are we seeing the adoption of subspecialties like prevention cardiology happening in hospitals? How are hospitals seeing such prevention setups in their settings? And do you think, sorry, I'll just like to add one question. Do you think preventive cardiology should be a unique subspecialty in all hospitals?
I think the awareness is growing, demand is growing, and that is why all the hospitals, they seem to have adopted at least a basic program for cardiovascular disease risk assessment and management. But as you very rightly pointed out, the essence of the fact is that there is a structured program of actually high-end predictive and preventive cardiology is not existent with the majority of the institutes. It's developing phase, but it's not developed as of now. Most of the hospitals are using the preventive cardiology platform to actually identify diseases so that angioplasties and other treatments can be offered to them. In true sense, preventive cardiology is one where you can actually prevent the episodes of heart disease from developing. There are grades of prevention. Preventive cardiology would have the third grade prevention, second grade prevention, first grade prevention, primordial prevention. Primordial prevention is before even the risk factors come, before hypertension come, before diabetes come, before you advance to 30 years of age, at that level. And most of the people actually are catering for tertiary prevention, that after the angioplasty happens, we do the risk factor modifications and all those things, but that's too late. In the curvature, many of the people would be allowed to develop those diseases, which is too bad for our country and the population. So yes, in my hospital, we have a very important structured program, which is dwelling into wellness. I'm not talking about the prevention of cardiology. It gives a wrong impression. We have a wellness program because we want to prevent disease from coming. So this is what we have as a wellness. We have to maintain the wellness, assess the wellness, and maintain the wellness. So many of the hospitals, big hospitals, they have those concepts and coming up with these things. We have a structured program. We are heavily indulged into predictive cardiology because that would help me in actually not only identifying whether you have a problem today, but 10 years down the line. In younger population, we talk about the lifetime risk of them developing heart disease and work around that. So there are a lot of models we are working upon, and we have a very good structured program in our hospital at Medanta.
Right. Dr. Mittal, I'm sure you have given out a lot of suggestions and messages out there in terms of prevention, but just last one message that you want to give out on World Heart Day and specifically on prevention, what would that be?
So to me today, the biggest threat is that heart diseases are the most important killers, the biggest killers for our adult population across the globe. Nearly 1/3 of the population dies because of cardiovascular causes, and 25, that is 1/5 or 1/4 of them die because of heart attacks in our country. These diseases are majorly preventable. One of the concepts which I want to very strongly give, if we wait for the disease to happen, the heart attacks and angina to happen, it's too late, because thereafter, many times, majority of times, it is not completely recoverable, and there is only limitation of the damage we can do rather than the complete reversal of the disease. The disease is in our hands, that means individuals' hands, to be controlled and preventive to be developed. There are simple steps which are cost effective. If inculcated early in life, you can actually delay or even negate the emergence of disease later in your life. This healthy lifestyle program should be inculcated and forced into childhood by parents, by schools and colleges, which have to communicate, first, excuses to exercise. Find excuses to exercise. Don't find excuses to rest. Please find excuses to exercise. Second, diet should be for nutrition, not for taste. Avoid the tasty foods. And second thing I can say is, if you have a tasty food, just use for tasting that rather than eating. The third thing is no tobacco in any way form. Avoid drugs, the performance enhancing drugs. These are big vices, can lead to sudden cardiac deaths, they can lead to heart disease in progress. The fourth thing is, please find time to relax, because you cannot do away with stress. You have to compete in this world. But to deal with that stress, it's always better to prepare your body for that stress by yoga, by meditation, by proper sleep and proper relaxation exercises. And last but not the least is, get yourself evaluated earlier on, specifically if you have high risk family history of developing heart disease. For those three silent killers, the diabetes, hypertension, and cholesterol abnormalities, and certain other things which are available in the market, which can be advised to you by your doctor. Please go and get yourself evaluated in that scenario. So these 5 points, if you inculcate in life, you can delay or defer the disease of heart from life completely. Thank you.
Right. Well, thanks a lot, Dr. Mittal. You clearly highlighted, and the silver lining here for me today remains the way you said that you cannot buy health. The people needs to understand, and the definition has to change. They can't have money in their pockets and believe that they'll be okay one day because they have money. The concept of health or being healthy works in a different way. You have to earn that, as you rightly mentioned. And one of the main components of that is to get screened early. Be aware of what is happening with your body, with all sort of lifestyle changes and eating habits you rightly mentioned. So thanks a lot, Dr. Mittal, for joining us here today. And we are very grateful for your insights that you've provided us. Thanks for coming out here and taking out the time to do this.
Thank you. And I believe that if the message is induced into the life of people, I would be happy if it helps a population and we reduce this burden of disease in our country.
Thank you. Thanks a lot. Alternate medicine in India has always been around, but only a few have the knowledge or the expertise to follow it. Now we have one such personality who has all the knowledge and expertise of homeopathy for heart diseases. We have none other than Dr. Mukesh Batra, founder and chairperson, Dr. Batra's Group.
On this World Heart Day, we must not ignore the role of alternate medicine. To discuss the role of homeopathy and what it does or can do in cardiac cases, we have with us none other than Dr. Mukesh Batra. As many of you know, Dr. Mukesh Batra is the founder chairperson of Dr. Batra's group, the world's first and the largest homeopathy corporate, and now has global presence. He's the first Asian homeopath to be awarded the honorary fellowships from the British and the American professional institutions, and is the only Indian homeopath invited to address the Academic Pediatric Association at its international convention. He's authored a lot of books, and his latest book has been Homeopathy, the Simple Remedies for All Ages. Welcome to BW Healthcare World, Dr. Mukesh Batra. Let's begin with, does homeopathy have any kind of a tonic for heart?
So thank you very much, Harbinder, and thank you for having the heart to include homeopathy in your talk. Okay, that's really very nice to see that, homeopathy is now being part of a heartful conversation between people. And let me start with a very interesting trivia. Did you know, that men were more large-hearted than women? Yeah, I mean, your eyes popped out, but this is literally speaking, not figuratively, of course. For a man's heart is 50 grams more than a woman's. So, on this happy note for us men, let's go ahead with understanding what is it that the heart does. So basically the heart is a muscle. Let's understand that. And it's a muscle that beats, and that's how it pumps blood. So do you know that it contracts 100,000, 1 lakh times every day, and it pumps in about 7,500 liters of blood. So when something goes wrong with it, and when this muscle does not function well, that's when you get heart failure. That's when we get what is known as a coronary, or called congestive heart failure, CHF, or commonly known as a heart attack. So when it doesn't pump enough blood into your heart, that's when you start getting all the problems. Now in homeopathy, there's a generic medicine called Crataegus, mother tincture, which homeopaths call a heart tonic. And 20 drops of that twice a day will actually keep your heart ticking healthier and longer. So that's good news.
That's actually brilliant. I mean, one is, I didn't know this part that, a man's heart is larger than a woman's heart. And what is also, amazing to know is that, there is something that can actually help you keep a healthy heart. So, which is amazing. But does that mean that women may be more prone or less prone to heart conditions than men?
Yes, I would say in some cases, yes, because, they have the hormone, and because of that, they do get more prone to heart problems as well. But the idea was really a trivia that I mentioned, not really from a health point of view, because irrespective of the size of the heart, every heart functions well, and it's meant to function well. It's meant to beat till the end. So as long as it beats, you're alive, and when it stops beating, then that's the end of life. So it's supposed to beat well for everybody. Unfortunately, it doesn't happen, and there are many reasons why it doesn't happen. There are many medical reasons why it doesn't happen, and there are many lifestyle problems because of it doesn't happen. So we can talk about that a little bit. So three of the commonest, there are many problems, and again here I am restricting myself only to problems which we can actually control and treat. I'm not talking about congenital problems. There are lots of congenital heart diseases. We find them, like what we call children are born with a hole in the heart, for example. It's an valvular defect. Then there are septum defects. So the blood flows from one side to the other side. Impure blood mixes with the pure blood. Again, you get blue babies. So there are lots of such conditions which I'm not talking about, because some of them are surgical. They are easily treated through surgery. So we don't touch that as part of our discussion today. What I'm going to talk about really is the problems that are very common and that can be treated. Now, the first one among them is something called CAD. So this is coronary artery disease. Now, what happens here is that you have high cholesterol, or you have high triglyceride, and because of that, you get a plaque in the blood supply. So it's just like a pipe where the water is flowing, and every time when some deposit, say chemicals deposit, on the inside lining of the pipe, then the flow to the pipe stops. This is exactly what happens in the heart as well. So the vessels of the heart, the arteries of the heart, if they start getting cholesterol and fat deposits on the lining, then the flow of the blood becomes less. Now, when this happens or when it occludes, you then get a heart attack, and that is where life ends if it's severe, So the real thing is that can these deposits or can these plaques be either reversed or not happen? So again, here the good news is, yes, with lifestyle changes, you may not get it, and with lifestyle changes, you can help. And again, then there is, homeopathic medicine called cholesterol, which again, if you take in your 6x potency twice a day, 5 pills, it will help you to lower your cholesterol levels and your triglyceride levels over a period of time. Now, when you do that, then automatically the pipes get cleared. So when there's no deposit in your arteries, the chances of getting a heart attack are much less. And this is how homeopathy can help in this problem. So this is one very, very common, and as you're growing older, it's a progressive problem. I'm saying you can't escape it in that sense, but you can delay it. You can help yourself in some way or the other through homeopath. But I mean, it's inevitable. If you were not to die, you would live forever. As they say that, the only terminal disease is life itself, because it has an end date. And, sometimes, going through a heart attack and going away through a heart attack is actually one of the nicest ways to pass away, rather than suffering from all other chronic problems like cancer and kidney failures and all that, which has so much of suffering. So let's come to the happy part, that there are treatments and there are ways in which you can help yourself to reduce this coronary heart disease. And this is one of the commonest causes of heart problems. The second commonest problem of heart problem is something called angina, which actually literally means I cry. So it's like your muscles are crying for blood. So what happens again is that because of the lining, because of the lack of the blood supply going into your heart, all right, you actually are deprived of, just like how you get deprived of oxygen and you can't breathe. So like that, you get deprived of the blood supply to your heart. Part of your heart either dies and becomes ischemic, or it gets blocked out. And because of this, every time you walk and you exert yourself, you start getting pain in your heart, which is a very squeezing kind of pain. And that's why it's called angina, which means I cry. So you actually cry with pain every time you walk. And the more you walk, the more pain you get. It's really on exertion. So this is another disease called angina, which is very, very common. And of course, you can do a cardiogram, and you can do a stress test, and you can find out whether what is really the damage to your heart when this happens. But then there's a homeopathic medicine called cactus. Again, in its 30C potency, 5 pills twice a day, which will help to reduce this. And especially when this angina is associated with palpitations, it will help you as a patient to reduce it. And of course, you have to make sure that the root cause of it gets addressed. So I think this is the second most commonest problem that we get. The third is, again, little peculiar problem, but does happen with a lot of people, not with so many, but it does happen, which is called arrhythmia. So, what keeps the heart going is also the electrical impulses. So every time there are electrical impulses, which keeps the heart beating. Now, something happens when these heartbeats go out of sync. So they either become too slow or they become too fast. Now, this is something, this is why some people have to have a pacemaker in their heart. So they need an external help to pump the heart, because the pumping of the heart becomes irregular. So your heartbeats become irregular. So again, this is a problem. And homeopathy can actually help this by homeopathic medicine called digitalis. So when patients take digitalis and they suffer from palpitations and heartbeats and irregular pulse beats, you can take digitalis and you can be helped with this. Of course, all of this should only be taken under a proper medical supervision and with under proper homeopathic care, not just self-prescribed. I'm just giving you these ideas, solutions, just to open your mind, because people tend to think that, oh, heart problem hai, to homeopathy se to kuch ho nahi sakta. That's not true. So I'm just trying to tell you that so many common disorders of cardiac ailments can actually also be treated through homeopathy. And it has a role in cardiac care. Maybe a limited role, but it has a role. But a very definitive and very useful role.
Right. But sir, for example, when you spoke about arrhythmia, when a person discovers that there is a problem, arrhythmia, and they go to a doctor, can homeopathic medicine delay the process of getting an external device like a pacemaker, or can it actually bring you to a point where you don't need an external device?
Yes, that is possible. And that is why I said that, and just to let you know also that in Europe particularly, homeopaths are super specialists. So for example, you get an MD doctor who's a cardiologist but uses homeopathy. And this is exactly what they do, that, if they can treat without a pacemaker, they will treat. So they'll first try non-invasive therapy. If it doesn't work, then they'll go to something invasive. So there are established protocols here as well. So I'm saying, of course, subject to medical supervision. You don't want your heart to collapse. You don't want to drop dead suddenly.
Right.
Like they say, drop dead, gorgeous is okay, but drop dead, literally is not a good thing to happen. So of course, you have to be very careful with what you do. You have to be under medical supervision, but why not try something which is harmless, has no side effects, and yet effective, before you go to something where you're lifelong tied on to it.
Right.
It again needs supervision. So that's what I'm trying to say, that, why not try a safer system of medicine first, as a first option, not as a last option.
Got it.
And if it works well, good for you. You don't need to do a pacemaker. If it doesn't work, yes, you do go for a pacemaker. I mean, ultimately, you want to live long and you want to live well.
Absolutely. So, Dr. Batra, one more question that comes to my mind is that, people have this fear that if your parents had a heart problem, you may end up having a heart problem, especially if you are diabetic or these kind of conditions are there. So is there some kind of a medicine which can work as a preventive, so that you know that in your 50s, you can start taking this medicine to avoid your arteries getting clogged?
So, I can change my genes, what I'm wearing down, which you can't see, thank God. Okay. But I can't change my genes, which is spelled as GNES. Okay. So genetic is something which is hereditary. Okay. Which is why, in spite of the best efforts, some people still get heart attacks at 40, no matter how hard they try. But having said that, a lot of genetic things doesn't mean there's a propensity to get it, but it doesn't mean that you're going to get it. So if you're able to avoid the factors that can precipitate it, if you can lead a good life, if you can have a healthy lifestyle, the chances are you won't get precipitated and you won't get a heart attack. So genetics plays a very important role. One cannot deny it. Sometimes it also misses generations. So it may not happen with me, it may happen with my children, it may happen with my grandchild. It can miss a generation. So the genes are really, really important as far as diseases are concerned. And there's little that you can do to alter it, but you can prevent it and you can delay it. I mean, that's for sure. And therefore, this is this great word that we learned in COVID time. I think all of us learned it. I mean, doctors, of course, knew it, but I think the layman learned it. And that great word is called comorbidity. I'm saying nobody heard of it earlier, but we all said that, during COVID time, anybody who had a comorbidity was likely to suffer more, die, go to hospital, blah, blah, whatever it was, right? So this is also very important for heart. In heart as well, people who have comorbidities, people who have diabetes, people who have high blood pressure, especially on a long-term basis, and also people who are obese, who are grossly overweight, are more likely to get heart problems. Now, again, this is a lifestyle problem. So this can easily be treated. If you correct your lifestyle, if you keep your weight under control, you're not grossly overweight, and you're able to manage your weight well. If you're able to exercise a little bit every day, so that exercise also gives oxygen and blood supply to the heart. It keeps it pumping. It keeps you in motion, So all of this is important for a good lifestyle and for you to kind of prevent the heart attack from coming. Again, I'm saying that genetics is a very important part, but you can delay it and you can certainly lead a healthy life. So there is a medicine called circular force, for example, which helps to increase blood circulation, the flow of blood. And that's a homeopathic medicine. And that also can be taken to help such people. But whenever you have comorbidity, you've got to first treat the root cause. So the root cause is what? The root cause is either high blood pressure. Like, see, for example, today, if you also see lots of younger people are today getting what is called, CKDs, chronic kidney disorders. Okay, they're getting into kidney failure. Now, why is that happening? It's happening because they're suffering from hypertension and they're not doing anything about it. So if you have long-term high blood pressure, then your kidneys will fail. If you have long-term high blood pressure, your heart will fail. It's bound to happen. So therefore, you're going to treat your high blood pressure. So if you treat your high blood pressure, you treat your diabetes, you keep it under control, and you keep your weight under control, the chances of you getting a heart problem are very low.
So you brought up a very important aspect that is very specific to homeopathy also, that homeopathy believes in finding the root cause and treating that so that you can cure the problem rather than just press it. Am I correct? Right? So, keeping that in mind, I know you mentioned obesity, you mentioned diabetes, and you mentioned hypertension as the three things. To prevent heart condition, if you have these three things, what is it that you recommend as a homeopathic specialist to do to keep these under control?
So I already mentioned that. I said number one is that homeopathically, to increase the blood flow, you take circular pose, which is a homeopathic medicine. You have to make lifestyle changes, which are very, very important, which I've already mentioned earlier. Because if you want to get rid of, and the third thing is that you have to also treat yourself constitutionally. You have to go to a homeopathic doctor who goes to the root of the problem, understands what it is, and then gives you a medicine. So it's not something you can take off the counter. It's not an OTC prescription that you can try. But you have to take something which is really, which will help you to alter your constitution. We'll talk about this a little later. But the other important part is that, also you have to lead a stress-free life. Because, according to the American Heart Association, stress is very, very important, and it's very, very, it precipitates heart problems. Enough research has been done to link cortisol, the release of it, a body enzyme, with heart problems, which comes with stress. So when you increase stress, an increase of stress can actually give you an increase of cortisol, and it can actually give you a heart attack. So staying calm mind, having a calm mind, staying cool, it's just the reaction that you have, not reacting to an external circumstance. The external circumstance is not going to go away, but everybody's reaction is different. Somebody will shout and scream, get red in the face, become livid, and somebody will be very calm and cool. But somebody who's calm and cool may also keep it within the body, and may still react badly. So how to kind of deal with adverse things? So stress is very, very important, and and again, homeopathy is very important in treating this, because homeopathy is mind-body medicine. It's holistic medicine. It's looking at also the psychosomatic problems and taking that into account while prescribing homeopathic medicine. So therefore, it becomes even more useful in cardiac care, because if a lot of cardiac care is because of stress and psychosomatic problem, then homeopathy helps you because it's holistic medicine. It helps you to take care of your mind as well as your body. And just to add to this, as you know that, so there are medicines like Kalipa 6X, for example, which is a biochemic medicine. You take 3 tablets twice a day. It will help to keep you calm. And it's not a sedative. It's not addictive. Okay. And you will have no side effects or drowsiness. And you can still take it throughout the day. So people who are kind of hyper can actually take this to kind of calm them down. That's a very quick tip I'm giving you, totally free of charge on your channel, especially for you, right? And very easy to help people. Very, very easy to get from any pharmacy. What is interesting also is that homeopathy actually, the medical world recognizes personalities which are more prone to heart attacks. Now, these are called type A personalities. So type A person, those, are high strung, these are like top level CEOs. I mean, some of them, and, they're always thinking all the time. But homeopathy goes one step further. What homeopathy does is it recognizes personalities. And there are many such personalities which are type A type personalities. So one of them, for example, as an example, is Nux vomica. Nux vomica is a medicine which is prepared especially for people who are hyperactive, people who are top of the corporate ladder, people who don't sleep on time, people who have excesses. They're smoking too much, they're drinking too much, they have late nights, totally irregular lifestyle, they are irritable, snappish. They're also snappish because they are clever. Because Mr. Narayana will say, come on, get on with it. I know what you're going to talk. Because I'm smart enough to know why you're wasting my time. So they're also snappish, So this is a type of personality. Now, these kind of people are more prone to get heart attacks and to fall sick as far as heart problems are concerned. So homeopathic medicine, I've given just an example, like Nux Vomica, can help you to alter your constitution, can help you to change your mental frame, and can actually help you to settle down well. So you don't react very, very badly to the same circumstance which is there for everybody else. Right. And therefore, by altering your circumstance, by altering not your circumstance, but your reaction to the circumstance, you can actually live a healthier and fuller life.
No, this is actually the problem that we are facing in this fast-paced world today. That everybody is, without realizing that they are under stress, they are living a stressful life. But you spoke about people who are hyper, and you spoke about this medicine that can be taken. Now, what about kids? Because what we are seeing is that a lot of children, earlier on, heart condition was always associated with people who are 40 and above, 45 and above. Today, we've seen young people facing, cardiac conditions. And also, the children who are being termed as hyper. The ADHD is on a rise. So can children who are hyper be also given these medicines?
So I think that's a discussion for another day, because ADHD is a huge problem today. I totally agree with you. And, kids today are hyperactive, but that's a separate discussion altogether. It has nothing to do with heart problem. But when you talk about kids having heart problem, most of them are congenital problems. They are born with a defect. And sometimes the defect is seen at birth, and sometimes the defect is even felt a few years later on, when they really start moving around, and, that's after 5 years, 6 years, you come to know. So there's a specialty now today in surgery, which is called pediatric heart surgery. So there are many pediatric heart surgeons who actually do this surgery very successful, and they're able to actually give a great quality of life to such children.
How do we know that the particular condition can be treated by homeopathy, or the person needs to go in for some other alternate form of medicine or surgery? So how does one define that?
Very difficult, because as a practitioner of my system of medicine, I would believe that I could do anything. But I think the answer really comes from visiting an honest homeopath. When you have an honest doctor who knows his limitations, I always say this, that, a disease is too complex, and no one system of medicine is complete and can really help. And jokingly, I always say that, whatever good for the customer and the consumer is what you should be doing, or for the patient. So whether it is allopathy or homeopathy or Tirupati, whatever works well for you. And that is what you should be really, taking. But, it needs an honest person to tell you that. Somebody who has no commercial interest in your case, somebody who's actually looking at patient benefit rather than personal benefit. And there'll always be a line. I'm saying one of the things that, we have been running for last, I think some 12 or 15 years, been running clinics all over the world. And one of the factors that we have is that doctors have to prepare for an exam there. I think among all the other medical questions that they asked, the one question that they always asked, and some of them fail actually, and now we train them not to fail and to succeed, is where will you draw the line? Tell us what are the diseases that you will not treat? Because as a homeopath, you should not, start claiming that I can treat everything under the sun. And in that, then the patient suffers. So there's a limitation to every system of medicine, and there's a benefit. Pick up the benefit, and from any system of medicine, where you get the benefit. Like I'm saying, surgery, I spoke about pediatric surgeries. I've supported, when I was the president of the Rotary Club of Bombay, I conducted 100 free surgeries, pediatric surgeries for 100 kids, and gave them new life. And even today, I fund pediatric surgeries. As a homeopath, I'm funding pediatric surgeries.
Right.
Because it works and it gives people life. So, whatever helps people is what we should be looking at.
Yeah, absolutely. Doing the right thing is the most important aspect. Dr. Bhatta, one more question is that a lot of people, when they face a heart problem, it is usually an emergency situation and they go to a hospital. Now, can homeopathy handle emergencies related to cardiac?
So that's a very difficult question, and I have to be very honest. And, I would say no. And when I'm saying no, I would say that it's not clinically proved. And I would say there's not enough evidence to prove it. And I always say this, that, whatever is an established system of medicine where it is working, you should follow that. So if you're having a heart problem, what are you going to do? You're going to get into an ambulance and you're going to rush to hospital. And you know that the first 1 hour of any kind of such episode is most critical. You don't want to waste time. You don't want to waste your life. So I would always say that you can use homeopathy preventively for pre, post, but during an emergency, you're still, you're still restricted to going to an allopathic hospital. I mean, there's nothing you can do. Once the institution takes over, then you become an institutional patient. You have no rights. All the rights are with the doctor. They treat whatever they want to treat. Sometimes you don't even know what medicines you're taking.
Got it.
So I'm saying, I mean, I would not risk a patient's life. I would always say that wherever any system of medicine that works for you and which is clinically proven with its benefits, please try that out and follow that. But there are many things which are, which are not helpful. Like I said, and there are many alternative methods of treatment which people don't know, even doctors don't know. So if we can make them available to people and reach out to them and make them understand that it's not always that you have to go for a heart surgery. There are some reasons where you may not need to go. Like we spoke about the pacemaker. Yes, pacemaker is very good. It adds value to life. Nothing wrong in it. It's good. But can it be avoided? In some cases, yes. So why not try? Can you have less of cholesterol in your arteries through homeopathic medicine rather than allopathic medicine? Possible. Why not try it? So that's really what I'm saying. But if there's an emergency, and I won't risk a life, and I would only go with whatever is the accepted method of treatment where you can get the best treatment to save a life.
Got it. So a lot of people who go through surgeries.
Jahan hai to jahan hai.
बिल्कुल सर, बिल्कुल absolutely. Sir, लोग जब surgery के लिए जाते हैं, when they get a bypass surgery, now they come back with a feeling of a revived body, revived heart, and everything is now clear. And they are told that now you're starting a life afresh. But what are the things that they need to take care of? Of course, lifestyle changes is a part of it, but is there something that homeopathy can help in as a post-operative treatment or an option so that the same problem does not repeat itself?
So there are two parts to this question. One part is immediately after surgery. When I'm saying immediately means the time you come home, when you're recuperating, not when you're in hospital. And today they send you back very, very quickly. They want to clear the beds and they want to rotate them quickly. They don't want you to lie over there. Okay. So, and today it's all about mobilization. They actually make you walk and go back home as early as possible, and chances of cross-infection are much less as compared to what it used to be earlier. So the first thing is that there's a very simple homeopathic medicine called arnica. Okay, it's been used by lots of surgeons as well. In Bombay, I know so many surgeons who use it. So post-operatively, that's a medicine that will help you to heal faster. So that's something that everybody should use irrespective of whatever you're doing. So arnica for healing is an immediate thing that you can do. The second is a long-term thing. Now the long-term thing is that you've had your surgery done, but you can always get plaque again. Now it won't happen within 1 year or 2 years. It may happen after 10 years. It may happen after 15 years. But if you take a proper constitutional homeopathic medicine and make lifestyle changes, it can happen after 25 years. It may happen after 30 years. So you can actually delay that process. But again, there's no specific medicine. You have to consult a homeopath and you have to take a constitutional medicine. So that the same thing doesn't happen again, because you have to see everybody doesn't get plaque. Obviously, there's some hereditary factor. There's a tendency to get it. There's a lifestyle problem that is making you have it. So if you change your lifestyle and if you reduce the tendency, then the chances of you getting it back again are minimized.
So thank you so much for joining us. It is such a useful information that you have provided to our viewers today on this special day. So I think people are going to be very, very informed about what homeopathy can do and what it is not probably geared up to do as yet. And I really thank you from the bottom of my heart to take so much time out from your busy schedule to be with us today, sir.
Thank you very much. Always lovely to meet you and to chat with you. And God bless. And let's all of us hope that we all have a heart full of happiness.
Absolutely, sir. Thank you so much, sir. Thank you.
Namaskar.
Moving on to a conversation on diabetes and the heart. And to tell us its correlation and how one affects the other, we have Dr. Ambrish Mittal, Head of Endocrinology and Diabetes, Max Healthcare, Pan Max, Saket, New Delhi.
Welcome to BW Healthcare World.
On the occasion of World Heart Day, we have with us Padma Bhushan Dr. Ambrish Mittal. He is the chairman and head of endocrinology and diabetes at Max Hospital, Pan Max. He was awarded the Padma Bhushan by the Government of India in 2015 for his contribution in the field of medicine. In 2019, Dr. Mittal was nominated at the Governing Council of the National Health Authority, and he is now also the president of the All India Institute of Medical Sciences, Gorakhpur. Dr. Mittal has always been very keenly involved in spreading awareness about diabetes among the general public. Welcome to BW Healthcare World, Dr. Mittal.
Thank you for inviting me.
It's a pleasure, sir. Dr. Mittal, let me begin by asking you that diabetes is something that has been the root cause of major diseases across the globe. What are some of the key effects of diabetes on heart?
So, of course, it's the World Heart Day, so we're going to be talking about the heart. But diabetes and heart have a very strong link with each other. It's almost like if someone has diabetes, it's like having a history of a heart attack already. So the risk of heart disease in people with diabetes is significantly higher than in the general population. For example, some studies have shown the risk may be up to 4-fold high, but it is definitely at least double. So if you have diabetes versus if you don't have diabetes, if you have diabetes, your chances of getting into a heart problem are 2 to 4-fold higher. And if you have diabetes, you should be treated as someone who has already had some cardiac event, so that your risk mitigation and risk factor management should be much more targeted and focused. So there are two linkages in this. Now this is something that we've known for some time, what I'm telling you. Yes. But the other link is also now, over the last few years, there's a link between diabetes and heart failure. See, there are two components in the heart, putting it very oversimply, okay. One is that the arteries get blocked, and we said the heart attack risk and everything. The other is the heart muscles don't pump well enough. So over the last 5-7 years, there has been a huge focus on the impact of diabetes on pumping of the heart. And now we know that even in that, the risk of heart failure, as we call it, heart failure doesn't mean heart has stopped. Heart failure means that the pumping is less. So the weakness of heart muscle is again 2 to 4 times commoner in people with diabetes than those without. So there is a double hit. There is a hit, I mean, there is some interconnection between the two also, but there is a direct impact on cardiac muscle also. So, you know, it's important for us to understand that if you look at people with diabetes, just overall, you will find that 10 to 20% of people with type 2 diabetes, the usual variety of diabetes, 10 to 20%, particularly if they are older, particularly if they have had diabetes for some time, may have elements of pump failure, that is mild or moderate heart failure. And so it's not just heart attacks, it's also heart failure.
So one is that people who have diabetes are more at the risk of getting a cardiac problem. But people who have diabetes, does it mean that they will definitely land in a cardiac problem sometime or the other?
No, it doesn't. No, it's not the case. There are many who do not land into that, but the risk is clearly higher. And since heart disease is the major killer in non-communicable disorders, I mean, you have to have your antennae always up. About 2/3 to 3/4, okay, simpler, 60 to 70% of people with diabetes ultimately succumb to heart disease. So, but it's not true that everyone does. Now, one important point here that we need to remember, it is not just blood glucose. When we talk of diabetes and the heart, it is not simply blood glucose, going there and attaching to the heart. That also happens, but that's not the only path. The path is also because of the partners in crime with diabetes. But there is a cholesterol problem that often happens. There is a blood pressure problem that often happens. Often these patients are obese. All this adds up to increase the cardiac risk. It is not just the blood glucose. And therefore, when we talk of mitigating the risk factors or managing them, You have to manage blood sugar, you have to manage blood pressure, you have to manage the cholesterol, you have to manage general lifestyle measures, adequate exercise and sleep. So just if sometimes, people may feel that if you're a diabetic, your sugar's well controlled, then there is no cardiac risk. That's not true. You have to have the ABC. A1C, that is sugar control, B, that is blood pressure, and C, that is cholesterol. All three in tight control, then your heart will be protected.
Right. So when we look at the causes for cardiac problems, we understand that it's a lifestyle issue and people are not probably going for exercise, they're not eating properly. But today we are finding a lot of people ending up with diabetes and cardiac problems despite being very, very active and not drinking, not smoking. What does stress contribute to this, and does also stress increase your sugar levels?
Yes, so I left out stress from the classic risk factors, but more and more studies have shown that stress plays an important role in heart disease. Definitely it plays a role in uncontrolled diabetes also, and there are two ways that stress does that. For the heart disease there are various mechanisms, but for blood glucose, what happens is, number one, directly if you're stressed, you release certain hormones in the body that cause the blood sugar to rise. So there is a connection there. But also people who are stressed or anxious or depressed, it is very difficult for them to maintain an optimum lifestyle. They tend to either overdo or not do things. That balance is sometimes missing. So when they binge, and they really binge, and when they don't want to eat, they don't eat at all. So that systematic routine balance along with mental peace, that has to be maintained to preserve our hearts. Obviously it's a utopian dream. All of us in modern lifestyles in cities will find that hard, but that should be our goal.
So now when we look at cardiac patients, a lot of cardiac patients who land up in the hospital land up having stents.
Yes.
Now, does diabetes have an impact on the lifespan of the stent or the pacemakers placed in the heart or implanted in the body?
So there have been studies, several studies looking at restenosis, and my cardiology friends will explain more to you about that. But when we talk of people who are prone to restenosis means blockage of the stent or narrowing again, then definitely people with diabetes have a greater risk. There is no doubt that because of their underlying abnormality of various metabolic processes, people with diabetes have much greater stent reocclusion rates or restenosis rates than someone who doesn't have diabetes. Even in a large study done in India, the Tuxedo study, even there people with diabetes had a significantly greater percentage of restenosis as compared to people without diabetes, sometimes 3 to 4 fold higher. Okay. So again, what can we do? It's very well to say, oh my God, I've got diabetes, I'll get a stent, now it'll get blocked. Right. That is not necessarily true. In this situation, management of the same risk factors, in particular data on glucose control when the procedure is being done and after that, has a huge impact on the chances of the blood getting into the wrong place again. And I think because blood clotting is affected by diabetes, high blood glucose enhances blood clotting. So if we can control that, so okay, someone has not been careful and he's landed up with a coronary event, he's had a stent placed, no problem. Our cardiologist now makes sure that if you reach the hospital in time, you'll pull through and you can do well. I mean, I have patients who had stents or surgeries done like decades ago and they are good. Right. They have good lives. They are in the 80s and so that is all very possible. So how do we make optimum utilization of the stent, like we maximum benefit from the stent? So in that, glucose control is really important. So even if you messed up earlier for some reason, you didn't know, you didn't realize, or you're just careless, once you're having the procedure, just before, at, around, after, and subsequently, if you have good control, then you reduce your risk of getting into trouble again very substantially. So that's a very important message for people, that even if you've been through this, keep your sugars in good shape. You will probably end up with very little risk of restenosis.
Absolutely. I think, the clots haven't appeared in one day.
Yes,
it has taken
absolutely.
So now you get a new lease of
Yes.
life. So you get to start
Absolutely.
afresh. So it's a new chance that you have. Now, what are the early signs that you feel usually get ignored? Now, everyone should be mindful to detect diabetes, but people don't even know when they are pre-diabetic, or unless they start finding some visible symptoms.
So symptoms of diabetes is a big question mark. Yeah. Okay, classic symptoms of diabetes you would all know: increased thirst, increased appetite, increased urination. That happens when there's sudden and severe diabetes, onset. Then you get that kind of symptom. That happens typically in type 1 diabetes, which is the childhood diabetes, and insulin deficient diabetes. We are not talking about that today. But when we talk of typical type 2 diabetes, most people present with very vague symptoms. They present with very vague symptoms and, maybe nothing. At least half of them have no symptoms. So, if you were to do a community survey, half the people you would find as diabetes would have no symptoms at all. Otherwise, you may be getting symptoms of fatigue, blurring of vision. Fatigue is quite important. Sometimes, calf pain, general aches and pains. Sometimes tingling, numbness may be the first symptom. So those are the kind of symptoms people come with, very non-specific. And therefore, when sometimes people talk about chronic care and diabetes, they say, "Doctor, you're only looking at my numbers." So while doctors should never only look at the numbers, treating diabetes and preventing complications is about numbers.
Right.
So when you're feeling fine and your sugar is 300 and people say, "Oh God, what is this? I'm like top of the world." And this guy is saying that my HbA1c is 10. So you please continue to be on top of the world, but make sure that you're taking the right steps to control that, so that you can protect yourself and keep yourself like that.
Absolutely.
The symptoms, once they appear because of complications, there's so many people who are diagnosed when they get a heart attack first time, or when they get an eye problem. Right. So that means you already crossed a particular line which you should not have ever reached.
Got it.
So that's how it is.
Dr. Mithal, when we look at more number of younger people being diagnosed with diabetes, lifestyle issues, and even eventually we have younger people, having cardiac problems. Does that mean that there's a difference between being visibly fit versus being medically fit? And do you feel that we should have now prevention to a level where younger people start going in for preventive care and screening, which was otherwise always recommended for 40 plus or 50 plus?
So given the fact that there has been an exponential change in non-communicable disease in India, and again, I'll talk about diabetes as an example. Two things have happened. Number one, there is exponential growth in diabetes numbers. From when I started my career to now, it's like a tenfold increase. Right. It's huge, Yeah. So number one. Number two, the increase is very dramatic, and therefore urban areas, for example in Delhi, you may find that the age of 60, which is my age group, you would find that 35-40% people have diabetes. Look at those numbers, okay? And now it's rising in urban areas also at an alarming rate, although there's a gap between the rural and urban. But as economic development happens, you can chart the growth of diabetes. If you look at Indian data, within states where economic development is a little lagging behind, diabetes is still lower. And the moment there is more sort of urbanization, people move to the cities and, lifestyle changes, access to all kinds of food is easier, supplies are better, you find diabetes also. That is tragic. Now that is a global phenomenon, but we have to learn from that.
Right.
It's happening in Latin America, same thing.
Correct.
Crazy. Correct. The way numbers have gone up, obesity and diabetes there. So we don't have to repeat the same mistakes. I really think that it's very important that our youngsters are aware about the need for having a regulated lifestyle, which is very boring, need not be boring, but is perceived as boring, because any discipline is perceived as boring. So the same things, it's nothing big. Same grandmother's advice, get up early, make sure you have your meals on time, make sure you do your 30 to 40 minutes walk or exercise or go with your friends, play, whatever. Those things are important, and don't become fat.
That's
that
a
is
very important
childhood
message.
obesity is very important. Children who are overweight or obese become overweight or obese adults. And those are the ones who get into diabetes, blood pressure, heart disease. So I think obesity is the mother of all non-communicable diseases. If we can tackle weight, if we can tackle obesity, then we can take care of a lot of this. So the risk is the same. I mean, the same factors that promote obesity will also promote the development of all these. So I think when we talk of screening, you asked me about screening. So the age to start screening in India is like hotly debated, because people say it should be really low. But definitely it can't be higher than 30.
Right.
Because we are seeing so many young diabetics at 20 now that a lot of us feel it should be lower than 30 also, maybe 25 or even 20. But the fact is that youngsters who are 20, 25, no symptoms, maybe minor symptoms, just had a cut or a boil and went for a check, doctor said, do your blood sugar, boom, 350 milligrams, So definitely at 30. Earlier perhaps in those who are obese and those who have family history. Those who should screen even earlier than 3. Once a year is good, but I think that's important.
So you mentioned boils. So is boils one of the symptoms of diabetes?
So a tendency to get more boils and non-healing infections, prolonged infections, even a sty in the eye may not heal, even a small cut and minor infections that anyone can get boils, or people call it baltod and those kind of folliculitis, but it's not going away, it's happening again and again. Please look for the
diabetes.
Yes.
Now you mentioned obesity, and obesity is on a rise. Diabetes on a rise. I mean, we are considered as a diabetic capital of the world. Are we on our way to becoming a stroke capital of the world?
So it's very good that you asked that question, actually, because stroke has got little less attention in the public imagination as compared to, say, heart attack.
Correct.
But actually strokes are definitely high in India. There is data comparing Indian and US stroke rates, and our stroke rates are higher and they occur in younger patients. And the same risk factors almost that are responsible for stroke, for heart attacks are responsible for stroke. But in stroke, the dominant risk factor is hypertension, high blood pressure. So high, like diabetes without high blood pressure for stroke. So we treat high blood pressure. A lot of the treatment is directed towards reducing the risk of stroke. So Indians do have a higher stroke prevalence. They also have strokes at younger ages, which can be really devastating. Because in fact, if you have a heart attack, you're either this way or that way.
Correct.
But in stroke, you can really get knocked out for the rest of your life,
Right.
starting at a very young age.
So do you think we are working on controlling diabetes, or are we working on the root cause of the problem? Have you been able to identify that, what has contributed to making you diabetic in your body?
Well, lifestyle is a very vague word, but I pointed out some features that have definitely contributed. The risk for diabetes actually starts increasing when you're in your mother's womb.
Okay.
And there are two interesting points there. Number one, overweight mothers, overfed mothers. In one type of India, there are many Indias within India, right? They give rise to overweight children who are more prone to obesity and diabetes. But malnourished mothers, because the fetus is then programmed to live in malnutrition. When they get exposed, the baby gets exposed at an older age to energy dense food and accessibility to fast food, they put on weight very quickly around the tummy. Why do Indians put on weight around the tummy? Because our bodies are programmed to live in starvation, centuries of deprivation. And now we're getting that energy. So body stores it immediately as fat.
Got it.
Because fat is what makes you survive during those periods. So that, to break that, you have to start nutrition management for the whole population.
Got it.
So the risk starts in pregnancy, childhood, obesity, adolescent. I already said some adolescents are developing type 2 diabetes, and then it goes on. So it's a whole thing. It has to be an upstream approach. I mean, downstream approach is also better management, but upstream approach as a population policy has to be there.
Got it. But this brings me to a very interesting point. I mean, we're talking of genetics today, and everybody is being pushed to go in for genetic testing. If this is genetically been happening over centuries, then is it possible for us to find out the future probability of having diabetes?
So there is an issue about that. As far as type 2 diabetes is concerned, it's a multifactorial disease. You can't identify a gene that puts you at risk, number one. Number two, most data actually indicate that Indians are not genetically predisposed to develop it.
Okay.
It is the same formula that I was telling you, that it's a nutrition down the centuries that has made us more prone.
Right.
Maybe tomorrow we will discover something that will tell us, no, we are genetically. But so far, in the genetic makeup, no single gene or no single defect has been identified which will tell you that yes, you are likely to get diabetes. It is very crude, family history and then lifestyle.
Got it.
And I think we are, at the moment, not just I, but many of my colleagues, we all feel that what we think is that Indians are genetically prone to heart disease and diabetes is a very it's not a very strong scientific statement.
Right.
Indians have greater risk factors. That is a statement. Why do they have greater risk factors? Because of their lifestyle, because of their programming down the centuries.
Got it.
Not really a gene thing.
That's a very interesting aspect. So now, are there any diabetic medications that have a long-term effect on the heart? So one is you're diabetic and you are at the risk of getting a cardiac problem. But are the diabetic medicines also leading you towards heart problem?
I think that's a great question. This whole field is about 10, 12 years old maybe 15 years old. We were always taught, and we always taught, the same thing that I told you: control the risk factors. We told you A, B, C, and you protect your heart.
Right.
Around 2008-9, there was a controversy about a molecule, a group of molecules, that actually turned out to be much more hype than reality. But one molecule that actually increased, which was treating diabetes well, but was increasing the risk of heart attacks. But that molecule was subsequently banned, and others from that group don't have that action. So it was, even that now you look at the data very carefully, it's not very convincing. So there was something that outside of the effect on blood glucose, you may actually be impacting the heart adversely. But that was more or less a red herring. But what they did was, it forced the US FDA to insist that every new drug has to show heart safety. In the bargain, what happened? All new drugs have to undergo cardiac safety trials.
Right.
In the bargain, you discovered two groups of molecules. You just discovered them because you were doing those studies,
Right.
which were cardioprotective.
Got it.
Not just controlling blood glucose, but in addition to that, having additional action on the heart. So that has changed our management of diabetes completely in the last 4 or 5 years.
Right.
So there is a group called SGLT2 inhibitors, gliflozin, whichever drug has gliflozin after that. Those have clearly shown dramatic improvements in heart failure, reduction in risk of heart attacks, all those things.
Right.
And then there's another one called GLP-1RA, which are also doing similar things, not so much heart failure, but in particular for heart attacks. So that is amazing stuff for us.
Right.
So now with the same molecules chosen judiciously and correctly for the patient, you can not just control the blood glucose, but you can actually directly protect the heart also, in addition to whatever else is being done. Right. So that's remarkable.
Got it. And there are also some medications that I've heard have come out where you not only protect yourself against diabetes, or these are the diabetic medicines, but they also help you lose weight and
same group that I'm talking. So this group of drugs has been shown to control blood glucose. That's why they were developed. But they also caused weight loss, which is a great thing. They also protect the heart and the kidney. And in our own studies which are published, liver, even fatty liver. So all these organs, what is the goal of treating diabetes? Why should I treat diabetes? Why should I have an A1C of 7 or whatever we say? Who cares if I'm feeling fine? It is to prevent these complications, right? So to prevent these complications, these new drugs are a very useful addition to our armamentarium. And in fact, I think this is just the beginning. And we will see much more development down this line. They've cracked that code. I will have many, many more newer and better molecules.
There are a lot of controversies around dieting. And there are a lot of conversations that are happening around intermittent fasting. Now, when we typically think about diabetes, the age-old theory is that you should have frequent but smaller meals. And then we have intermittent fasting, and people say that you should let your body. So what is your opinion on this?
Okay. So if we talk of diabetes, the standard guidelines, again, very boring. No one wants to hear them. All my patients say, we all already know all this. What are you telling us? But still they don't follow. So the thing is, we have to reduce refined carbohydrate. That's very important. Reduction in refined carbohydrate is very important. What is refined carbohydrate? Maida. Maida, in a sense, is poison for diabetes. Sorry to use strong words, but yeah, because maida is just sugar, basically. So white breads. Sorry to say this, but naans and kulchas made out of maida are not the best thing that we can have. So refined carbs, processed carbs, out. As much as you can. If you do, use the atta which has multiple grains in it. Use buckwheat atta, jawar, bajra. I mean those millets, not. Or if you use wheat, then wheat with the choker. How rural people used to eat once upon a time. That's how. But we've got used to, because of a palate and So that is one thing. First step is refined carbohydrate is the biggest culprit, single biggest culprit. The other, which again, somehow Indians have become very fussy about these things and being told these things, is there is a lack of protein in our average Indian diets. Even in the more affluent people who can afford, our concept is carbohydrate based. That's how I was brought up. That's how most of us are brought up. Roti, chawal, the idea that proteins are very important. Proteins are very, very important for managing diabetes. So if your diet has more fiber rather than refined carbohydrate, lot of fiber, and if you have adequate protein, then some fat is also okay. So that is the principle of that. Now, small meals, so you can do either, depending on the stage of diabetes, depending on the kind of medication. So if you are on multiple insulin shots, etc., you can't do intermittent fasting. You have to do small, frequent meals, right? If also on some oral medications, particularly the older ones. But if you are on medications, some of the newer ones that don't cause a low blood sugar, so why do we say that you have to take small frequent meals? The concept came largely from, of course, some physiological things, but largely from the fact that you shouldn't get a low blood sugar. If you're on drugs that don't produce a low blood sugar, you can practice intermittent fasting. Now, I'm neither a supporter nor am I against intermittent fasting. The concept is that if you go for 16 hours without eating something, there's a metabolic switch kind of process in the body, you break down your fat, etc. But all the studies have shown that intermittent fasting, when practiced by people with mild diabetes or pre-diabetes or on minimal medication, helps people lose weight, helps control their diabetes, but that is equal to the others who didn't follow intermittent fasting but had the same amount of calories.
Got it.
So for some busy professionals, intermittent fasting is a good way if you're not on particular medication and after checking with your doctor, and not for type 1 diabetics ever, to reduce your calorie intake. For others who can't do that kind of thing, then taking small meals is a better option. So wherever you can reduce your calorie intake without harming yourself, that will work for diabetes.
Got it. Now, when COVID happened, there was a huge, fear that people with comorbidities had, more fatalities. Now, what are the complications due to COVID that you are seeing in the diabetic patients?
Well, in the acute stage, as you yourself said, it was terrible. We did a large study on 400 people with COVID here, and almost half were diabetic. Half. That's huge. And because when you see it, patients requiring hospitalization, the proportion of diabetics dramatically increases. So, and they clearly had poorer outcomes. People with diabetes, no question. Otherwise, post-COVID, what we are seeing is we do seem to be seeing diabetes going out of control for not just the COVID period, but for some longer period. We are seeing higher glucoses, but I am not absolutely 100% convinced how much of this is because of the virus and how much of this is because we gave up physical activity, were cooped up in our houses, eating all day, so all those kind of things could have made a contribution. To be honest, there is really very little solid data to say that COVID increased the risk of diabetes overall. So for example, you need data that in 2019, these were the number of diabetics, and now 2022, they are hugely different. I think that data, a lot of people are working on it, but the data is still not quite there. But there are other long COVID things, fatigue, breathlessness, tiredness, all those things are there. And temporary worsening of diabetes, no question. Long-term increase in diabetes risk is a matter under research.
How many times do you think should a diabetic person get his heart checked?
So that seems like a very straightforward question, but unfortunately doctors don't know a good answer to that. Why? Because the concept that people without symptoms should undergo heart testing is a bit, it's not borne out by longitudinal long-term data. It's not borne out by that. It's not. So it is more like, yes, if you have even the slightest symptom, don't ignore, right? That is number one. Yes. It could be just breathlessness. It could be just fatigue, not chest pain necessarily. Don't ignore these symptoms if you're a diabetic.
Okay.
Fatigue and breathlessness are very important symptoms. Fainting, like chakkar. Those are very important symptoms of heart disease, especially in people with diabetes.
Right.
Classic chest pain may not happen. So those with any symptoms, 100%. Those without symptoms, perhaps once a year. Definitely those who've had diabetes for 5 to 10 years, maybe not in the first few years always. It also depends on other risk factors. If you're a smoker, if you have high blood pressure, you have cholesterol, then maybe earlier. But otherwise, once a year is good. Once a year, get a general health check, which includes cardiac testing. If you're young and there's nothing much, maybe you can do the cardiac testing every alternate year.
Right.
But in a completely asymptomatic, physically active person, all the cardiac testing we do is a bit, we are not sure.
So what would be your message for the youngsters, since we are seeing more heart ailments in younger people now? So what is your message to them?
Well, my message to youngsters of my country is that we should all try and maintain healthy habits. I mean, I think that's very basic. All of us at that stage of our career are driving as hard as we can. We were all like that, okay? But I think getting adequate sleep, if you talk of metros, getting adequate sleep is a huge thing. I know of so many of my young patients who don't sleep well. Why should you not sleep well? So getting a 7-hour sleep is very important. Definitely build in 35-40 minutes, 40-45 minutes actually ideally of physical activity. Now people say, which one should I do? As a prevention mechanism, I say do anything you like. Supposing you are an aerobics kind of guy and I say you should do yoga, and supposing you are the introvert type or someone who wants to do yoga alone, and then you say no, you should go for a for a community aerobics. So it really varies on what people like to do. I believe that if you're not doing exercise that you like, you won't carry on with it.
Right.
But you have to start with something, whichever is the best. But a combination of exercise is very, very good. If people, ideally, I don't do it, but ideally that should be there. We should have some aerobic exercise like a brisk walk or a jog if you're younger, at least 2-3 days a week, yoga thrown in couple of days a week, and even strength training once or twice a week.
Right.
If you make a mix of this, it's fantastic if you can. So some people who are enthusiastic about physical activity and enjoy it just for the sake of it will do it, but many will just do what they like. So at least latch on to one of these and do that regularly.
Got it.
Also remember, you're talking of stress. You're talking of stress management is very important for youngsters.
Yes.
The best antidepressant is exercise.
Got it.
So you will feel the difference. When I feel low, I realize, oh, I missed my walk today. When I go for a walk at 6 a.m. or whatever time, you can choose your own time of 5:30 a.m. sometimes, and in the open air, and with trees and with birds chirping and with flowers sometimes depending on the season, and often with a friend, and the day goes much better for me.
Got it.
Then on a day that I oversleep or whatever, or got up and had work to do so I couldn't go. So it is a very important mood elevator.
Got it.
And therefore we should try and build in physical activity into our program.
No, I think it's a very important message because a lot of people think about exercise as just a physical fitness thing, but like you said, it's a mood elevator. So it will help you overcome your stress and be mentally free as well.
Absolutely.
Before I let you go, sir, I have one last question. It just occurred to my mind. A lot of diabetics have erratic food habits. When I say food habits, the timing. And many a time they have their breakfast and they're supposed to have their medicine and they miss having that medicine. And after about an hour, they realize, oh, my medicine bhul gaya. Is it okay to take that medicine at that time, or what is it that they need to do?
For some medicine, it's okay. It depends. And for some, it's not. There are some of the older medicines in particular which cannot be taken at any time, have to be taken before meals. Insulin, for example, most of the time has to be taken before meals. But I think when we talk of technology, and in a country like India, which is a master in developing apps, and you've seen that during the COVID times, how brilliantly we did on that front. So there is no reason why you cannot take the assistance of various apps to remind you your medication.
Got it.
At least the youngsters we are talking about and the kind of people who live in cities and metros, there is really no excuse. Once in a while it can happen, but it really shouldn't be. There are ways to do that.
Right.
But I think forgetting medicines is normal, it's human, but we should try to circumvent that instead of saying that is normal and human.
Right.
We should find a way to beat that.
Absolutely.
And there are tools that will help you do that.
Absolutely. Dr. Mittal, thank you so much for taking out time for BW Healthcare World. Whatever you have said is not just answering questions, but it is a huge piece of advice for people to start living a healthy lifestyle in the times to come. We wish that we are able to make a difference and build a better, healthier nation. Thank you so much for your time, sir.
Thank you. Thank you very much.
Keeping your heart healthy is not an easy task. What to eat and what not? Is that healthy, or should I avoid that? Are questions we all ask ourselves. Now, to answer them and tell us the right pre-operative and post-operative foods, we have Ms. Shalini Arvind, Chief Dietitian, Fortis Hospitals, Bangaretta Road, Bengaluru. Let's listen into the conversation. Diet is a crucial aspect of a human body. It supplies essential nutrients for the body to function effectively. If done right, it does wonders. If done wrong, believe it or not, it can create chaos, and especially to patients who are dealing with cardiovascular diseases. Having stable and a nutritious diet is all that matters to avoid further complications and a better recovery as well. To tell us more on what to eat to keep our heart healthy, we have with us Ms. Shalini Arvind, Chief Dietitian, Fortis Hospitals, Bangaretta Road, Bengaluru. Thank you for being here, Ms. Shalini.
Thank you so much.
Mishali, first of all, I want to understand the role of bad eating habits. And it is right now, the bad eating habits are, I mean, it's common across ages. So, how big of a role do you think eating habits are playing in increasing the cardiac burden of the country?
Okay. Yeah. So as you said, we all know diet plays a very important role in cardiac health, right? So let's try to understand few factors behind it. So there are modifiable risk factor and few are non-modifiable risk factor. So non-modifiable risk factors are like your genetic predisposition or heredity, ethnicity, gender, age. So there's nothing you can do about it, right? But when you focus on modifiable risk factor, that's something we can have a control on. So diet is one important thing, a balanced diet, exercise, stress management, quitting of alcohol and quitting of smoking. So out of these, diet seems to be the most pivotal and preventive factor in reducing the CVD or cardiovascular death. Because whichever condition you see, any metabolic condition or non-communicable disease, basically all these lifestyle diseases that we are talking about, say diabetes or metabolic diseases, hypertension, obesity, which all are linked with cardiac health, most of this can be controlled by a best diet, right? Diet and exercise all together. So yes, and a very large scientific study has already proven that diet is the pivotal or most preventive factor. And for example, if we say you talk about a diabetic, when you keep his blood sugar levels under control, his sugars will be stable, his condition will be stable, and recovery will be faster. And also the risk of him developing a CVD will be 2 to 4 times lesser than those who have a high blood sugar level. Okay, the same goes with hypertension for a patient having that hypertension or other metabolic diseases and obesity. Actually, demographic data says that heart disease among Indians or South Asians is double as compared to Western world. Whereas on the contrary, we Indians shouldn't have so much of prevalence at all, because we traditionally, if we stick on to our eating habits, is logical and scientific, and everything can be in a proportion, best proportion, which will reduce the risk of CVT. But since we are moving away from our tradition and our best eating habits, we are ending up having a lot of junk, supersized and calorie laden food, and obviously with a lot of trans fats or a lot of saturated fat, everything in excess of calories in a small quantity or small portion with very, very low exercise. And that's all, we are inviting all kinds of problems.
Yeah, right. Uh, Especially youngster these days are having high cholesterol and even diabetes. That is something which is uncommon. And do you think, the like bad eating habits are also at play here in a big way? And
Definitely.
yeah.
Yes, definitely. As you said, it's very surprising to see youngsters, teenagers, even child of 8 or 6 year old developing type 2 diabetes. So we have seen kids with 2 months or 2 years with type 1 diabetes, which is quite natural, which is understandable. But when it comes to type 2 diabetes, it's a basically lifestyle disease, and seeing it a young child is really heartbreaking. There are many such cases which we see, and so when you see youngsters, you actually cannot gauge their age also. So even at the age of 20s, they look like 45 or 50s because of not being able to manage their health. So the factors are plenty. There are too many luring offers, supersized, calorie laden things, buy one get one free offers, and too much of outside eating, not much of control on their eating habits, not much of knowledge. Or actually, we are in an era where we have plenty of knowledge. We have to just put into practice. So yes, with the youngsters, we are seeing a lot of such cases, and it need not be that a obese person only can have hyperlipidemia. Even a lean person, if his habits are not well, he also can end up having a hyperlipidemia, that is high cholesterol, high triglycerides, beyond the range what he should be.
Right, right. Now comes the solution part of it. What, according to you, are the best foods that keep our heart healthy? What should one avoid?
Okay. Okay, so to make it simpler, let's try to understand from nutrient to nutrient. So if you see our plate basically should have food from all the food groups, and the food groups or our plate should give nutrients, all the nutrients in the required quantity. So it has to be have carbohydrates, protein, fats, vitamins, minerals, and fiber also. Though fiber is not called as a nutrient, but it's one of the most important factor in a balanced diet. So if you go nutrient by nutrient, let's first start with carbohydrate. Carbohydrate are very important. Many do get influenced by some fat diets where they say no carbohydrate diet or no carbohydrate after 7 p.m. So please do not get swept away with such wrong information. Carbohydrates are like fuel. It's like the car runs on a fuel, our body runs on carbohydrate, and our brains prefer glucose. So please do not skip and do any fat diets. When you choose carbohydrate, it has to be more of a complex carbohydrate and less of refined. And complex carbohydrate basically is not nothing fancy. You need to just go for least processed carbohydrate rather than taking the ultra processed, ready to eat breakfast items. Try to stick on to your traditional food, and believe me, it's just a little bit of planning. If you plan a bit, you can our own traditional normal food, breakfast items or lunch or dinner, everything can be cooked with little efforts in a minimum time also. What you have to see to that, you try to combine your breakfast a bit also with protein, because we usually do not have a lot of protein with our carbohydrate with our breakfast. So try to give little space for protein also in our breakfast time. And all the meals, breakfast, lunch, and dinner, has to be wholesome. It shouldn't be like it shouldn't be like rivers of sambar or rasam or curry and mountains of rice without any vegetables, or too much of non-veg. It shouldn't be like that. It has to have all the nutrients in required quantities. So one thing was about carbohydrate. Second is about protein, because protein is required for all the regulations, biochemical processes that happens in our body. So choose a healthier variety of protein. So even those who eat non-veg items, they might prefer taking a skinned out chicken, also boiled, steamed rather than being fried, and fish curry rather than a fry. Egg most in the white form, boiled egg whites rather than the yolk, and red meat to be avoided as much as possible, because as such innate red meat has a lot of saturated fat, and the processes which goes in the preparation also can lead to a lot of problems, not only high lipids but also cancer also. Okay, so red meat also has to be avoided as much as possible. And yeah, this was all about proteins, and try to include plant proteins also as much as possible. It's a myth that those who are vegetarians do not get protein. Absolutely not. If they plan properly, they will get good amount of protein as well. Vitamins, minerals, fiber, you don't have to pick any one particular food for that. If you take everything in least processed form, see, obviously you have to have a process. You can't have paddy right from the field. You have to get it into a rice form. But go for a rice which is not totally white. Let it be half brown, less polished brown rice, black rice, or less polished rice. And sprouts, boiled sprouts, vegetables with each meal, salads with each meal, some kind of fruits either in the mid morning or with the breakfast time. So try to include food from all the food groups, and without leaving long gaps. And fiber, most important, helps in keeping blood sugar level under control, helps in keeping the weight under control, and prevents from constipation, and definitely gives you satiety so that you don't overeat. So these are the best foods. If you want to take an example, say anything that you eat in a South Indian, if you say idlis with sambar, or a paratha with some dahi or a veg gravy, or if dhokla would be fine, or bisi bele baat, which is a wholesome food, right? So try to combine little protein also along with your meals. Those who eat eggs can add egg whites with breakfast, otherwise some boiled sprouts. So it's all about proper planning.
Right. I have a popular one for a popular question for you, which is that nowadays a lot of people are debating that a plant-based diet is more nutritious. It gives you less diseases. Uh, when it comes to non-vegetarian food, be it red meat or the other meat, A lot of studies are also telling us that people who have more non-veg diets will in their older age will get some diseases. They're exposed to some particular diseases, and most of them are NCDs. So uh, so how, I mean, what according to you should be, I mean, should there be a little meat, more vegetarian, or should a person go, if a person wants to really be healthy, should adopt a plant-based diet?
Definitely, it's very, very evident plant-based diets are most healthiest one. And if one has the willpower to quit, if you tell a non-vegetarian to quit non-veg, he feels something has been, he's been devoid of something. So if he has the willpower, definitely he should be coming off that. But if they find it very difficult to quit non-veg, probably they can reduce the frequency and prepare it in the most healthiest manner. But definitely plant-based diets have all the required thing. Antioxidants are there, and the way it is cooked also is very healthy, and saturated fats are not there. You don't have any plant based food which has cholesterol. It's only the animal based food. So even milk is an animal based product.
Yeah.
So I'm not talking about veganism, but vegetarianism. Those who are vegetarians, of course, can definitely continue with milk. Yeah, plant based diet, as I told you, get everything that is needed along with the fiber. Do you get any fiber with non-veg? No. So either try to strike a balance and continue with non-veg if you really are inclined. Otherwise, the best is definitely to go for a plant-based diet.
Right, right. And is there a special diet that one has to follow after one's cardiac health is not in order? And how much can that change? How much can that change in the diet help to reverse the ill effects of the patient's cardiac health?
Okay. Here, it's definitely very important that you take care of your diet after the surgery. So if someone is going for just a stunting, it's a small procedure. Uh, but when the responsibility of the patient starts after the surgeon has done his job, so either be a stunting or be a CABG or any heart related surgery or a procedure, see, the doctor has done his job. I always tell to my patients that it's now their responsibility, that they have to take care of their health in such a way that they can keep their sugars under control, and they don't allow a developing of risk factor again even after the surgery. It's because it's not irreversible process. If you go back to the same path, the risk is again the same there, right? So one important thing is pre-surgery, if a person is diabetic, he has to see to that his sugars are under control. I know this is not a part of your question, but I would want to take this opportunity to spread a message to people, because if someone is planning for a surgery, they have to try to keep the sugars under control, because that also determines the outcome of the surgery. So having sugar levels under control is very important, and also blood pressure. And post surgery, as we said, keeping the sugars under control and the lipid profile under control throughout the life is very important. So the same tips which we will tell during the time of admission, at the time of discharge, a qualified dietitian usually will give the counseling to each patient, and they have to stick to it lifelong. So keeping low on sodium, not excess of salt, keeping low on saturated fat, having food in proportion, in controlled portions rather than eating up to the rim should be there, and having a small frequent meals with a lot of emphasis on protein and fiber and moderate energy.
You talked about the post-operative diet there. I want to know what are the foods that you recommend after one has had a treatment of a cardiac arrest, be it an angioplasty or other procedures.
Okay. Yeah. See, there's a lot of myth which persists among people, that those who are undergoing open heart surgery or bypass surgery, which is also called a CABG, uh, from many sources, they get to know that they feel that a person has undergone surgery, he should not be given salt at all. He shouldn't be given a food which has normal spice at all. So he's supposed to eat a bland, salt-free, very, very pathetic food. which discourages the patient. His intake comes down. Okay, so any procedure itself is invasive. Okay, and on top of that, if a food like such is given at home, he will be going low on his nutritional status. So it's a request and appeal to everyone not to spread such word. A patient has to have required amount of sodium, protein, energy, everything. So he shouldn't be devoid of the normal food. So a same food that everybody eats at home, it should be healthy, obviously, has to be offered to the person who has undergone surgery also. What he has to keep in mind is he has to keep his salt intake up to 3 to 4 grams for at least next 2 months. If he is hypertensive, he has to continue lifelong, but at least fluid restriction and salt restriction will follow after 1 to 2 months. Also, sometimes depending upon the conditions, so at the time of discharge, he'll be told. And sugars are to be kept under control, and food shouldn't be so spicy that he ends up coughing. Okay, but otherwise, a normal food which everybody eats at home, of course, made with low fat, has to be offered and has to be soft for a few days till the time he tolerates a normal diet. He can have soft food and then he can switch over to the regular food like chapatis, parathas, and everything. Otherwise, he need to have soft food. He shouldn't eat so less that he ends up constipating. Okay, so small frequent meals with fluid restriction and salt restriction, low fat, and that low fat is for lifelong. And obviously, if he is undergoing some wall replacements, there will be a special diet which will be told to the patient. But otherwise, special unnecessary restriction should not be imposed on the patient, giving him a very bland, tasteless food. It shouldn't be done.
Do you also recommend with the yoga some exercises or yoga after a patient has had an operation of cardiac?
Yeah, usually physiotherapists will be there in the hospital who will advise, and they will mobilize the patient as soon as he's fit for it, and they'll encourage him to be active. So based on the situation of the patient, condition of the patient, he is mobilized, and physiotherapists will be the best people to do that. And definitely he shouldn't stay on the bed for long, and he has to be active enough. And doctor would usually advise how long he should be taking rest and what amount of exercise he can do.
So one thing that I see a lot these days is people popping pills, be it vitamins, be it minerals. And I see a lot of my friends also, when I ask them what is this pill, they're saying this is vitamin, this is mineral. But I am like a little, wary of this, that should I go through this route of eating pills to be nutritious? So what's your point on this?
Definitely, it's not something which is recommended. That's what I said. The knowledge is there, but it's getting used up in a wrong way. See, popping in pills as a daily habit is definitely not something which is recommended. One, the absorption doesn't happen the best way. So absorption of the nutrients happens the best way when it is taken as in the form of food rather than as a pill. But yes, if someone has gone into deficiency of calcium, iron, vitamin B12, or vitamin D, one has to take supplements and get back to the normal levels. But taking it lifelong as a routine is not good, because all that one thing is added as a extra toxin on your liver. So because liver and kidneys are the one which has to flush out. So when you're taking a medicine, it's coming in a capsule, right? So unnecessary, it's a burden on those organs to flush it out. And also there are high chances of you getting into toxemia, because fat soluble vitamins like A, D, E, and K, these, if you are taking over a period of time again and again without any requirement, it's all going to get up built in your body and will go to the toxic level. So at least vitamin C, B are water soluble. It may not be going to the toxic level, but all other fat soluble vitamins can go into toxic level. So it's very dangerous to simply pop in pills without any requirement. And of course, same thing about the minerals also, be it calcium, zinc, whatever, shouldn't be taken like that at all.
Are there any other myths, since I'm hearing a lot, are there any other myths that you normally see around you about diet and or about like medicine?
Yeah, plenty. I mean, when you talk about nutrition, it's only myths. It's only myths. You don't get to hear the correct thing. And if you just have nice channel, someone to sponsor, that's it. Anyone can talk anything. And because there's no professional background who is checking. So actually, one appeal is always go to a qualified dietitian who has studies 5 to 6 years in this field, because dietetics is a paramedical field. You must give respect and go to a professional dietitian, because I have seen many patients who have ended up having a lot of problem after taking a wrong route. Because of course, when you go through social media, there are many myths, many advices, and people want to follow it because for a quick fix. So you would have heard going for some GM diet or soup diet, or a lot of buttermilk diet, or only vegetables diet. So just to reduce the weight, or skip your meals, fast for so many hours, and or do a keto diet. So see, scientific basis are not there, and it has reversed in another way. So but people don't see those after effects. We see the effect because patients will come to us. Those things are not ever posted on the social media, very rarely it comes out. So there have been patients who had done a lot of keto diet, taking 90% of calories coming from fat and only 10% from carbohydrate and protein together. They ended up having fatty liver, hyperlipidemia, lot of acidity, and fatty liver of grade 2 and 3. So this is a myth. One should not go for such diets. And also skipping of meals. When you skip your meals and expect a weight loss, it doesn't happen, and then actually you'll get a lot of acidity, a lot of bloating, and concentration will come down, and body will feel that you're in some famine condition. It tries to restore the fat, so losing fat becomes much more difficult. And once you start eating normally, you'll gain the double of what you have lost. So this is another myth. And also not to eat carbohydrates after 7 p.m. or 6 p.m. because it turns into fat. So again, it's not a science. Basically anything, not only carbohydrate. When you eat anything in excess after any time, when it's not getting used up, it's going to get turned into fat and stored in the body. So it's not that it's only after 7 p.m. Yes, those who have a lot of gastric reflexes issues and all that, they have to eat much earlier to their sleeping time, so at least 3 hours. But for others, at least 2 hours prior to their dinner, it's best to have their dinner, so that they don't leave a lot of gap after their dinner, because they end up feeling hungry. They wake up and have junk and more quantity, which is not going to help. And especially for diabetics, there are chances of them going into hypoglycemia. So such things shouldn't be done. And those who are feeling very hungry, diabetics, just drinking water and going to sleep is very dangerous. They can go into hypoglycemia and nobody will know also. And there are chance of going into very, very low albumin stores with all fat diets, like living on only buttermilk or only vegetable salads or having only salads for dinner. You don't get any protein there. Okay, so myths are plenty. Many,
Right,
many.
right. So a wholesome diet is needed rather than popping pills or having diets which are just either vegetable or either carbohydrates, reduce all the fat, and all those extremism which is going on in
Yes.
terms of diet out there. So I also want to understand like, one message that you want to give out on World Heart Day, specifically on diet and on your background, that you want the people or the our viewers to understand or to take away, one takeaway from today.
Okay. See, I would say always uh, look out for the changes that is happening in your body. It's not that someone becomes fat in a day or in a night. It happens gradually. So uh, things that at least try to implement that. Like we know that excessive calorie laden food are to be reduced. That has to be done. Try to keep a control on your portion size, and to have don't get easily swept away with any fad information which comes across. Try to always stick on to something which is scientific, something which can be relied upon, something that you can follow lifelong and which has some scientific base. So always get information, but try to have that sense of evaluation if it is really healthy, if it is really natural, scientific, and practical to follow, and try to read a bit thing on everything and get an expert opinion rather than trying on something which will end up harming you. Heart condition, heart diet wise, as I told, whatever God has given naturally, have everything in moderation. Don't overdo or don't underdo. And exercise, there's no other replacement. One has to exercise at least half an hour per day for your mental and physical health. So a normal balanced diet with exercise, stress management, definitely it's a key to a good cardiac health.
Right, right. Well, the silver lining here remains for me is that there is a lot of misinformation in terms of what a good diet is out there. So one needs to be informed a lot about what they're eating and what they're listening from influencers, from people on social media who claim to be experts. But as you rightly mentioned, one of whoever the expert is, he should have 5 to 6 years of experience in the field that he is in. So
Yeah, 5 to 6 years of education, at least.
education
in
as
the
well as experience, right? So I think a wholesome diet and an informed attitude towards what we're eating is going to help us a lot to keep our hearts healthy. Thanks a lot, Ms. Shalini, for joining us here today and giving us your views on what a best diet could be.
Thank you.
Thank you. Yoga has stayed with India since centuries, they say. But in today's day and age, it has become a crucial ingredient to healthy mind and body. Well, turns out it is no different for health of our hearts. To tell us more on yoga for a healthier heart, we have Dr. Nikhil Chaudhary, Senior Consultant, Interventional Cardiology, Clinical Lead, Heart Failure, Narayana Health, Multi-Speciality Hospital, Jaipur. Yoga is known as a great stress buster, but beyond that, practicing yoga may also help lower one's blood pressure, cholesterol, blood glucose levels, and also the heart rate, making it a useful lifestyle intervention. To tell us more on this, we have with us Dr. Nikhil Chaudhary, Senior Consultant, Interventional Cardiology, Clinical Head, uh, Heart Failure, Narayana Health, Multi-Speciality Hospital, Jaipur. Thank you for joining us, Dr. Nikhil.
Thanks a lot. Thank you, Alfred, for inviting me. Welcome to all listeners.
Sure. First of all, I would like to understand, why is exercise so badly needed to keep our heart healthy?
So I think we all know that India is suffering from an epidemic of cardiovascular diseases, and heart disease or cardiovascular disease is the #1 killer worldwide. So there are two. It is the most important cause of death, which is because of heart attack, and it is the most important cause of disability, which is because of stroke or paralysis. And all of them basically are lifestyle diseases. And there are certain risk factors associated with them, which are actually a part of how life we lead. And whenever we treat our patient, it is basically a mix of three things. First is diet, second is medicines, and the third and most important, according to me, is exercise. And it not only decreases our risk factors, but also overall long-term our prognosis for diseases, our tendency to develop these diseases, that is decreased.
Right. Yoga specifically is quite helpful in bringing down the aftermath of a heart disease. So are there any asanas that you can tell us specifically which help in preventing heart issues and which help in maintaining a healthy heart?
So you rightly pointed out, yoga is actually in today's world, it is a boon for us, because not only does it make us healthy, but also improves our heart health. It is an age-old tradition, old as long as civilization itself, maybe 5,000 years old, and we are actually lucky to be living in a country where it is a way of life. So yoga, you all know, it means sum or addition of all things. So not only does it include physical health, but as well as mental health, spiritual health. So it is a mixture of all these. And when we speak about our patients of heart disease, we just don't need to look into one particular physical health. We also need to look at stress. We also need to look at spirituality. And yoga is something which brings all these things into common. And so basically what yoga is it's a mixture of kriyas, mudras, asanas, and of course pranayam. So and actually science has taught us that last 100 years there have been innumerable studies which have studied yoga very closely. A lot of evidence-based medicine going into yoga and cardiovascular health. And all of them more or less say that although it may not increase life, but it makes the fight of our cardiovascular disease or heart diseases, it makes it more effective. It increases the treatment efficacy and improves overall well-being. So when I speak about heart diseases, there are two aspects to it. First is prevention and the second is curative. So yoga, of course, someone who is healthy, he can adopt it as a way of life, and practicing daily yoga at least 5 times a week goes a long way in improving our in making our heart healthy. Speaking about asanas, I think the basic concept is that breathing is very important. So not just making a particular posture, you have to focus on the breathing, because that is where the benefit of yoga lies. And so that is why for someone who is beginning yoga, I think he needs to understand this concept and just do some 4 or 5 minutes of deep breathing before he goes for various asanas. So I think just taking deep breaths inside and exhaling, that is important. And the concept of yogic breathing is that the duration of inspiration in which you inhale, that should be half of the duration in which you exhale. So you take a deep breath and you take at least twice the time to exhale that breath. So it should be a slow process. And so there are particular postures which actually help in improving our heart or making the heart healthier. And so basically what I tell my patients is start easy, start with breathing. You can go on to pranayam, which are breathing exercises. And then you can go to postures and start with the posture which is in a standing posture. Tadasana is very helpful. It actually, what you do is you stand on your toes and take your hands over your head, lock them, and then you stretch your body. So it basically improves the body's oxygenation, stretches all the muscles of the body, and increases the oxygen carrying capacity of the heart. So then after Tadasana, one can switch to Tiryak Tadasana, which is sideways bending, Trikonasana, which is further sideways bending to touch the feet. And then going on to various other asanas, like if you've done your standing asanas, you can move to a sitting posture. Start with Vajrasana, focus on your breathing, meditate a little, and then you can basically look at asanas which involve bending forward, touching your toes, bringing your head towards your knees, which is Paschimottanasana. So these are exercises. Ushtrasana is a very good exercise for patients who have undergone a cardiac surgery or an angioplasty. So what in Ushtrasana, what the patient does is he might actually sit on his knees and his toes, and then he flexes back, he bends back, and tries to touch his toes backwards. So that again helps in improving the chest vital capacity, improves cardiovascular health. And then one can move to lying down posture. And there are various exercises, but especially for cardiovascular health, what is said is that you look for exercises which increase flexibility. And among them, I would say Setu Bandhasana is a very good asana for improving heart health. And again, finally, you end with Shavasana. You lie down, breathe, relax, and let each muscle of your body breathe and enjoy that state, that peaceful state. Definitely goes a long way in making us healthy.
Right, right. You also talked about some people who've gone through an angioplasty, and such procedures can also perform those uh, asanas. But what about people who have had such as implant of pacemakers or bypass surgeries? Can they practice yoga?
So it came as a shock to me. One of my patient who is 75 years old came all the way from Bihar to me. I practice in Jaipur. So and he had a pacemaker around 6 years back, and he told that Dr. Saab, मैं शीर्षासन कर लेता हूँ. What Shirshasana is the most difficult exercise among all the yogas, and what basically it means is you stand on your head and the legs are in the air. So you will be surprised how the body adapts. We can do any kind of yoga, and even pacemaker, there is no foundation. Of course, once initially the pacemaker has been implanted, we ask the patient to actually not move his head overhead, move his hand overhead. So not try to increase it above the shoulder height, but that is actually for wound healing, and that is only for the first 2 to 4 weeks. After 4 weeks, any form of exercise can be done. Just do it in a graded manner. And if you are starting out with yoga, I think you always try to do it with a guru who can actually teach you how to breathe properly, how to focus properly, and how to do each mudra properly.
Right, you need an expert before you start performing asanas on yourself when you've had such surgeries, which can, I mean, this without an expert being there can lead to a serious repercussions also if they're not done in the proper way. Right. So they say that the breathing is a sign of life. What are some breathing exercises? I know you've already told, but specifically if you had to highlight, which would those be that you will highlight that these are the most important ones?
So a great question, and which actually summarizes the basic concepts of yoga, I think. So there are actually what I'm a cardiologist, and what I deal with is patients who have undergone procedures or who are suffering from disease where they cannot go for vigorous exercises. So what I do is start educating them about pranayam, and pranayam is basically taking control of your breathing and then taking control of your body. So I would actually say that there might be different kinds of pranayam, and all there are many kinds of yoga actually, but 5 basic kinds of pranayam are actually very good for our heart patient, especially those who are starting out with yoga. And so I'll just enumerate them one by one, and just try to do some justice to how it is to be done. So the first thing is just actually, as I said, just try to breathe in, relax, exhale, and then one can do Bhastrika. So what Bhastrika means is a very deep inspiration followed by a very deep expiration. So Bhastrika Pranayam is the first which I explain. So basically it's like so this is the first concept. Then those who are fitter can go for Kapalbhati Pranayam, and especially those patients who have undergone a surgery, a bypass surgery, a pacemaker, or angioplasty, I would say just wait for 6 weeks before you do a Kapalbhati, because that is the one question which I very frequently encounter ki Doctor Sahab, main Kapalbhati kar sakta hu kya? So Kapalbhati basically means just basically forceful expiration, and not try to inhale too much. So it's we all know, since it is one of the most popular exercises and one of the most popular pranayam. Basically, just try to do it as slowly as possible. Take your time. Those patients who have undergone an angioplasty, start with only 30, 30 breaths, and then gradually you can move up every week to maybe increase to 300 times in a single setting. But that is the second important pranayam. Third would be, I would say, Brahmri. Brahmri is again another pranayam which actually improves our not only our heart but also our brain, improves focus, improves concentration. So basically, what one does is that tries to take a slow and prolonged expiration or exhalation. Just focus and try to concentrate, and it improves our, as I said, mental health as well. The fourth would be, I would say, Ujjayi. Ujjayi pranayam is again very important breathing exercise, also called as ocean breath. And you just try to breathe through a partially closed glottis. So it's like and finally, I'd like to end with Anulom Vilom, and it is one exercise which anyone, even a patient who is posted for surgery or who has just been operated on day one, he can just do it sitting on his bed, focus all his attention on his breathing, and just close one nostril, inhale through one nostril, close it, try to exhale through the other nostril, and inhale through the other nostril, close it, exhale through the other nostril, to the first one. So it's like. So these five pranayam, I think these are the basis of someone who really is serious about practicing yoga and who wants to improve his, make his heart healthy. This World Heart Day, I think I would actually, I'm surprised actually that 15% of the adult population in the United States practices yoga. And maybe this is 2017 data, and post-COVID, I think there have been so many workshops. India, we still are laggards, and I think this World Heart Day we can try for that resolution, adopt yoga as a way of life.
Sure. You highlighted some points there about people have to take care who've just come out of a surgery or something, which asanas they should do or they should not. So specifically, if we have to talk about some asanas and some cardiac rehabilitation as they go through after a bypass surgery, so which are the asanas you tell them to do, and which are the asanas that you tell them that don't do these one?
Okay, great. So actually, I'm from Narayana Hridayalaya, and in Narayana, Bangalore, actually there was this big study conducted post cardiac surgery, post bypass, in which they actually looked at 3,000 patients and finally enrolled 500 of these patients who had undergone a cardiac bypass. And they were divided into two groups. One was given routine care and rehabilitation. That was 250 patients, and 250 of them were given proper teaching in yoga and prescribed yoga along with medicines. And what this study actually found was, this was published in Indian Heart Journal 2014, I believe. And what this study found was that those patients who had undergone a yoga-based rehabilitation, they had better control of not only blood sugars, but also blood cholesterol levels. So the HDL cholesterol, which is the good cholesterol, actually improved. VLDL and the LDL cholesterol decreased. Not just blood aspects, even aspects related to the heart pumping or the ejection fraction. So patients who undergo bypass, some of them have hearts which are weak or with low ejection fraction. And what was seen in this study was that patients who undergone yoga, they had a improved ejection fraction at the end of therapy. So actually it goes a long way in telling us that this is Indian study on cardiac patients undergoing yoga-based rehabilitation that was better than standard of care. So I think this is one thing which actually should make us wonder why we are not doing that. So if I speak about asanas which are really helpful for cardiac surgery patients, some of them we've already discussed. I think that goes without saying, but particular asanas which are quite beneficial are some asanas which improve our chest capacity. So if we speak about asanas which we can do standing, I think Vrikshasana. So from Tadasana, one can move to Vrikshasana, try to stand on one leg, cross the other leg, bring it to the level of the knee, and basically do deep inspiration and expiration. So very simple exercises patient can do standing, doesn't require any materials. So this is an asana which is very, very useful. Secondly, I would go with Veerbhadrasana. So Veerbhadrasana is again a very good exercise which increases the chest vital capacity. So basically turn to one side and bend one knee, stretch the other knee. So I guess it's very easy. Of course, if you join a particular class, it becomes simpler, but even there are a lot of YouTube videos. One can easily watch them and do these exercises. So if I go about exercises which involve sitting, I think there is Shwanasana and Matsasyasana. Gomukhasana is particularly a very important asana. So basically what you do is cross both legs, bring the left leg on the along the right thigh and the right leg along the left thigh. Basically bring one hand up, one hand down, and at the back try to catch hold of your hands, and facing forward try to focus on your breathing. So Gomukhasana is again a very important and useful exercise for patients who have undergone cardiac bypass or angioplasty patient, or those patients who undergone angioplasty. Then I would say Uttan Padasana and Paschimottasana. So these are particularly good exercises which increase the cardiac circulation, increase the flexibility. So I think these are the ones which I routinely tell to my patients. And I think just start slow, I would say.
Ones that you don't
try to master each exercise before you move on to the next step. And I think just go slowly. That is all.
Right, right. Also, I want to understand your perspective on what are the major best asanas for which anybody can do and which everybody should do to keep their heart healthy. Not only just the patients who are going through the rehabilitation process of a cardiac bypass surgery or an angioplasty, but also the general public. Which are the best easy or the best ones that you would prescribe them?
So this is actually something which is very close to my heart, and I think prevention has always been better than cure, and we should all try to increase our healthiness quotient. And so what I say is, if I have to just speak about one single exercise, that would be Surya Namaskar, something which is a complete exercise. So if a lot of times what my young patients, or those who are actually not even patients, young people who I come across, is what they tell me is that they feel a lack of energy when they start the day. So what I believe is that Surya Namaskar is a complete exercise. There are basically 12 postures which have to be done, and the beauty is that if you just doing a single Surya Namaskar will energize you, and that feeling of lethargy or fatigue is going to go away. Just doing a single or just couple of Surya Namaskars. So you do these 12 steps, focus on your breathing. It's a complete exercise which involves stretching of the whole body, bringing the breathing pattern to as close to normal as possible. And I think when we speak about aerobic exercise or exercise which involve strength training or bodybuilding, I think Surya Namaskar is a complete mix. It brings our red, basically there are two kinds of muscles, the red fiber and the white fiber. The red fiber are the ones which work on the aerobic principle, white fibers are on the anaerobic metabolism. So Surya Namaskar involves both of these muscle fibers, and it is the exercise which I think anyone who is healthy can start doing it. Start with a couple, and I think you'll not stop before 10. At least everyone should do at least 10 Surya Namaskars, and of course, depending on how you like it, of course, move. But I think 10 Surya Namaskars a day is a great way to start your day.
Right, and also go slow.
Yeah.
So yeah, the last thing that I want to understand and know from you is your message for World Heart Day. One message that you want to give out to our viewers on whichever topic that you want, be it yoga, be it heart health.
So basically, I think we are into the 75th year of our independence. We are celebrating the Azadi Amrit Mahotsav, and in recent times there has been a lot of stress on yoga as a way of life. And I think if you have not started that, I think this is the best time. One should be proud of our heritage, our country, and this really scientific mode of way of life, and which we have received from our ancestors. What I am seeing is it's a really sad state of affairs where I see 25 years old who are coming with heart attacks. What is really disheartening is I get people who are 60 years of age, they come with their sons, and I asked the 60-year-old to take a seat next to me. He said, "No, Dr. Saab, ye main apne bete ko dikhane laya hu." So this is a really sorry state of affairs, and I think the only way we can battle this burden of cardiovascular disease is try to exercise daily. Anyone according to one's capacity, starting from someone who is 5 years or 4 years of age to someone who is 80 or 90 years of age. Yoga is a great way where you can completely energize your body, improve your physical and mental and spiritual health. And I would say not just I would say try to include your family. It's a great way in which you can help everyone, your family and as well as friends.
Right, you mentioned a great point that we are seeing a trend in the West that people are picking up yoga like anything. It's a trend there. People, even youngsters, people in their old age, picking up yoga. But in India, we're not seeing that kind of an adoption level. And seeing the cardiovascular burden, as you rightly mentioned, is it rising day by day. It is surmounting to a level that if we don't the preventive measures, I mean, we're going to be in a sorry state if we don't realize it sooner enough. So on that note, thanks a lot, Dr. Nikhil, for joining us, and we are very grateful for your views here.
Thank you so much. Thanks a lot.
I believe we have had a highly insightful day, which has made us all think why is heart health critical, and most importantly, how to keep our heart in the right shape. As the CVD burden rises of India, our measures both at individual and at institutional level have to rise to counter the surmounting burden of heart diseases. Now, I would like to take this opportunity to thank all the specialized cardiac doctors and health experts who have made this day special by enlightening us with their knowledge into the field of cardiology or what works for our hearts. I would also like to thank our viewers for joining us for this highly rewarding conclave, which I'm sure has given something for everyone as a takeaway.